किती अगोदर कसं understand? Good morning, everybody. So welcome to day 2 of DRS WCPD conference. So we are starting on time here. So we are leaving the doors open so people can start joining us. So welcome everyone. And so we have the chairpersons for the day for the first session. So these are the keynote speakers for today. So for that, I invite Dr. Nivedita Maulik, Dr. B.M. Makkar, and Dr. Akshay Kothari.
Good morning, everyone. It's always a pleasure to be the opening, chairperson, and we have the opening batsman with us already here. So there is no reason to delay the first session. I would request all the people who are outside the hall and can hear my voice to please move inside as we are starting with the first session. And to start the first session, I would request my co-chair, Dr. Maulik, to introduce the first speaker.
Good morning, everyone. And as Sir said, it's nice to start as an opening batsman. So it's fresh in the morning, and welcome everyone to this hall. I thank the organizers for inviting us to chair a session. And my first speaker for the session would be Dr. Dario Tuchinardi. I was just speaking to him and getting introduced to him. Sir is from Italy, Rome, where he's into an academic institute. He's an MD, PhD, and a well-known Italian endocrinologist. He's working at the Polisseno University campus. His main interest has been in diabetes and obesity, and he's done a lot of research on deep pen, which helps us recognize lipoatrophy and lipodystrophy. He has an extensive academic background and has been into much of research, but his main interest has been on type 2 diabetes with obesity. However, today he's going to talk to us on prevention of type 1 diabetes. Is it really true or is it a myth? So welcome, Dr. Dario, and you may start your session. Thank you.
Thank you very much for the very kind introduction. I'm very happy to be here with you in this incredible country. The topic that I'm going to talk about is a very tough one. We don't have a lot of data out there regarding primary prevention of type 1 diabetes. We all know that we struggle in screening patients before the onset of the disease. So I'm going to talk about regarding some interesting, even though few data regarding this topic. And I'm going over different type of prevention because we would talk about the primary prevention as the title would suggest. But I will also talk about secondary and tertiary prevention of type 1 diabetes, in which we do have more data thanks to the fact that these kind of populations, secondary and tertiary type of population, is already there. For primary prevention, we have to screen them out and is more complicated. So in fact, I'm going to start showing you the different stages of type 1 diabetes. In fact, we do have 4 different stages. Each stage has a specific characteristics regarding symptomatology, so clinical scenario, autoimmune scenario and therapeutic scenario. So we will start from the pre-stage 1. What is pre-stage 1? In pre-stage 1, I don't have any autoantibody against insulin. And I don't have any dysglycemia. I have only a genetic predisposition to develop autoimmunity against pancreas, endocrine pancreas. Then we have stage 1 diabetes, which is defined by the fact that I have at least 2 autoantibodies positivity in the plasma, but I don't have already developed any alteration in the glucose metabolism. Then we have stage 2 diabetes, where I have to have, of course, the at least 2 antibody positivity, but I have started to develop some grade of dysglycemia, which is basically pre-diabetes, impaired fasting glucose, or glucose intolerance. And then we can move to the overt type 1 diabetes, also called as stage 3 diabetes, in which of course I have the positivity to anti-pancreas antibodies, but I do have also the hyperglycemia, which can allow the physician to make the diagnosis of type 1 diabetes as per ADA type of diagnosis. This is a very, very recent publication in Diabetes Care and at the same time in Diabetologia. Had just been published a few days ago, actually, and it's a guideline to guide us physicians in trying to see how to follow up in people with high genetic risk to develop type 1 diabetes, autoimmune diabetes, and also in people that have developed one or more antibodies which are connected with autoimmune diabetes. So in your left-hand side of the slide, you would see some colored arrows, and if you follow the arrows, you will see the stages that we have just talked about. But close to them, you have a yellow and then an orange arrow. In the yellow arrow area, we are pre-symptomatic. We have not developed any symptom. And in the orange area, we have developed symptoms which are characterized of the onset of autoimmune diabetes, of type 1 diabetes. We already have talked about the stages, so I just want to, using this slide, to show you the fact that the glycemic status is diagnosed according to the ADA criteria. So it's gonna be a pre-diabetes if fasting glucose is between 100 and 125, or fasting, or between 140 and 200 after 2 hours after a glucose tolerance test or a glucose tolerance test. But a group of the committee that wrote and published these guidelines also really wanted to make the continuous glucose monitoring part of the story to make diagnosis in this kind of population. Although there was a strong will of doing so with a strong grade of guideline, but still then the whole committee decided to give a grade B, not a grade A, to the continuous glucose monitoring to follow up and make the diagnosis within this particular population. I'm not talking about the general diabetes population. So they put the continuous glucose monitoring into the criteria to diagnosis stage 2 or 3, but still is a grade B type of strength, not A. And then for stage 3, we have the classical ADA criteria to make the diagnosis of type 1 diabetes, glycemic-wise. But we do have also symptoms, of course, because people who has the diagnosis of type 1 diabetic, very often they have polyuria, polydipsia, and they also can have DKA, which actually is why this consensus has been wrote. So the main aim to follow up this kind of high risk stage 1, stage 2 people is to avoid the DKA event, because knowing that they can develop type 1 diabetes, the symptomatic, the stage 3, and acknowledging them, the caregivers, the primary practitioner, that they are in the path to develop this disease, we can really empower them in recognizing the symptoms of DKA. So this was the main aim of this very recent consensus, avoiding in high risk population of developing type 1 diabetes, to give them the empowerment and knowledge to handle and recognize symptoms of autoimmune diabetes. Who should be monitored? As we said, is stage 1, pre-stage 1, stage 1 and stage 2 population, in which we will see in a few minutes, we could think of doing prevention. And so why is that? Because we know if you have at least 2 autoimmune autoantibody against pancreas islet, you will 100% develop type 1 diabetes. So you are in a very high risk situation to develop stage 3 type 1 diabetes. And then it is very important, and you can see in your left hand side the part which has framed in red, and which you can see that this kind of population, of course, clinically wise, we have to follow up them to avoid DKA, but we should really look carefully into this population, because it's the right population to enroll in clinical trials for secondary or primary or primary and secondary prevention. So this is another very important aim, because now we are at the stage of still very, very need of evidences with compounds that can really act and modify the disease progression. So we really do need clinical trials. And in the right-hand side of the slide, you see all the flow chart that would guide the healthcare practitioner in doing the follow-up, how to monitor the antibodies, how to monitor the glucose metabolism. And it's very, very clear. I have to say that this data can be applied to the adult population, but they mainly derive from pediatric status, because we know that pediatric population is the population that is mainly involved into autoimmune diabetes. So, talking about prevention, which is the time frame in which we can really effectively act to prevent type 1 diabetes? So, we would say that is between stage 1, 2, and the very early beginning of stage 3. And we will go across primary, secondary, and tertiary prevention. So this is the window in which we can really act to modify the disease, stage 1, 2. So let's start with primary prevention. So as you can see in the blue arrow, we are talking about the pre-stage, so high risk genetic predisposition to develop autoimmune diabetes. So basically, the strategies are mainly dietary, or vitamin D supplementation, or antigen-specific oral insulin therapy. And the aim is to modulate the early autoimmune response. So these folks, they have not developed already any auto antibody. They are genetically at risk of developing autoimmunity. So which are the data which have been already published on primary prevention? So I found several, but I just choose the most important. And so we have the famous trigger in which they have used the casein hydrolysate formula instead of breastfeeding. They were more than 2,000 infants, high-risk HLA genotypes with a mean age below 1 year. It was a randomized controlled placebo trial, but unfortunately the hazard ratio was not reaching the significant difference in terms of reduction of development of autoantibody in the infants that were receiving the casein hydrolysate formula. Then we had the Findia study from Finland, and they gave the subjects, the infants, bovine insulin-free formula. So it's a bovine milk without insulin protein in the milk. They were at almost 1,000 infants, and was a randomized control trial, and they saw a reduced risk of beta cell autoimmunity, and this data was significant. Then we have the beta baby diet, the light gluten exposure, 150 infants enrolled in this study, and they had HLA high genotype risk of for developing autoimmunity. This is another randomized clinical trial, no significant reduction. And the 3.1 with oral insulin, again, no significant reduction. So unfortunately, apart from the bovine insulin-free formula, we couldn't find any really clinically, but also biochemically in terms of autoantibody development significance apart from the Finnish study. Let's move to the secondary prevention trials. So it's going to be stage 1 and stage 2 type 1 diabetes. So the aim here is to modulate the immune response to antibody positive subjects. So stage 1, stage 2, and we have to prevent the moving forwards the stage 3 when I have the onset of dysglycemia and the diabetes onset. These trials focus on intervention that induce immune tolerance, acting on B cells and T cells, using agents such as nicotinamide, insulin, and more potent autoimmunity. So let's go over the data. If you look at the data published in terms of randomized clinical trial, I've wholly chosen randomized clinical trial for this presentation for this topic. And we have kind of different type of approaches for secondary prevention of type 1 diabetes. And so the first one is with nicotinamide, and unfortunately this type of intervention did not lead to any significant reduction of onset of diabetes. Then we had the injecting insulin in relatives of type 1 diabetes subject. These subjects were at right risk, but they have already developed autoimmunity, and no significant difference was found in developing stage 3, so real type 1 diabetes compared to the placebo. Then we have the oral insulin. Same story, almost 400 relatives, high-risk type 1 diabetes have already developed autoimmunity, as I said. We are in a stage 1, stage 2 type of folks. And still overall no significance in developing stage 3, so type 1 diabetes. Although in those who had a high titer of anti-insulin antibodies, they saw some interesting results. Then we have the teplizumab, which is an anti-CD3 monoclonal treatment, which leads to a reestablishment of immune tolerance. This was the only very strong and significant, not only statistically but also clinically wise, compound that actually delayed the onset of type 1 diabetes. In fact, we do have an FDA-approved anti-CD3, the teplizumab, for delaying the stage 3, which is prescribed in stage 2. And then we have another very interesting compound, immunomodulators, which is a CT, so it works on T cells, CTLA4 analog, prevents antigen-presenting cell, APCs, from delivering the co-stimulatory signal to start the autoimmunity process, right? So this was 212 subjects, stage 1. Ages from 6 to 45 at the time of screening, was a placebo control. And they saw an interesting results in terms of area under the curve of stimulating C-peptide after a mixed meal. But unfortunately, they couldn't see any delay in the progress from stage 1 to stage 2 or to stage 3. So this compound worked in preserving C-peptide, stimulated C-peptide, but not in modifying the natural pathway of developing type 2 and type 3. So let's focus very few minutes on anti-CD3 therapy, because it's very important. Why? Because we do have a medicine, a compound that we actually can prescribe in our patients with stage 2 diabetes, type 1 diabetes. So teplizumab worked by modulating effector T cell activity, and we saw it preserves beta cell function. So a single course of anti-CD3 can significantly slow the decline of C-peptide level, particularly when we act in an early manner. This is very important, to act very early. So it delays the stage 3. In fact, as you can see in this slide, we do see a different type of slope. In blue is the teplizumab proportion-free type 1 diabetes incidence, and in red you can see placebo. So you can clearly see a significant delay in the onset of clinical type 1 diabetes, at least of 4.8 months. This was the difference between placebo and teplizumab. But what is very important is that, as I said, now we have an FDA-approved compound which can be prescribed in subjects with 8 years of age and above in stage 2 type 1 diabetes to delay the onset of type 3 diabetes. And particularly responder were a subgroup of subjects that was the HDL-DR3 negative, the HDL-DR4 positive, so with a different type of genetic predisposition and risk to develop autoimmunity against pancreas islet, and anti-zinc transporter 8 antibody negative. These subjects, these groups, were the ones that responded better to the teplizumab. When we have the abatacept that I just talked before, it acts on the antigen presenting cells, and this compound, as I said, do preserve beta cell secretion after a stimuli, the meal, but could not block the passages through stage 1 to stage 2, stage 1 to stage 3. Which are the main challenges in this kind of prevention trial in autoimmune diabetes. The recruitment, the screening, and the safety considerations is another story if we want to compare it with type 2 diabetes type of prevention, of course. The first point is identifying people at high risk, of course, relatives of type 1 diabetes, but we do know that the most part of people living with type 1 diabetes, actually, they don't have a direct first-grade relative with type 1 diabetes. And then we do have also complexity of early-stage disease markers, the need of safety with this kind of, immunomodulators compound in a very young population to enroll. And large, very expensive screenings are required to have a decent amount of people for power calculation to enroll in these studies. In fact, you don't have huge group enrolled in this kind of trial if you compare type 2 diabetes type of studies. And then we have tertiary prevention. So we already have the diagnosis of type 1 diabetes. We have the type 1 diabetes in terms of ADA criteria. And so 80% of beta cells function is already lost at this point. So which kind of prevention can we do? We have to prevent further decrease of beta cell dysfunction. This is the type of tertiary prevention that we can do in this population, which is the population that we see early, close to the diagnosis, close to the onset of type 1 diabetes is the main population that we see in our services, right? So we have to preserve residual beta cell function in this population, and still the main trials has been focused using compounds which are immunomodulatory, anti-CD3, rituximab, etc. And these are the main RCT that have been published. If you look at the data are interesting, but still not very super convincing compared to the teplizumab in secondary prevention. And so has been studied teplizumab in the tertiary prevention with 500, so more people, because this kind of people is more recognizable compared to the previous stages. Of course, the mean age was 13 years old, randomized placebo-controlled trial. What they showed, the authors showed that with teplizumab, there was a slower decline of C-peptide, so indirectly a significant prevention of beta cell function. Then we have the thymoglobulin, just 60 subjects, already a randomized controlled trial, no differences. Maybe in a post-hoc trial, the author showed that older people had more benefit compared to the younger one. And then we have an anti-CD20, the rituximab, just almost 90 subjects enrolled, aged 8 to 40 years old, randomized controlled placebo trial, and they showed a slightly significant difference by 2 years in preserving C-peptide secretion higher into the rituximab group compared to the placebo. So what is the ongoing in the future in this topic? And I'm going to finish my presentation. So maybe the combined on top of type of treatment would be the most effective, acting either on T cells and B cells. Probably is the best way to act on different signals that leads to autoimmunity, and so eventually protect beta cell function. And there is an ongoing study on teplizumab in younger population. There are some data on probiotics and novel agents like the JAK inhibitors and anti-CD4. And also addressing the heterogeneity of autoimmune diabetes. I'm not saying type 1 diabetes, but autoimmune diabetes, which has a high ranges of phenotypes, right? So there is a high variability in progression, age of onset, response to treatment. So we really need a personalized approach. And also we need to improve the biomarkers that we use to follow up these guys. So to conclude, I would say 10 years ago, we just had a very, very narrow window of intervention at the onset of autoimmune type 1 diabetes to try to preserve beta cell function. But now, and this is the top of the slide, but at the bottom of the slide, you have a wider window of intervention to work not only on tertiary prevention, which is the bottom, the upper part of the slide, but in the bottom part you have pre-stage 1, stage 1, and stage 2 phases, in which we can really try to use disease modifiers, compounds, or intervention. So to conclude, and this is my view, what I would say for the conclusion is that our patients with autoimmune diabetes in the near future, they will be more compliant. We have a lot of continuous glucose monitoring system that really helps them. We will have fewer lower complications because preserving beta cell function, endogenous beta cell function, of course, we really can decrease the onset of diabetes-related complications. And mainly, we have to try to guarantee them a higher quality of life. Thank you for your attention.
Thank you, Dr. Dario, for a very illuminating talk on all the studies in prevention of type 1 diabetes. You've taken us through primary, secondary, and tertiary prevention. We have time for a few questions if anyone is interested. Yes, Dr. Panch.
Dario, fantastic talk. First, I would like to understand that is it possible to use different immunotherapy, or is there any study where they have used, because ATZ is also working, diltiazem is also working, verapamil, not diltiazem, sorry, verapamil is also working, and some of the molecules also had shown some data, may not be very promising. That's number one. My second is it any data is there that it has been reused, because the teplizumab is going to delay the maybe for 1 year, maybe for 2 years, then there is a possibility that patient may get type 1, so is that it can be reused for further delaying? That's the second one.
Very interesting.
And third is in Italy.
3 questions.
Oh yes, the third is very important, because in Italy now universal screening is the only country where I think you allowed your type 1. So how frequently they are screened for all 3 antibodies? So suppose one person is having type 1, so all the family members or first blood relative, they all checked up, and then how frequently they are to be checked up? For all 3, I need the answer.
Thank you for your very interesting question. So for the first question, the future, as I try to say, is exactly the combination of different immunomodulatory type of intervention. Mainly, of course, on beta cells and on lymphocytes and T cells, because working on different pathway can really try to block the autoimmunity compared to using only one target. So multiple target is gonna be the future. I would say that is quite early, as you said, for safety reason mainly. But still, the future is going towards that type of intervention. So joining the synergy of the 2 different pathway in order to really block the autoimmunity. Then the second question was, sorry?
Was the then combination we asked that how much it can delay. So once
Right. So this is super interesting, because this is a chronic disease and the autoimmune process is continuous. And then once we have reached an important amount of loss of beta cells, we cannot really do much at this stage. So what the expert says in this field is that it should be continuous treatment in order to keep the autoimmunity under control and immunomodulation under control. Then regarding the third question, it depends on where you live and what you have in terms of lab facilities. It's not very easy in some part of the world to have all the three main antibody detected in our patients. For Italy, for example, we try to prescribe all the three autoantibody in relatives of type 1 diabetes subject. And this is what we are doing now in order to...
No, but so what the guideline? Suppose I have a 7-year-old boy who had
Yeah.
type 1 and there is a one sibling of 3 year and other is 11 year. Will you check for both the kids? And then if it is negative, for what will be the next, when you will check them again? That's more
So the
important.
guidelines that I showed you just published a few days ago, they really guide us in this type of follow-up. So what they say is basically what I said. It depends where you are and the facilities that you have. If you develop one antibody, the chances to develop a second antibody are very, very high. But also you can become negative over time. This is also been shown. I can go back to the slide if you want. And they say that you have to differentiate between adults and children. It's not written here. Sorry, if you can show the slide I have on the laptop still. So they really guide you precisely with the timing in which you should in which you should go over the measurements of autoimmunity. If I am not wrong, they suggest that in the pediatric population, you should do it at least each 6 months. So you have to do the serology, meaning the antibodies in the plasma, but also you should check the glucose status because it goes together, right? In the adult population is slightly different because when you have a positivity antibody-wise in a children, you have a higher chance of a rapid progression towards dysglycemia. In an adult, LADA, etc., you have a lesser expedite and rapid possibility to develop dysglycemia. So for kids, you have to be more focused and you have a very scheduled timing of measuring antibodies and glucose, fasting glucose, or also HbA1c. For example, they say in the guidelines, if you measure HbA1c each 6 months and you see an increase of 10%, okay, across the month, you really can predict a very rapid development of type 1 diabetes and also DKA, of course, which is the thing that we want to prevent. If you see a 10% across month in our patients, right, it's nothing. It's nothing, 10%. It can be just lab, right? But in this particular population, with at least 2 antibody are already developed, so stage 1 and stage 2, you have to really carefully look into this 10% increase in HbA1c. So what I suggest, and they suggest, if you do see a risk, so a higher 10% increase of HbA1c, do an oral glucose tolerance test. Try to look into the glucose status of your patient so you can really predict the onset of phase 3.
So teplizumab
Thank you,
at present
Dr.
is safe
Bansi.
in 1 year, 2 year, 5
Dr.
year, 10
Bansi.
years. I'm just asking the safety, very important that below the age of 1 year, if somebody had developed autoantibody positivity or at the age of 10 or at the age of 15 or 25, everywhere the safety has been approved?
They grouped, yes, below and up to 18 years old. They grouped.
Thanks, man.
Thank you, Dr. Bansi, and thank you, Dario. Let's have a big round of applause for Dario Duchinadi for a wonderful presentation. Now we move on to yet another very important presentation, and for this presentation we have none other than Dr. Ambadi Ramachandran. Dr. Ramachandran, I don't think needs any introduction to this audience, but I will still, tell you about some of the salient points about him. He is president of the Indian Diabetes Research Foundation and also is the chair of Dr. A. Ramachandran's Diabetes Hospitals in Chennai. He is internationally renowned for his work, especially in the field of epidemiology, and his Indian Diabetes Prevention Program is a very widely acclaimed study, widely cited study for work in epidemiology. And he has also great work in the mobile technology for primary prevention of diabetes. So over to Dr. Ramachandran, sir.
Yeah, thank you, Bridge. Good morning. First of all, I must thank Manoj and Bhuvi and Banshi for inviting WCPD to Bombay, because I am a board member of WCPD and I was happy that I was able to connect WCPD very much with the DRC. Fantastic meeting and congratulations for the beautiful arrangement that you had. I'm going to talk about digital technology, a hot topic. And as you all know that we are using, I think half of you are now looking at your telephones already now. See, you're not looking at me. That shows that how powerful is the digital technology. So I'm going to tell you our experience of using digital technology in two aspects. One, on primary prevention of diabetes, and then the second, in treating diabetes, which will be more interesting for people who are sitting here. So the agenda would be, first, I'm going to just tell you and talk about what Dr. Nandita talked yesterday, the first study that we did, the Indian SMS prevention study, and then the UK-India collaborative study, and then we did a national program using mobile technology to see whether it can scale up the prevention program. Then we'll talk about the use of digital technology in diabetes care, and you'll be surprised to know that we started using that pretty early, and tell you about the SMS study as well as, and now of course, you're using the apps and our experience of using apps in treatment of diabetes. The first one is the SMS Indian prevention, and this is one of the first studies in which mobile technology was used to change the behavior of people to see whether you can actually have a clinical outcome, namely prevent type 2 diabetes. So we took people with impaired glucose tolerance and randomized them into two groups, one on standard care and the other one is on people with who are getting the SMS on their telephones talking about changing their behavior to good behavior. I mean, dietary aspects, and of course, before you start sending these SMS messages, we have already done a previous study, which I'm going to talk to you a little later, to investigate what should be the acceptable and desirable ways and limits of sending the number of messages that you can actually be acceptable to people. So in that we found that usually people, we wanted to know the frequency, the timing, and the type of the message. What time would people look at their machine? And because this was done at a time where apps are not that popular, because SMS was more popular. So we wanted to know what time of the day people may attend or look at this, what is the number of things they will read, and what type of messages will be interesting to them. So that was done earlier. So this was a randomized controlled trial, and the intervention group had standard motivation plus motivational messages, and the standard care did not have the SMS messages. Now, luckily for us, the American company, one of the companies, actually came to us, and then they said they will help us in using the mobile technology algorithm and the software. And the software that we used was actually a one which in which we actually looked at people, how they behave, and then changed the messages according to their behavioral change. So there is a feedback mechanism. In other words, changing adult behavior is not that easy. So we used what is called a trans-theoretical model in which you have a pre-contemplation, contemplation, then preparation, and then action, and then maintenance. You tell somebody, you start dieting today, you start exercise today. Don't expect that they will start that today or tomorrow. So that is what. And the other thing is, even after you starting, there can be relapse. So therefore, all these were accounted when we are doing this study to see whether we can change the behavior of people to prevent type 2 diabetes. So many people ask, hey, what type of messages you said? Well, on the panel on the left-hand side, you are examples of mobile messages, reminders for physical activity tailored according to the stage of the model. On the right-hand side, you have examples of messages, reminders on diet, etc. Because if somebody is already exercising, you cannot tell him start exercise. You must say encourage and tell him continue your exercise. So in that study, we found, surprisingly, we got a 36% relative risk reduction in the risk of development of diabetes in 2 years' time. And for the first time, we saw that. So the control group had 27%, intervention 18%, and the absolute risk reduction was 9%, and the relative risk reduction was 36%. The number needed to treat was 11, which is pretty powerful, and I would say is pretty correct. And this is done only for 2 years. The next question that you can ask is that, of course, you said you send SMS messages, but you prevented diabetes. Is it by chance? Or is it that really they change their behavior? So in order to do that, we did this particular paper, which is looking at the life scores and seeing, we are asking the people how much they walk, did they walk, what are the changes in their dietary aspects, what about the fiber content. And we had these life scores, and when you find that if you have an increased life score, the incidence was much less, which means that actually the SMS changed the behavior, and the changing the behavior was the reason to prevent diabetes. This has also been shown in previous studies. Jaakko Stemilehto has shown in his Finnish study about the scores. Higher scores, you have a lower risk of developing type 2 diabetes. So the lesson from the Indian SMS prevention program was that mobile technology can be used to change behavior and reduce risk for diabetes. First time demonstrating a clinical outcome using IT. This has a scope of scalability to larger population and can be more cost effective. Now, at that point, that was actually funded by the UKD fund, which is the United Kingdom Educational Fund. And we were very much encouraged because we were actually collaborating with Imperial College in London. At the time, the MRC came in and ICMR from India came in and they said, well, now we want to do a better study because we want to do the study in the United Kingdom also. Why only in India? So then we had a collaborative study with India in Chennai, MRC Cambridge and Imperial College. But at this point of time, we had a lot of discussions, and Nick Wareham, who was in the MRC Cambridge, said, what you did, Ramu, was OGTT. This time we will do the HbA1c because Americans are talking too much about HbA1c. So therefore, we used, HbA1c to actually identify and diagnose pre-diabetes, and the HbA1c of 6 to 6.4 was the inclusion criteria, and that was done both in London as well as in Chennai, and we had 2,094 patients. Then they were divided into standard and intervention group, 1,000, both in London and in Chennai. And what we found was during the 2-year follow-up, the control had 22.7, intervention had 21. There was a difference, and the p-value was only 0.22. So the incidence of diabetes was higher actually in the Indians, as usually we see. So, but the interesting part of this study, if you look at the forest plot, was that in the overall there is 11% decrease, which is not as good as that we did in the first Indian SMS trial. The second thing was it was better in the Indians compared to the United Kingdom people. I don't know whether the white people do not look at their SMS or they do not behave as good as the Indians to prevent diabetes. The next interesting thing was we had 31% reduction in women. And again, the question you can ask, well, the women were more obedient than the men, both whether you're in India or in London. Anyway, this is a study. What did this study made us learn was that there could be differences in the results of the same intervention on the, if it is in geographical regions or in different ethnicity with different socio-cultural factors. And there was one more reason, which Dr. Neeta Paroshi was asking that at the time, because as time changes and as we advance technology, when the SMS came in the beginning, that is exciting people to receive SMS on your telephone from your friend, from your bank, or from your... But that became absurd because there was a number of SMS coming into your phones, so we are not interested in looking at SMS. Then we are going to newer technology because the WhatsApp came, internet became more available, so the app technology. Therefore, in the early 2011, when we did the first study with SMS, it is interesting for people. Now, that may be not that interesting, maybe SMS will not change their behavior. The other difference, of course, was that in the IDPP and SMS study, we did oral glucose tolerance test, and the India-UK study, we did the HbA1c. Now, very recently, there's been a study from Finland, which is the real-world effectiveness of digital and group-based lifestyle interventions as compared with the usual care to reduce type 2 diabetes risk, a Stop Diabetes Pragmatic randomized control trial, and they had NGT 44%, they had IGT. The intervention based on multiple behavior changed improved diet quality and decreased abdominal adiposity and prevented an increase in insulin resistance. They did not have a hard clinical outcome, but they found it actually improved their behavior and some of the cardiovascular risk factors. Now the next thing which I talked to you was whether can you scale it up. When we did the SMS trial and when we finished the UK study, the WHO got interested and they wanted us to do a study in a national program, whether we can use mobile technology to scale up into that. So in this, what we did was we actually collaborated. Actually, the WHO office in Delhi called Geneva, and the Geneva people call me because we have done the study in Chennai, and the Ministry of Health, Government of India got involved. Therefore, that was a very good collaboration, and we could use the logistics and also the resources from the Ministry of Health and Family Healthcare, which is a fun. So the methodology was to see whether we can reach large number of people using the mobile phones to see whether we can access and capture or include them into a program. So first was the registration, and when you register, you can register whether you're a normal person, whether you have diabetes, or whether you're a pre-pregnancy person, or we can also give a score to them and ask them and see whether we can actually categorize them as people at high risk of diabetes. And that we did, because the text messages were then actually grouped on healthy messages on diet and also on exercise. And what we did for this first pilot study was give the messages for 6 months. And then we did an impact evaluation after third month during the study and at the end of 6 months, and then finished the intervention, did another impact evaluation after 1 year to see whether there was any sustainability. So there is a very big program. You can see that Government of India could send 130 million text messages, multiple ones. And the total participants which were actually included were 100,000. So that's the power of Government of India, not me. Okay. So, and we registered in 2 types. We had a website, we had a missed call, where on the telephone, we had 64,000 people registered on the missed call, 43,000 people on the website. And then, so that is the number of people who are categorized. We had about 70,000 people who are normal, and then we had 23% diabetic patients. Then they had a high risk group of about 5.6%, which were again categorized on the telephone itself by asking. Then we had also some other categories. So the messages were actually sent in 2 languages, in English as well as in Hindi, because there are a lot of Hindi-speaking people who were involved in this particular study. And the text messages were on health, diet, physical activity, basic awareness about diabetes itself, because we had people without diabetes, and adherence to medications in those people who are diabetic. And then the impact evaluation, we asked about all what the changes happened. We actually had 90 messages, which is grouped. Alternate days, the messages were sent for 6 months duration. If you ask some of the details. And interestingly, go from the bottom. What do you find? People with diabetes, we had 1,000 of them which were seen after 6 months. And within that 6 months, people who are never going for a checkup, 67% went for a checkup because they got aware that you have to treat and take care of diabetes. And next, the high risk, people who never checked up for blood glucose, 52% of them went and checked their blood glucose with their doctor within that 6 months, which means we were able to encourage them, motivate them to go for a checkup. And if you look at the whole group, physical activity improved in 72% of people and dietary habits improved in 57% of people. I think that was a very good impact and all. Then, at the end of 1 year, we asked them, did it sustain? Because we finished the intervention at the end of 6 months. Well, it continued. 41% continued to be still be on the good diet. 54% continued to be on better physical activity. 56% programmed have to improve their knowledge on the level of diabetes, we asked them, and about 11.3% screened for diabetes. Of course, when you get SMS, is it acceptable? Well, we found 97% they understood the text messages. 80% said they participated to improve knowledge about diabetes. 83% appreciated that. And 57% said happy with frequency of messages. And 16.5% said requested increase in the frequency of messages. So this is a trial to see whether it can. So the lesson learned from that national program was mobile technology is scalable and may help in national programs as this can reach large number of in short periods of time. Its efficacy is demonstrated and can be cost effective. Well, most of you citizens here from India are clinicians. So, well, I talked about prevention. Well, we are more interested in taking care of your patient's diabetes. So now I'm going to tell you about how we used mobile technology to treat diabetes in your clinics. So the first study was taken up in 2009, published in 2011. Simple. We took a bunch of patients from the outpatient department who just had diabetes and getting treatment, and then see whether we can reinforce adherence to prescription recommendations by using SMS, a very pilot study. Now, this is done about 15 years ago, so you can see. So what did we do? We took 200 patients, randomized them into two groups. 100 received standard treatment from the physician, the other 100 received treatment plus reinforcement with SMS, again with the frequency talking about. They were followed up for a year to look for any glycemic or non, because sending SMS was absolutely cheap, nothing much at all. And what did we find? It's very interesting. What we found was that one important factor, after about a year, we found that the improvement, the percentage of people below 8% HbA1c increased from 31 to 48% in the control group because they were being observed, but it improved from 31 to 55% in the people who got received SMS, which showed receiving SMS, which is a very cheap method of intervention, really improved their glycemic control. At that time point, my researchers came and asked me, sir, I think we are doing a wrong thing. You can do a little more better because you took patients who already had diabetes for some time and they have been already advised to do diet, exercise, etc. And then you try to improve at the middle of their disease. They will not change. Why don't you take people who had newly detected diabetes when they are ready to change? Oh, I got diabetes today. I should do something. So in this study, we took people who had diabetes detected today and then randomized them into two groups. And that was among newly diagnosed type 2 diabetes, a multi-centric. So it is not in one center. It is a multi-centric randomized control trial conducted in 2 states in southern part of India, 248 patients, 122, 126, mean age of 43. Both groups received personal advice at the beginning, but one group got SMS. And that was for 2 years. And the primary outcome was an improvement in HbA1c. Secondary outcome was body weight, lipids, adherence to. And what we found was again interesting. We found that at the end of 2 years, there was a significant improvement. The intergroup analysis of HbA1c showed a significant improvement, lower value of intervention group when compared with the control group. You can see 7.4 versus 7.8. Similarly, we also found the fasting plasma glucose in millimoles was 8.4 in the control group, but it was 7.5 in the intervention group. So, when you take people with new data in the diabetes, everybody will have high sugar in the beginning, everybody will respond. But the response is better if the intervention is more intensive and sending SMS. So this is another example of using mobile technology for improving behavior of people for better control of diabetes. This is the graphic representation of the same one. Well, now you will be interested in a little more modern one, because now we are all sitting with this in your phones. From SMS to mobile application. Why did we do this? And I tell you why we did this. This was done because the COVID closed our clinics, and the government said that only people who want to have, multi-specialty hospital can function. If you're only looking after routine diabetes, close your outpatient department. So what will our patients do for consultation? And for some time, we are finding it difficult. So we want to know whether we can develop a mobile app to see and we can connect with patients. We're not talking about artificial intelligence here. We're talking about connecting your patients with doctors, our own patients with doctors. So it's a patient-centric, individualized medication. So it was actually a hybrid technology that we used, and the software was a little expensive because in the beginning we had to depend upon an American software company, and the hybrid technology we wanted to be accessible, affordable, and sustainable. So this is called DiaHome, and in fact this was a concept. The concept was actually by Dr. Arun Raghavan, who is the first author of the study which I'm going to give you, where online consultation and answers to questions, and you can, doctors can connect with this mobile app, get their fees collected. It offers not only consultation, we can do also blood test in their local area. Patients do not have to walk, come, travel to the hospital or clinic to get routine diabetes treatment from expert diabetologists, and that is what we did with this app, and it is still functioning. So there is clinical help, advanced even diagnostic test, and then dietitians is connected, physiotherapy can be connected, counseling can be done, and electronic medical records could be easily stored, and even a pharmacy was connected. So we wanted to see whether is it really good, because at that time COVID went away and opened out. So then we had still patients who were continuously working on the app, because there are lots of patients who were, for example, if you are a big consultant in Mumbai and your patient is coming 300 miles away because you are an expert, and the patient is not able to come, you won't expect him to come very regularly, because diabetic is an asymptomatic disease and you know that the dropouts are very high. But this is one technology which can remind people and keep them on a regular basis to consult you, because they do not have to travel, it is cost effective, and their expenditure is very low, and you are connecting. So we wanted to see whether was it really working. So this paper is published called this Improvement in Glycemic Control in Patients with Type 2 Diabetes with Treatment Using an Interactive Mobile Application. We studied the glycemic outcome using what is called the DiaHome. Why is it called DiaHome? Because diabetes care comes home. You don't have to go to the doctor. It's a smartphone application compared to conventional treatment. So what we did was, because we started, after the COVID patient had started coming, and we had trickling in patients and they were coming, we did a retrospective case control study of patients on virtual diabetes care using their app, and those who visited the hospital as one of the first studies to see whether there was any difference. In fact, it's almost like a non-inferiority study. And what did we find? Actually, we thought that whether you use the mobile app or whether they are coming into the hospital, they must both will be done very well. And we probably expect that patients who are coming into the hospital visits to see the doctors, they may do better. But not that. It is the other way. We found that the HbA1c was 7.3 on follow-up in patients who came to hospital, but it was 7.2 in patients who die home. Now you see, these are selected patients who are on routine care. They are not coming for illness. And the fasting blood glucose also actually was significantly better in those who were actually being treated using the mobile application. That shows the percentage differences in HbA1c and fasting and 2-hour plasma glucose. As you can see, HbA1c was better, and fasting plasma glucose relative reduction percentage is better in patients who are using the DiaHome app compared to hospital visit. The other question, of course, you can ask is, suppose when you have interaction, you may ask a question, was it actually very useful? Well, was it acceptable for patients? As you can see, that there was a user satisfaction. Now you may ask me, are people still using it? That's a number that you have, that in July, we had almost 15,000 consultations done on this. In our hospital, we use this almost every day. On 3 days, I don't have to go to the hospital. I can connect with my patients sitting at home. We had almost 6,000 patients enrolled in this. So then there are many other studies. Peter is here. I don't know whether Peter had done, he's also, this is another study on the impact of digital lifestyle intervention on diabetes done in Germany. Digital health application, 3 months prospective multi-center open label trial with an individual group. HbA1c reduction was achieved. Digital health application was effective in significantly reducing body weight as well as fasting plasma glucose. This is another study, again showing a MEBIX, which is another app intervention for 3 months, and HbA1c values were observed every 3 months retrospectively, and we found a better. There are a number of studies. Some of them, unfortunately, had very short periods of time and very small numbers, so I'm not going to give that. So finally, use of digital technology is useful in primary prevention. The post-trial effect also has been demonstrated, and we found that primary prevention study with mobile technology in India and the UK showed ethical differences. Mobile technology may be used in national programs, and either SMS or app can reach large number of people, and there can be significant beneficial effect on behavior. App is useful in routine diabetes management. Now, before you walk out of this room, I'm going to just put this last slide. When you listen to talks in these conferences, always you come here to gather knowledge, information. But finally, when you walk out of this place, you want to ask a question. What did you gain by listening to this talk? And other than meeting your friends and having good dinner and good wine, something else you should have done. So when you walk out of this hall, please take away this message from this particular talk. Improve diabetes care in your practice. If you contact care@diahome.com and register, as your patients can download DiaHome app free, get registered free, connect with your patients online from your clinic, case history collected by an assistant to help you, not your assistant, we will provide. Blood collection will be done at home by 300 laboratories anywhere in India. Video consultation with you, not just telephone. Patient sees you, see your face. You don't have to wear a mask because he's sitting 400 miles away. prescription can be given, diet counseling is done free, diabetes education free, you can collect your fees which will send to you. Dropout of patients will be minimized and confidentiality maintained, there will not be any migration of patients. More importantly, let us say you're sitting here and your patient is sitting 50 miles, 60 miles away in Mumbai, and that man wants to connect with you. But his daughter is in Bangalore working in the IT, and she says, I want to be with my father when she consults you. We can connect her online in the same app. Multiple people can be connected. So it's a pretty effective, very, very efficient, and you can use it from today. Thank you.
Thank you, sir, for a very lucid presentation, and you have rightly shown that technology can improve the behavior of the patient positively and cause good glycemic control and improve their quality of life. Thank you, sir.
Thank you.
With this, we conclude the session. Let's have a big round of applause for both the speakers. And over to the organizer for next session. Thank you, sir.
Can I have one question? I think, all.
Sir, we are already running behind time, so you can talk to Dr. Ramachandran also.
Thank you.
So before we move on, I would like to invite our esteemed chairperson and speaker of this session to join us for a group photo. Moving on to our next session, which will focus on adherence to type 2 diabetes treatment in order to prevent its complication. It's my pleasure to invite our next chairperson to lead for this session, Dr. Ilhan Satman, Dr. Aparna Mithil, and Dr. Jayaprakash Sai.
Good morning. Our first speaker is Jen Mabnia. His topic is how to avoid inertia in treatment with non-insulin glucose lowering drugs. Over to you, Jen.
I want to also thank the organizers for inviting me to this session and to give this talk. My talk will be based on experiences and my flirting around the world. These are my disclosures. There's nothing aberrant to this presentation. This will be my outline of the presentation. I would introduce the type 2 diabetes and what it is. Then I'll look at the failure to advance therapy. And then I will look at avoiding inertia in the treatment of non-insulin drugs. Look at interventions that we can use to overcome this inertia. And then I'll give a few take-home messages. As we all know, type 2 diabetes is characterized by a decline in beta cell function and worsening of insulin resistance. And therefore, maintaining glucose targets is important in the management of type 2 diabetes. But the progression is such a way that you see that as the beta cells function decreases, you notice that we have certain momentum that we can use to manage the type 2 diabetes. And this informs a general lifestyle, but you also have non-glucose agents, and initially and eventually the patient might go on incretin. But we are dealing with a very complex and diverse patient in our clinics in terms of old age, in terms of high blood pressure, in terms of comorbidity. So if you want to initiate treatment, you have to take all these things into consideration. But we have guidelines that will help us to increase the message. But what happens, what you see with non-glucose agents, drugs, is that by the time we intensify it according to the guidelines, it takes a specific long time. And this is what we call clinical inertia. So we have to increase on inertia. But why do we do that? Whereas the guidelines are very clear in terms of what we do, that we start with drug combinations to act on the multiple pathophysiological defects, and then they treat the target pathogenic abnormalities, and of course, early treatment and intensification. Their aim is that early combination therapy strategic approach. We have a synergistic action in terms of the management of type 2 diabetes so that we don't go into clinical inertia. Secondly, this is what we all use today in terms of glucose-lowering medications in the management of type 2 diabetes. And therefore, the guidelines, again, are extremely clear that we have to start with lifestyle interventions. Then we look at people who have secondary effects in terms of atherosclerotic events, be it heart failure, be it chronic kidney disease. And then we stratify this treatment in such a way that intensification is possible. So the guidelines are clear. So why are we not using the guidelines? Why do we not use guidelines? Because there are challenges to glycemic control, and we have what we call the deadly triad, which is diabetes is a progressive disease, which I've just mentioned to you. Thus, clinical inertia does exist because people don't apply the guidelines, but also that poor adherence to management regimens is a problem in our society. But the solutions are there when you integrate a teamwork, when you work self-adherence, when you use applied guidelines in your prescriptions, and when there is a trust shared bearing in patients' education. So that's what we'll go through this morning in terms of using teamwork in management. But let us be very clear. Inertia, in the terms of non-glucose insulin drugs, has so many factors. You have the patient, you have the physician, but also the healthcare system is also incriminated. As we define inertia as defined as the failure of healthcare providers to initiate or intensify therapy when indicated. This gives us suboptimal glycemic control for many years and will lead to dramatic consequences, be it diabetes complications or otherwise, but also incur a high cost in terms of associated with uncontrolled type 2 diabetes in a community in the healthcare system. So what are these patient-related and care system? We know that in terms of physician-related factors, about 50% of it is due to that, which is failure to set clear-cut goals, failure to initiate therapy, failure to titrate the dose, and these are all what I've listed on this side of the curve. But when you look at patients-related factors, which are about 30%, they involve denial of having the disease, low literacy, high cost of medication, which is the case in most low-income countries, of course, the side effects, and then lack of trust and communication between physicians, and of course, a lack of physician trust and absence of symptoms. But there are also healthcare-related problems which are no in terms of clinical guidelines, in course of training, continuous medical education, poor communication with their patients. So let's look at a short time to spend consulting negatively associated with physician dissatisfaction. And you see here that significant association between the time you spend consulting and the impact on the physician. It's very high. And that the short consultation length is likely to adversely affect patients and in terms of patient load, and that is significantly associated with physician burnout. But of course, short exam was responsible for driving polypharmacy, abuse of certain medications, and of course, a lack of intensification in patients with type 2 diabetes could be associated with short physician factors. But then physicians often redirect patients' description. We don't listen to our patients. By the time they finish their sentence, you are already referring them to other possibilities. And this is reversal. And then the length of time of stay we give with them, it generally is about, sometimes let them speak, it's about 23 seconds. By the time they finish, you've already done something else. And then they are redirected. Once redirected, the description are really completed. And the consequences of incomplete initial description include late rising consent and, of course, leading to patient adherence. But language has a strong impact on the perceptions and behavior because we are giving drugs to patients, how we're going to present them. Therefore, the use of empowering language in diabetes care and nutrition can help to inform and motivate people. Of course, language that shames and judges may undermine this effort of tuning. The use of language is neutral, non-judgmental, and based on facts, action, physiology, body descriptions, the description of physiopathology of the disease, free from stigma, strength-based, respectful, inclusive, impacts hope, that foster collaboration between people with diabetes and healthcare providers. But more importantly, in our management of type 2 diabetes, it should be person-centered with diabetes referred, don't say diabetics, we usually call them people affected with diabetes. And then I would look at the physician-patient communication strategies, which is important to adopt. Better physician-patient communication enhances the greater use of collaborative and encouraging conversations, have greater well-being and self-care. And then the need to add on medication, which is the topic of our discussion. Physicians' empathy and beliefs about the patient and their disease may play a significant role to promote patient engagement and safe care. People with type 2 diabetes who are tempted to delay additional medication are usually due to poor patient perceived communication and in terms of quality and outcomes. So there must be a balance, and the balance is the pros and the cons. When the decision involves weighing the pros and the cons of various features of relevant treatment, especially of oral drugs, the appropriate choice depends on understanding how the patients value the risk. So we have to be able to explain the risk to the patients. On the other hand, the physician should present the benefits and potential side effects of available treatment. Because of the polypharmacy in terms of intensification, which we have nowadays, we just tend to throw the drugs, non-insulin drugs, to the patient because the guidelines have said it, but we need to effectively explain these references to the patients. What are the interventions that we can use to overcome? Here I've put the principles of care, which are many. You consider shared decision making, consider lot healthcare setting factors, complications, health behavior, and you see the risk, even psychosocial factor. This is important to cover if you were ensure that you would have no initial. And the interventions, continuous medical education, motivating and supporting patients on self-care, adherence to medication, adherence to guidelines by the healthcare provider, personal feedback to healthcare providers from the patient, effective use in information system. Dr. Ramachandran has just been discussing this with us, and developing quality measure. Now, shared decision making is what we reinforce this lack of inertia. The purpose is to identify reasonable management options that best fits and address the unique situation of your patient. And here you have, you create a conversation which will identify the best course of action, exchange information which is bidirectional, in which you use research evidence, patient and clinical experiences, expectations, concerns, fears, in order to use this exchange to acknowledge what matters most to the patient. And of course, deliberating collectively by each patient and clinicians to consider how issues, matters arise. And this is akin like having a research hypothesis, where you develop the hypothesis and you try to ensure that your research hypothesis works. And that's the same thing of managing people using the guidelines so that you don't get in a state of inertia, or especially clinical inertia in your patients. And then, of course, coming by mutual agreement to a decision that reflects the evidence-informed patients' preferences. It's important of improving adherence, and this goes, you all know this ADA, ESD brain approach of adherence, but it's not only that, is that you have 3 major levers: prescribe regimens, educate the patients, encourage close collaboration, and 4 strategic approaches, which I will not be able to get into this morning because of the time. The levers are prescribed regimen with high probability of adherence. You have to be able to the lowest possible appropriate pill burden, because we load our patients, apart from the vitamins and the rest, with pills. Reduce cost frequencies, favorable effects which do not cause side effects, and of course more effective cost management are important in order to get the balance of the drug. And the levers are education, therapeutic education, from the diagnosis, knowing the patient, family structure, socioeconomic status, and all what you need to do with the patients. And of course, you have what is the medical dimension, what is the history, personal family history, what are the cognitive dimensions in terms of knowledge barriers, and help the patients acquire or maintain skills he needs to be better manage his lifestyle disease, which are all important if you have to stop at inertia. But you develop a therapeutic alliance where careful listening feels, the patient feels regarded, clarifying concerns with expressed interest, giving reassurance to the patient, encouragement, empathy, and praising the patient when necessary. And this compassion will lead to strong therapeutic relationship between you and your patient. Of course, my take-home messages from here are quite clear and quite simple. The first thing is that individualized treatment targets and treatment intensification options based on guidelines with non-insulin drugs. But is that all? No, you also have to do the shared decision-making where the clinician uses the evidence from guidelines and clinical experience to start the conversation, develop that deliberation to encourage decision-making tools, use these evidence pattern preferences for decision-making, and where the patient value the context and the experience of the physician in managing their disease. I want to thank you for listening to this presentation.
Thank you, Professor Jain, for the excellent presentation. Now I request my colleague to introduce the second speaker.
Thank you. Yeah. Now it's my pleasure to invite my long-term friend, Professor Nevoja Lalik. Lalik is a professor of internal medicine in Belgrade University. I know him from clinical trials on diabetes and lipids. He's currently serving in the Serbian Academy of Science and Art and chairing the IDF Europe. Please, he's going to talk about the clinical inertia in insulin treatment. Yeah.
Thank you very much for the invitation to the organizers and to the chair lady for remembering us of the, I wouldn't say all days, but the beginning of our collaboration, which was a couple of decades ago, during the trials on prevention of type 2 diabetes. So, my talk is, in a way, continuation of the previous talk of Dr. Mbanya. And now we are in our practice, and everybody in the auditorium knows, switching from oral agents to insulin, or to other agents which are not orally used, but now it is still, in most cases, insulin. And we do hope that we have solved a lot of problems and that we will avoid, among other things, clinical inertia. However, it is not always the case, and in many instances, it is not the case. So my talk will be dedicated to that. These pillars of our decision is that the prevalence of type 2 diabetes continues to increase, that however the course of type 2 diabetes can be altered, and especially if we focus the new insulin formulations and the ways to be applied. However, we are not having the same pacing of the awareness of patients' diabetes burden and impact on daily life. It is needed, but it is not always present. The dogma, let's say, of diabetology is that we start our treatment with basal insulin and that we explain to our patient that the patient should be well educated, as we have heard for the oral agents as well. There are rules, I wouldn't go into details here, and of course insulin, when properly used in accordance to those rules, and when used in accordance to the individual characteristics of the particular patient, still has a very important place. You can see that its efficacy is among the highest ones in controlling diabetes and in at least lowering blood glucose. But however, what we expected at the very beginning of the whole thing is that we would, in a way, avoid this roller coaster curve that we had with oral agents. When you introduce a new oral agent, you get an improvement of HbA1c. Then in the second phase, HbA1c escapes, and then you introduce another one, and so on and so forth. However, we thought that insulin, the use of insulin would, in a way, in an easier way, prevent these facts, and that we will have a stable control. However, this is not the case, or it is not the case, unfortunately, in the majority of studies. Why? Because insulin treatment at the same level or even more than that has the need of being all the time adjusted and all the time adapted to the needs of a particular patient. And if that is absent, we are coming then in a same situation as we are with oral agents or any other agents. And the analysis that Kamlesh Kunti did have shown that even the insulin is introduced very late, and after the use of 1, 2, or 3 agents, and that it can be with HbA1c higher than 7 after 7 years of the unsuccessful treatment of diabetes, which is unfortunately the reality. What is the causing this reality? It is causing the components are distributed between the people with diabetes, patient-oriented, physicians or healthcare providers. However, they are also system-related. And a number of studies have been dealing with this phenomenon, and what were the barriers for insulin initiation. And one would say that this is a fear of injection, and that is a fear of hypoglycemia. However, this scale, if you wish, that you have when there are patients barrier, says that there is another very important psychological thing, and then patient perceives the use of insulin as the failure of the treatment of his disease or her disease. So that this is something that marks the disease that cannot in general be properly cured. Then that insulin causes complications. This is an echo of our discussions how insulin participates in the pathogenesis of complications. However, there is a loss of independence, and then not so far in the ranking, not so high in the ranking, there is a fear of injection and fear, of course, of hypoglycemia together with weight gain. When the clinical side is concerned, there is a sort of suboptimal insulin knowledge, especially in this plethora of new insulin formulations, and again, fear of hypoglycemia because of the activity that are needed to be done in those patients. So the key points are that don't let inertia trace back to you, and talk to your patient and get their perspectives and empower them to titrate the treatment as himself. And if we do that, we will be able to deal with these 4 most important burden, and these are insulin as a death sentence, fear of injection, and the sort of loneliness that patient can feel, and the fear of hypoglycemia. However, in the modern treatment, when the combinations of insulin and other agents are very popular, it is important to take into account the adherence, the extent to which a person's behavior taking medication corresponds to agreed recommendations. Are they too complicated, maybe? Or concordance, which encompasses the idea that healthcare providers and the patients are equals, and that the person with diabetes makes informed decisions. Informed means at the level that he can understand and implement. That might improve the situation, which is nowadays very gloomy. And another analysis says that the adherence to insulin, both in multinational studies and in one country studies, UK studies, are very high. Low adherence to insulin is very high, and it goes up to 30% of all the patients taking insulin. Even more complex insulin regimen, taking more daily insulin doses, complicates the whole situation and decreases the adherence even for about 10%. We see with the relevance to the complications, we can see that some studies have shown that late introduction of insulin have, of course, very negative consequences to the onset of complications, especially cardiovascular ones. Some of the studies have shown that in the people with aged higher than 65, the microvascular events are decreasing with the later use of insulin, which might be the failure of methodology, in my opinion, or there might be other mechanistic reason for that. And this is something that we should take care of when the response of the people older than 65 is different from the response of the others. The number of people with type 2 diabetes not receiving goals, targets of less than 7% is rather high, and this analysis in 6 European countries have shown that this very infrequently goes up to two-thirds of the number of population. A similar study in bolus insulin naive patients in USA say that within the first 6 months, nothing is undertook for the correction of the situation, and then later on, still no action is prolonged until the 24th months of the presentation. We, in our own settings, we just try to see what are the predictors of clinical inertia in the treatment of type 2 diabetes. And it's interesting, especially for the developing countries, where new formulations of insulin are not very much available, or they are under different constraints, that there is a phenomenon that the patient uses this, for example, very modern forms of insulin analogs, but however, his the control of his disease and the involvement of the patient and the doctor in this is lower, and then in those ones who are receiving older forms of the disease. And that is the thing that should be corrected. The new forms of insulin do not certify that this is going to be the good control. And on the level of Southeastern Europe, we gathered and made an expert opinion. What are the major factors of clinical inertia from patient side and potential ways to overcome it? And what are the major factors of clinical inertia from physician side, and what are the major ways to how to avoid. At the same time, many groups are trying to do that, and this is the product of some studies done in the US, giving 5 major tips to address to insulin therapy, which says that we should explore the anxieties, emphasize the positive aspects, offer guidance, deliver instructions, and follow up regularly and check adherence to the persistence. And finally, and in the end, we should not forget that the area of insulin treatment is constantly showing a technological advancement. And there are many alternatives to the current insulin delivery. And if we get a consensus with the patient, that there are simple solutions that can reassure a more stable and more persistent adherence to the whole to insulin treatment. Closing comments would be that for many patients with type 2 diabetes, insulin can restore residual beta function, but we should be positive when discussing insulin therapy with our patient, and basal insulin should be initiated according to the current clinical recommendations. Thank you very much.
Thank you very much, Lali, for this very comprehensive talk. And I will pass to my colleagues for the third speaker.
Good morning, dear friends. I have great pleasure introducing my mentor, Dr. Brij Mohan Makkar, who is an eminent diabetes and obesity specialist in the country and is immediate past president RSSDA. Dr. Brij Mohan Makkar will speak on how to avoid clinical inertia in obesity management.
Good morning, everyone. Thank you, Sai, for those very generous and almost embarrassing introduction. I don't know how to set them for my presentation. Anyways, so after 2 stalwart speakers, it becomes very difficult to make a presentation, but I will try to do justice to the topic that I am given, how to avoid clinical inertia in the treatment of obesity. And the interesting thing is there is hardly any data on this subject. I don't have any financial disclosures for this. Now we know that obesity is a huge global problem. The prevalence is increasing. We have more than 1 billion people worldwide who are obese, almost 650 million adults, 350 million adolescents, and about 40 million children. By WHO estimates, we are going to have this number increase by almost 70% by 2025. And we are going to see many more adults and children living with obesity. Now, India also, we have a good, or I would say, very high prevalence of obesity. And this we saw from the very recent data which came out of the ICMR INDIAB study. And ICMR INDIAB study is ongoing study since 2008, and Dr. Mohan Center and ICMR are collaborating on this study. I must, convey my regards to Dr. Mohan for sharing some of the slides. Now, this study, though, is looking at the prevalence of diabetes in India, but came out with very, a striking data for obesity prevalence also. Now, currently, we have almost 30% of people, adults in India, living with obesity. And if you look at the urban population, almost 40% of the people are living with obesity. And if we look at central obesity, the prevalence is almost 40%. Now, obesity we know is mother of all important diseases of adult life, and now the list exceeds almost 240 diseases which are associated with obesity. We also know from large studies done way back in 30 and 40 years back that every increase in A1C, in BMI, is associated with increase in the prevalence of diabetes, and obesity is one of the key drivers for rising prevalence of this diabetes epidemic also. The studies have also shown that whenever there is a rise in BMI in any population, it predicts changes in diabetes prevalence also. And this has been seen in two large studies, one from Paul Zimmet in Australia. Increasing prevalence of obesity over 2 decades was paralleled by increase in prevalence of diabetes, and same is being reported from US by CDC. The increasing prevalence of obesity in North America over 2 decades was paralleled by increase in the prevalence of diabetes. So obesity is not just weight. It is not termed as ABCD or adiposity-based chronic disease. Now, what happens is in individuals who are predisposed to become obese, there is a complex interplay between the genetic factors and the environmental factors and epigenetics to lead to development of ABCD or obesity. To begin with, these people may be insulin sensitive or insulin resistant. Those who are insulin sensitive go on to develop biomechanical and psychological complications, and those who are insulin resistant go on to develop pre-diabetes, pre-hypertension, metabolic syndrome. Those who are insulin sensitive also in due course become insulin resistant, and these people have increased risk of developing all the cardiovascular risk factors, and once they develop hypertension, diabetes and NASH, there is further increase in the risk of developing all the complications related to these conditions. So we know there is a huge problem. We know it has serious implications, but this is the amount of action that we have for this. There is hardly any action which happens in terms of managing obesity. This is one of the recent papers that we presented at the ECO meeting in Maastricht 2 years back, which looked at the, complaint of obesity as a medical condition by people who are coming to us with the other comorbid condition. This was the abstract 416. This is a retrospective observational study done at our own center to assess the percentage of people with high BMI and associated comorbidities who are presenting with overweight or obesity as a medical problem and seeking medical treatment for obesity. Data for all the patients visiting the center over 8 months period was analyzed. We included 971 persons with BMI more than 23 in this study, of which about 56% were males. The people with obesity, people who were in the obesity group, that means who complained of obesity as a medical condition, had a higher BMI, and those in the non-obesity group, that means they never complained of obesity as a problem, had significantly higher number of persons with at least one medical comorbidity, that was about 94%, and 84% had at least 2 or more comorbidities. Only 18% of the people who were having 2 or more comorbidities complained of obesity as a medical condition, and 82% never complained of obesity or overweight as a medical problem with them. So there is huge amount of clinical inertia in obesity, but clinical inertia in obesity is different from the clinical inertia that we use the term in diabetes. There are two components. One is the diagnostic inertia. We fail to diagnose obesity as a medical condition, and then there is therapeutic inertia, which is commonly defined as failure to advance therapy or de-intensify therapy when it is appropriate to do so. So, in obesity term, I would say it is the failure to initiate or optimize therapy when it is appropriate to do so. So there are two components of inertia in obesity, diagnostic inertia and therapeutic inertia. Diagnostic inertia is defined as a failure to diagnose disease and has not been analyzed in obesity. Data is very, very scanty. If we look at the therapeutic inertia, the medical nutrition therapy and physical activity are often used exclusively for obesity management, despite availability of effective treatments and other options. So we don't even offer those options to people living with obesity. To qualify obesity inertia in primary healthcare, this was a study, looked at obesity inertia in primary healthcare setting. And to quantify obesity inertia in primary healthcare setting in Spain, there was a population survey where whole population was invited to get the medical examinations done. So this population was over 40 years age. All obese persons who reported within the first 6 months were taken up for this study. Obesity inertia existed in 1 in every 6 persons. And this was very low. The study also says this was very low because these people were people with the high cardiovascular risk factors. This is another study which was a small quantitative study, done to understand why people living with obesity and people living with the obesity and those who are treating them, the family practitioner or general practitioners, what is the level of clinical inertia in them. 20 patients and 20 practitioners were, surveyed, and they were given a questionnaire which was responded. Both people with obesity and private practitioners often perceived obesity to be a secondary health priority that is associated with negative emotion, which had pervasive influence on obesity management. People with obesity were hesitant to explore new strategies due to financial barriers, access to support, and concerns of adverse side effects, effectiveness, and sustainability of these interventions. The practitioners were also, challenged because of the limited time and resources. They were also hesitant to recommend specific treatments due to concerns of risk associated with treatments, the effectiveness of treatments, and also accessibility to treatments. They were also hesitant to make referrals due to skepticism that other healthcare providers will be able to do anything substantial for these patients. Then healthcare coverage for many people with obesity was not there, and the cost was another big challenge, which was issue. Then this was a large study further, done with 200 people involved, and again showed that people with obesity hesitated to use prescription medicines and bariatric surgery due to financial reasons, concerns with the other side effects, and the long-term effectiveness. Even after initial weight loss, they often struggled with the maintenance and accompanied by decreased motivation and commitment to obesity management. These findings underscore the need for accessible resources and professional support for people with obesity. Now, let us see what causes this clinical inertia. We have clinical inertia, though we have very limited data, but we also have to understand why this clinical inertia is there. And this is largely because of the prevalent obesity narrative. The prevalent obesity narrative is that obesity is a self-imposed condition with very easy way out, that you eat less and move more. And that is going to be the answer for obesity. So this simplistic narrative of obesity is a self-imposed condition with an easy way out, creates a clear discrepancy on how obesity is managed in healthcare setting in compared to the other non-communicable diseases. The overestimation of efficacy of therapeutic interventions solely based on the patient education and lifestyle modifications is responsible for therapeutic inertia in healthcare professionals, in clinical guidelines, and limits and delays the adoption of more effective therapeutic strategies like anti-obesity medication and bariatric surgery. Based on these false assumptions, individuals can fully control their body weight through appropriate choices, or obesity is a simple, reversible, condition which can be reversed by persuading the patient to follow healthier and more virtuous individual behaviors. Is again one of the challenges. This persistent narrative also forms the deep root of stigmatization of obesity. That people with obesity at individual level, there is a stigma, and creates a clear discrepancy on how obesity prevention cure should be designed in comparison with the other NCDs, leading to clinical stigma. This is a beautiful paper published in 2021 from one of our friends, Luca Bassetto and his group. And the interesting thing is, if you look at the abstract, there is one important line here. What is the level of evidence? There is no level of evidence. Because there is no data. There is no work has been done in this area. So persistence of a narrative of obesity as the simple consequence of individuals' failures and lack of willpower is responsible for lack of support and systemic preventive measures against obesity at political level and social level. In conclusion, the persistence of a narrative describing obesity as a self-induced, easily reversible condition has profound consequences on how obesity prevention and management are built, including the design and implementation of obesity management programs and tendency of therapeutic inertia. So, to sum up this, we have individuals who are obese, and it is thought that individuals can fully control their body weight through appropriate behavior choices. And obesity is a self-imposed condition with easy way out, that is, eat less and move more. Now, this leads on one hand to stigma against the people who are obese, leading to increase in the risk of mental disorders, increase in binge eating, increase in emotional eating, increase unhealthy eating and sedentariness, increase body weight. On the other hand, it leads to stigma against obesity as a disease, leading to clinical stigma, decreasing the systemic preventive approaches, decreasing funding for the obesity research, decrease in the coverage for obesity as a disease, and increase in therapeutic inertia. And ultimately leads to stigma which increases individual suffering and hampers the obesity prevention and management in comparison with other NCDs. So we need interventions to overcome this inertia, and most important is the education both at the level of patient or their families and at the level of healthcare providers. We have to have motivation and other strategies supporting patients on self-management, effective use of information systems, developing quality measures, adherence to medications, adherence to guidelines, and personal feedback on the healthcare providers. With this, I conclude my presentation. I would also like you to block your dates for the forthcoming RSSDA annual conference, which is a mega event every year in November, 14 to 17 November, New Delhi, and it's a state-of-art, convention center where we are hosting this. So block your dates and be there. Thank you so much.
Thank you, sir, for the excellent presentation.
Sir, it was an excellent lecture on obesity. I'm Dr. Subhash Shah from Borivali, Mumbai.
Sorry, may I invite all the speakers
Question answer.
to the podium?
Just 1 minute.
Then you
I
can
want to
ask.
talk to it, sir. Sir, now what you said, sir, I have already done the 2,000 patient data in Mumbai in last 6 months about the obesity. Now what you said, right, personal, social stigma and a personal stigma. So I have to just tell them, you have to convince for counseling is the most important thing.
Yes.
Yeah, thank you.
Any other comment or questions? May I ask my question for the first two speakers, because obesity is quite early for. I would like to learn about your opinion about the treatment, the intensification or reverse clinical therapeutic inertia in diabetes, especially in the elderly people, or non-insulin and insulin treatment.
I think part of the problem we have is that we are developing medications so fast and promoting them so fast that the healthcare providers cannot keep up with what we are doing. And secondly, sometimes the evidence is thin because the new drug comes out, all what we do is that prescribe, because, but in the long term, when we actually know the effects, the side effects, and the implications of the drug, you start seeing that you have to be more careful. So that is part of the problem. We are embracing medical science very fast, and forgetting the history of like metformin or TZDs. You remember TZDs? We all said it was very good initially, and subsequently we saw that it was not as good as it was. But one of the lessons we have to learn is that in terms of clinical inertia with whether insulin or non-insulin, we know that combination therapy is the best, and titration of the insulin and the different types. But lastly, and more importantly, education, not only of the healthcare providers, but of the patients to understand the pathophysiology of diabetes and understand that they have to put in an effort to be successful in the management. I think that's what I have to say.
Madam, this is Ashok Das from Pondicherry. I have a question for Dr. Breach, last question for mine. Breach, you know,
Excuse me. Professor Lalik is going to respond for the first question.
Sorry, after that.
Just very briefly, I of course agree with Professor Mbanya about this slight confusion that we are coming in and marching through regarding new guidelines, formulations, and so on. But there is something that I would like again to stress your attention on our study that we did in our own country, which is not so rich in the ability of getting new formulations, especially of insulin. And once the patients are equipped and the doctor with new formulations of the drug, they stop worrying as if there is the battle is over. However, it is not the case. And after a while, it appears we clearly have seen that the results were after a while better in those ones who have less sophisticated insulins than more sophisticated insulin, not because less sophisticated insulins is better, but because of this intensity of care is more frequent.
Thank you.
Yeah.
Go ahead.
Thank you. Breach, I just wanted to mention that in relation to diabetes and obesity, which we call diabesity, one important issue is to probably impress that obesity treatment is a target for organ protection or complication mitigation. That probably has not gone in weight, number one. Number two is that I was discussing with you the Ayan Sharma's lecture that we need not be asking for the permission for discussion or for putting on therapy, but to put on the therapy most proactively, because we know the consistency of the lifestyle or the other methods of treatment where we lose a lot of time.
Agreed, sir. The important thing is even now, am I audible? No. So even now in India, you can hardly see anybody writing a diagnosis of obesity on prescription. Most of the people are not even, checking the waist circumference or weight regularly, or even if they're checking, it is a noting on the side, but nothing is done about it. So recognition of obesity as a disease is still missing in, most of the clinical settings. People walk into the center for treatment of hypertension, get treatment for hypertension, walk out. People come for treatment of diabetes, get treated for diabetes and walk out. So first thing is we have to recognize that obesity is one of the key drivers for all these conditions. And I think then the whole thing will change.
In some, like in Africa, for example, obesity is a sign of good living.
Yes.
Culturally, they think that if you're obese, it's good living. So people would prefer to be obese than to become thin, So it's a cultural thing that we also have to work on.
Can I?
The last question, please.
Thank you for the fantastic presentation. I have a question for Dr. Makar. So, as you know, if you look at the data of the Action.io study, in which have been interviewed through a survey, either patients living with obesity and the healthcare professional, the patients mainly are afraid of complication related to obesity. They don't have any clue about BMI or waist circumference. And if we look at the history of type 2 diabetes, people are not really aware of what hyperglycemia is, but they are aware of kidney dysfunction or retinopathy and so on. So even though we really have to focus on the fact that obesity is a disease per se, is a central disease, right? We do really focus a lot on complications. I think to let the people understand that they can actually end up having very serious complication. I would like to have a comment from you regarding the fact that we really need to focus on complications related to obesity in order to make it aware as a disease.
I totally agree with you. And in fact, if you saw the slide, one of the slides which I always put in my presentations is the complications related to obesity. And my standard, introduction to that slide is that obesity is possibly the mother of all important diseases of adult life. So if you treat obesity, you can actually, take care of a lot of things. Second thing is, your point is very valid that people are concerned about the risk associated with therapy. Because if you look at the history of obesity treatments, there is a full graveyard. You had number of drugs which came and were shelved, one after the other, starting with dexfenfluramine, then sibutramine, then rimonabant, then latest was lorcaserin. And none of them were effective therapies. They were all at best able to give you treatment, weight reduction in the range of 10%. So now things are changing. But because this was one of the reasons why obesity never came to center stage, because there was no funding for obesity. We were always thinking that the treatment remains still lifestyle intervention, nothing beyond. And second thing, there are cultural factors like, Professor Claude Mabani told you that in Africa, people would rather think that they are better off if they look obese. In India also, as we came out of poverty, first thing is people started having good food and less mobility, physical mobility, more mechanization, and they started gaining weight. And the first thing was, if you are, on the overweight side, it shows that you are from an affluent family. So this is like more of a sign of affluence. And these cultural factors also play a very important role in, inertia for managing obesity.
Thank you, all the speakers. We'll conclude the session with a message: eat less, move more. Thank you.
We have a group photo.
I would like to invite our esteemed chairperson and speaker for the session for a group photo. Moving on to our next session of type 1 diabetes mellitus, it's my pleasure to invite our next chairperson to lead the session, Dr. Deepak Dalal, Dr. Meenal Mohit, and Dr. Anushri Mehta.
Very good morning, everyone. So we begin with our third session of the day, type 1 diabetes. And I would like to invite our first speaker, Paula Andrea Diaz Valencia from Colombia. So, Madam is going to talk about Diamond 2 Action, addressing the global landscape of type 1 diabetes. So, ma'am, please be our guest and enlighten us with your session.
Because it's complicated. And more height. Could you hide, please, for me? Good morning. Thank you very much for the kind organizers of this wonderful meeting. This meeting brings hope for all of us. They bring the spirit of that everything is possible. So thank you, really thank you very much. It is an honor to me talk about Diamond 2 Action, addressing the global landscape of type 1 diabetes. I am presenting this presentation on behalf of the Diamond 2 collaboration. This is a wonderful network that I am super glad to show you and to invite you to join us. This presentation is dedicated with consideration and respect for all children's family and people that living with diabetes, and with the certainty that we can together fight the diabetes problem around the world. So this is the kind invitation. I declare any conflict of interest. We will try to pass through this content about a small landscape of the global incidence of type 1 diabetes, a little background, and the most important, what is new, how is moving the agenda forward for the type 1 diabetes, take some actions, and the most important slide will be join, please, our Diamond 2 collaboration network. So what happened with type 1 diabetes? Definitely, type 1 diabetes is like a disease that maybe is very behind of type 2 diabetes, but it's absolutely important. Now is our most frequently common chronic disease for people, for children, for so many persons around the world. So this is very, very important. Also, the insulin, it's absolutely needed for their support, for their life, and this is most supported by the health system and the social systems. And another fact is that this disease is increasing around the world, but is really affecting most people in low-income countries. The global agenda also is in favor of us because, for example, we now are celebrating the first 100 years of the insulin. So we, after the 100 years of insulin, we still have people without treatment, without the opportunity to survive because they don't have insulin, for example, or because the children didn't have the diagnosis. So this is very important for us. Also, the global target is 100 of people with type 1 diabetes must to have access to affordable insulin treatment and blood glucose self-monitoring around the world. So this is very, very special for us. This is just a historical note that was the first note that became as idea, an original idea in 1920s, when really the consignation of the insulin was born. So this is a small piece of paper that has the formula for the survival of so many people, and this is one of our first examples. Teddy Ryder, before, after, and in his 70s, after the treatment of insulin. This is most that we need to celebrate, and we need to really bring for all people around the world. What happened with type 1 diabetes? We know, for example, that mostly type 1 diabetes appear in the childhood, and this is a classic curve of the presentation. It's around between 10 to 14 is the peak that we know. But when we know this is because we really are studying insulin, we are studying type 1 diabetes in this group of age. But what happened after, what happened in the late years of life, maybe there will be a new peak, but we need to study seriously what happened with the type 1 diabetes across the whole life. These were sample of 298 articles or studies around the world, mostly from Diamond, the first Diamond, 114 studies that you can see in the triangles, 88 in squares come from EuroDiab and 28 from IDF. You can see the landscape of all papers until 2015, but this is the fact. The incidence is increasing in so many countries around the world. Even the countries with this very low incidence, the delta, the change is super high. So we need to really pay attention what happened with the incidence around the world. So if incidence is increasing, the prevalence will increasing as well around the world. This was a picture of the publications of type 1 diabetes between the 80s and 2015. You could see that Europe is the most continent with papers in so many dots, that each dot represents one paper or one publication. But if you see the same pictures in another diagram, in 2021, it's more or less the same. There are a lot of papers that are missing. If you can see the great countries, that are great countries means countries without data. So we really need to address this problem. What happened with the situation? What happened with the incidence, the prevalence, the age, the onset of type 1 diabetes? We need really to think about it. So this is one picture of the geographical distribution of type 1 diabetes around the world. You could see the Finland, one of the countries with the highest incidence in the world, but also so many countries that also has the same pictures. Came from the International Diabetes Federation. This is the update of this map. The first map went in 2015. You could see. I will return again. But in 2019 is the same. And if we go today, it's more or less the same. So very few countries are updating their data. Maybe Scotland, and that I remember by now, but really these pictures keep the same pictures since so many years. So this is a fact as well. Type 1 diabetes is missing, the data is missing, the prevalence of diabetes is unknown for the most global population. This happens in 2002. That was the WHO declaration, but now, 20 years later, it's the same. So we need really to think in this situation. What happened with the epidemiology and the distribution of the prevalence and incidence cases? Could you see that high-income countries are the countries with the highest incidence? But what happened with mortality? The deaths are happening right now in the low middle-income countries. So this is something that we need to think, something that we need to address, something that must be changed. It's important.
Also, as we mentioned before, think in type 1 diabetes in adults, this is a sample that type 1 diabetes could appear after the youngest age or years. So you could see, for example, in the squares in the top, in the bottom, 3 countries, Finland, Scotland, Hong Kong, with prevalence or this is the incidence in the late 16th, only 3 countries. So this is something that we must to really address and something that we need to move forward as well. This is more or less the same example. Studies reporting specific antibodies, cell proteins or C-peptides. Only 14 of 7 papers was reporting this kind of antibodies, and you could see in the graph. This is the full paper. So in conclusion, the world is full of people with diabetes. More than 8.7 million of people in the world living with type 1 diabetes. And there are 1.5 million of these young people really living with this very chronic disease. So how can we move forward in the agenda for type 1 diabetes? I invite you to believe in utopias. At the end, we will define utopias by a poet from South America. But I think now is the time to really thank Professor Jaco Tumileto for belief in utopias. He believed in the utopia of really to try to know what happened with the type 1 diabetes in the 90s. And Professor Jaco Tumileto is believing again that we could still try to recover this magnificent idea of Diamond 1. And now the Diamond 2 Action collaboration is born. When it was born? Was born in the main of so many people that believe that it's important to really know what happened with type 1 diabetes. This was a magnificent communication published in Lancet Diabetes Endocrinology in 2003. There was a group of people with the leadership of David Beran from Geneva, the University of Geneva, and with so many colleagues, including Professor Jaco Tumileto, they proposed a plan to improve the global type 1 diabetes epidemiological data. This is the call for try to find real data in type 1 diabetes. So, based in this correspondence in the Lancet Diabetology, they invited a core or group of experts after a presentation and discussion in Dar es Salaam in Africa. That was very important. They finally had a meeting in Geneva in 2023, 15 experts from 11 countries, supported by the several agencies that you can see in the bottom of this slide, joined together to Geneva, and after this important meeting, the Diamond study as Diamond 2 Action collaboration was relaunched. So you can see in the picture so many familiar faces. There are so many people that are dreaming and really believing in this important utopia. So the group was moving forward. Now we have expanding our collaboration. For example, you could see countries like Brazil with Professor Marinés, Professor Duncan, and you could see also another kind of countries that slow by slow that join our network of collaborators around the world. So after this big idea, after our plan, we need to move forward to the actions. What actions are doing now? What are doing now this group? First of all, we are thinking in regional webinars called for in any kind of language. We really aim to tell to the world what happened with Diamond 2 collaboration. Invite all of you
to be our partners, integrate our initiatives, try to move forward in this very important network and really increase our collaborators around the world. So we are trying to do this important action. Then we are trying to disseminate what happened with Diamond 2. We are participating and writing several grants. Some of them were successful, some maybe not, some are waiting, and some of them also are waiting for be writers. So this is our actions. Also participating in conference, this is an example. Thank you for this opportunity to talk about Diamond 2 collaboration in this important meeting in Mumbai, but also in Peru. Next October, we will talk about this important collaboration, and also we will try to integrate the whole region of the Americas. And then there are some sections submitted for several conferences. What are our goals? One of our main goals is to promote research. We believe in the research in several topics. It's important to try to keep and move forward in this important task as a scientific. Also, we would love to support development and maintenance of different kind of topics, like what is the cost effectiveness of health system, including essential supplies, insulin, to improve the life with people with type 1 diabetes, to strengthen also capacity and develop guidelines. Several people want to understand, to study, to move forward in terms of what happened in their type 1 diabetes in their countries, for example, but they need guides. So we are ready to help all these governments or this agency to move in this forward task. Also, advance in advocacy. We believe in advocacy. We believe in the collaboration, in the work together, in the include healthcare providers, governments, stakeholders, to really change the picture of type 1 diabetes around the world. And finally, we would love to advance in the empowerment of people with type 1 diabetes. We believe also in communities and in the strengths of people that want to really change their lives. Our objectives, we would love to promote epidemiological public health and health utilization and health economics research in type 1 diabetes. Also, we love to support capacity building in epidemiological field, public health, and multidisciplinary health services research. Also, we would love to provide relevant information for communities, for decision makers, for everyone that really are involved in type 1 diabetes. And also, we would love to supply the key epidemiological and health care for patients and organizations in type 1 diabetes. Our main components are basically three: the capacity development, the communication and advocacy, and the epidemiological research. Each one with several tasks and goals, but it's for us very important try to understand the data, the real data. It's because of that our first goal in terms of research is try to identify the prevalence and the incidence around the world. So we are defining several methods, but for example, we can use in a modern way the capture-recapture methods, for example, to really understand what happened with the prevalence and incidence around the world, but also several different tasks are involved in trying to identify what happened with the nodular or the most important needs in terms of understand type 1 diabetes around the world. Different variables are also considered. Our data and research has quality standards. Data quality for us is absolutely important, but also security and preservation. Also, we will love to be in line with any regulations of the countries or the propriety, intellectual property. Also, transparency, rights for this intellectual property. Ethical consideration and data accessibility is also considered in our network. So We are working to develop all these standards. The Diamond capacity development is supported by research support, research training, clearinghouse activity, and guidelines. Finally, communication, advocacy, and empowerment, absolutely important for all of us. And then this global collaboration is in line with global initiatives. They are supported by the experience of so many people that really have this compromise and so many strengths. So if you are interested in joining our network, please, you could fill this link, but also you can try to reach all of us and send an email. And what is Utopia for? She is on the horizon. It takes 2 steps closer, she takes 2 more steps away. I walk 10 steps and the horizons move 10 steps further. No matter how much I walk, I will never reach it. What is Utopia for? That is what it's for, walking. So we invite all of you to walk with us all together to really move forward in the type 1 diabetes needs. This was a poem from Eduardo Galeano. It's a poet from Uruguay that I love you so much. And thank you for your attention, and I am ready to answer any question that you have. Thank you very much.
Thank you. Thank you so much, Dr. Paula. That was really very informative. And working on type 1 diabetes is really a challenge, and we all are facing it every day. And your last slide, Utopia, it stands very true. The more we work for it, the more new children come and who are all the more ignorant. So we really need to work for that. With that, I would like you to have your house is open. Any questions from ma'am? Dr. Paula? Maybe we can take up the discussion later. You can have a seat, ma'am. I would request my co-chair, Dr. Dalal, to invite the second speaker.
Good morning, everybody. Now I invite Dr. R.G. Nayak, good friend of mine, for his deliberation on screening, staging, and prevention of type 1 diabetes. And he has done a lot of basic work in autoimmunity in diabetes. Dr. Nayak, please.
Good morning, everyone. Thank you, Dr. Dalal and chairpersons, and I thank the organizers of 11th World Congress of Prevention of Diabetes and Complications for inviting me to present some data on the type 1 diabetes. And we already heard part of some of the stuff maybe overlapping with what you heard in the keynote address by Dr. Dario in the morning, but I think this topic deserves more attention as of today, as we have for the first time therapy available for pre-symptomatic type 1 diabetes. So, as you know, the incidence of type 1 diabetes, we just heard from Dr. Paula, the global incidence of type 1 diabetes, and I'm focusing more on the US statistics, that you know that about 300,000 people in the US are at risk of developing stage 3 of clinical type 1 diabetes, and 64,000 people are diagnosed every year, with almost 40% being in children and adolescents. And the increasing incidence of type 1 is seen across all ethnicities and populations. And what is important to realize is the incidence peaks at between the age of 10 to 14 years. And it is also important to note that the median survival age of people diagnosed with type 1 diabetes at the age of 11 to 15 is 12 years shorter than age-matched children without type 1 diabetes, and this gap even increases the expectancy, the difference in the life expectancy increases to 16 years in people who are diagnosed less than 10 years of age. So it's important to diagnose early and intervene early in the type 1 diabetes disease process. And as you all have experienced, I mean, across the world, this is true, including the US and other countries, the decay is the leading cause of mortality in type 1 diabetes. and 30 to 60% of people with type 1 diabetes present with TKA in the United States, and 200,000 hospital discharges are for the DKA every year. But what is important to note here is that the DKA frequency is 1.5 to 3 times less frequent among the children or siblings of type 1 diabetes. What it means is, if the children and first degree relatives of type 1 diabetes patients are screened early and they are kept under radar and they have an opportunity for early detection and intervention, one could potentially prevent the risk of diabetic ketoacidosis and acute metabolic complications. So this has been proven by multiple studies. I mean, whether you look at the diabetes autoimmunity study in the young at Barbara Davis Center from Denver, Colorado, and environmental determinants of type 1 diabetes, Munich study, DIP study from Finland, and the German study, FR1DA, and Finnish study of Trigger. All these studies, if you look at the settings, the relatives of type 1 diabetes and people who are genetically at risk, and even in the DIP study, it was, or for example, in the German Bavarian study, it was a general population. So when you screen people either with genetic risk or the first degree relatives of type 1 diabetes or even the general population, the DKA rates, as you can see here in the third column, is significantly lower than what is expected or projected DKA rates without screening. Again, it underscores the importance of screening for type 1 diabetes in a people at high risk population is extremely important. So what are the benefits of screening early for type 1 diabetes? One, I showed in the previous couple slides, the risk of ketoacidosis, the frequency of ketoacidosis is obviously lower if you start screening the population very early. And it also provides an opportunity to deploy therapies and strategies that are intended to impact the disease progression. We can slow down the disease progression if you intervene early. And third, it provides more time to develop glycemic management skills if the population who are at risk were to develop type 1 diabetes. And it also provides an opportunity to participate in research initiatives through TrialNet and JDRF, which is more relevant in the US, to benefit from these ongoing clinical trials. By now, all of you are familiar with the fact that type 1 diabetes is a progressive T-cell mediated beta cell destruction, an autoimmune condition, involved loss of beta cells over the 3 stages. There is a pre-stage 1 diabetes where people who are genetically at risk of type 1 diabetes, there is an environmental trigger such as an infection may trigger the autoimmune diabetes disease process in the context of predisposing genetic background, that is pre-stage 1 diabetes. There could be no autoantibodies or maybe at the most one autoantibody developing. Then one moves to a stage 1 of type 1 diabetes where there are documentation of 2 autoantibodies, but the beta cell function is well preserved to maintain normoglycemia. In the stage 2 of type 1 diabetes, in addition to continued presence of 2 or more autoantibodies, there is dysglycemia as defined on the right side with a fasting glucose of 100 to 125 or 2-hour postprandial glucose during OGTT of 140 to 199 or A1C of 5.7 to 6.4. These are pretty much the standard definitions used all over the world for diagnosing impaired fasting glucose, impaired glucose tolerance, and pre-diabetes. And stage 3, beta cell function is further reduced, leading to consistently elevated blood glucose levels and the need for exogenous insulin, and clinical symptoms of the typical hyperosmolar symptoms, weight loss and risk of ketoacidosis, all those will start showing up. And antibodies generally are present at the early stages of diagnosis, but antibodies may disappear as the natural history of type 1 diabetes progresses. So what are those autoantibodies? The autoantibodies against the following beta cell antigens have been developed, and these are used as markers in early diagnosis of type 1 diabetes. Glutamic acid decarboxylase 65, as you can see here on the secretory vesicles, insulinoma associated antigen 2, and zinc transporter 8, insulin antibody and islet cell autoantigen. So the number of antibodies has been shown to be predictive of the disease. greater the number of autoantibody positivity, larger of the clustering of type 1 diabetes autoantibody markers, greater the risk of progression to type 1 clinical stage 3 diabetes. But there is no predictive ability ascribed to the order of appearance of antibodies. It's not that if one antibody appears sooner, the risk is higher, but it is actually the number and clustering of autoantibodies that actually determines the rate of progression and risk. And when do these antibodies develop? Data from German baby diab study showed that the seroconversion or the detection of autoantibodies happens between 9 months to 2 years, here as you can see here. So people who are genetically at risk, if you measure their autoantibody profile, whether it is insulin, GAD, IA2A or zinc transporter antibodies, between 9 months to 2 years is a time point where the major seroconversion happens. And the similar results were observed in another longitudinal study, TEDdy study of newborn with genetically at risk of type 1, where autoantibodies appeared and peaked at around 9 months of age. But contrary to that, the diagnosis of type 1 diabetes occurs much later between the age of 10 to 14 years. What it means is that the seroconversion happens between 9 months to 2 years of age. That means 2 years is a time point where you can detect presence of autoantibodies in a significant number of people who are genetically at risk, and by the time they get to 10 to 11 years or 14 years, there is a peak incidence of type 1 diabetes. That means it offers a window of opportunity of almost a decade where one has an ability to intervene and prevent the progression or at least delay the progression of this disease process. And this is applicable both in the male and female population. And as I said, the autoantibodies have a predictive value in when the patients will develop stage 3 of type 1 diabetes. If you have got 2 autoantibody positivity, by 5 years there is a 44% chance of developing stage 3, and this goes up to 70% by 10 years and almost close to 100% or 84% by 15 years. And if on top of autoantibody, here I showed the data of autoantibodies without considering the dysglycemia. But when somebody moves to the stage of stage 2 with dysglycemia, by 4 years from the time of stage 2, there is 75% chance of developing clinical diabetes. And now with all this information that has been developed over the decades, ADA's 2024 or 23 actually, it came into classification that the 3 stages of type 1 diabetes, stage 1 and stage 2 and stage 3, have been well defined and are recognized as part of the natural history of progression and classification of type 1. So ADA recommends screening for type 1 diabetes risks, measuring islet antibodies in the relatives of those with type 1 diabetes, and in children from the general population can effectively identify those people who develop type 1 diabetes. Personal and family history of allergic disease and other autoimmune diseases increases the risk of autoimmune diabetes compared to the general population. And when multiple antibodies are identified, 2 or more, testing for dysglycemia can be used to further forecast a near-term risk. As I said here, that could be 74% in 4 years. And the criteria to diagnose dysglycemia, we have already covered this, impaired fasting glucose, impaired glucose tolerance, and A1C based criteria for pre-diabetes. And based on the presence and number of autoantibodies, what should be the next step? If you do the screening, you identify 1 antibody or 2 antibodies, so what do we do next? There is no clearly evidence-based consensus guidelines that have been developed as yet, but what we have today, there is no evidence-based guideline developed, but the consensus expert opinions clearly show this is the best we can do at this point in time. One of the publication was referred in the morning from the Diabetes Care publication about recommendation for antibody screening in type 1, and this is another publication published about few months ago. So who should be screened? People with family history of type 1 diabetes, personal and family history of autoimmune diabetes, and screening can begin as early as 2 years of age. And there could be variety of modes to screen the population, and children without personal and family history of autoimmune diabetes, repeat screening at any age if the symptoms were to develop, and children with personal and family history of autoimmune diabetes, repeat screening every 3 years until the age of 18 years, and adults no additional screening required, and people with one antibody positivity, again the guidelines differ for children and adults, and 2 and more antibody positivity, they require more close monitoring of oral glucose tolerance test and A1C monitoring, etc. going forward, because the risk of near-term progression is significantly higher. We all know that given the longer half-life and constant rate of clearance, C-peptide can be used as a surrogate marker of endogenous insulin reserve. And as you can see on the right side, average oral glucose tolerance test C-peptide area under the curve, there is a window of rapid C-peptide decline few months preceding the diagnosis of stage 3 of type 1 diabetes and subsequently thereafter. So stimulated C-peptide levels decline in the months before and after the stage 3 of diagnosis, hence preserving the beta cell function is extremely important. And younger the age of onset, we know that greater and more rapid the decline in the C-peptide. Why I'm harping on C-peptide is C-peptide preservation is an important consideration in intervention in type 1 diabetes immune therapies. Greater the degree of C-peptide, more the endogenous insulin reserve, greater the long-term metabolic control and decreased glycemic variability in the long term, which in turn is associated both with hypo and hyperglycemic complications. Here it can clearly see here that when you classify with the C-peptide measured in an untimed blood sample, with the people with the lowest C-peptide group marked in red, the frequency of serious hypoglycemic events and frequency of retinopathy was significantly higher compared to people who had preserved a C-peptide. So early intervention is to preserve the residual beta cell function and reduce the long-term metabolic risk in type 1 diabetes. With this background, we have one therapy that has been approved in November 2022 by US FDA, humanized monoclonal non-FC receptor binding antibody anti-CD3 teplizumab, also sold by the brand name called Tzield, is approved for use in stage 2 of type 1 diabetes. And the seminal publication came from Kevin Herold's group from Yale. It was a phase 2 study, randomized placebo-controlled double-blind study, and this was the pivotal study to get an approval for teplizumab for early intervention in stage 2 of type 1 diabetes. And here, relatives of patients with type 1 diabetes with dysglycemia and presence of 2 antibodies were randomized to teplizumab, 44 patients, and 32 patients were randomized to placebo, and they had oral glucose tolerance at 3 months, 6 months, and then every 6 months. And the primary outcome was development of type 1 diabetes in this, and secondary outcome was number of patients with adverse events between the baseline visit and the diagnosis of type 1. The median time to develop type 1 diabetes in the teplizumab group was 48 months, whereas in placebo was 24 months. That means there was clearly a 24-month delay in the development of type 1 diabetes, and the stage 3 of type 1 was diagnosed in 43% of teplizumab group and 72% of those treated with placebo. Although one may ask a question, eventually people who develop type 1 stage 3 diabetes, what's the big deal of using the treatment? The purpose of treatment, even any delay of few months to few years, helps preserve the endogenous beta cell function, C-peptide preservation, and that would translate into long-term better metabolic control and reduction in the risk of complications. The treatment we need to always weigh into the risk-benefit assessment and the side effect profile. And here you can see here lymphopenia was seen in 73% of patients, rash, and 2% of people demonstrated cytokine-mediated syndrome. But most of these side effects were transient, they resolved, the most important being lymphopenia. It is a teplizumab, for those who are not clear about the infusion protocol, it's a 14-day infusion administered every day consecutive 14 days. The drop in lymphocyte counts can happen between 4 and 5 days, but by 45 days, the lymphocyte counts came back to normal baseline. Although the study had several limitations, but the fact remains that this was one of the first studies that clearly demonstrated that the disease process can be modulated successfully in a clinically meaningful way to prevent the development of stage 3 of type 1 diabetes. A follow-up analysis of the TrialNet 10 study, which was a phase 2 study that I just referred to, showed that not only there was a delay in development of type 1 diabetes, but there was also preservation of beta cell function. As you can see, at 12 months, the difference in the C-peptide levels were statistically and clinically significantly different in the teplizumab treated group versus the placebo group. Subsequently, the studies were conducted with teplizumab in patients with stage 3, newly diagnosed stage 3 of type 1 diabetes. And this was a study that combined the data. It's a pool data of, say, as you can see here, 5 studies of stage 3 of type 1 diabetes, teplizumab 375 and control group of 234, showed that across stage 2 and stage 3 of type 1 diabetes, 1500 patient years of exposure or follow-up, adverse events of lymphopenia, rash, and headaches were observed, and most occurred immediately after the infusion following the dosing and resolved without intervention, and it consistently preserved the beta cell function as measured by C-peptide with a safety profile that was characterized by self-limited adverse events. And here you can see the data of the mean 1-year C-peptide area under the curve across the 5 phase 3 studies that clearly show the difference in the C-peptide between the teplizumab group versus control, and the mean 1-year insulin use across the 5 studies was again statistically significantly different between the teplizumab and the placebo group. So it was concluded that the integrated analysis to determine whether the effect of teplizumab were consistent across multiple studies, where the C-peptide preservation and safety events were similar across the groups, compared to placebo or standard of care, teplizumab significantly preserved the beta cell function as measured by C-peptide, which is, as we talked about multiple times, a measure of endogenous insulin production that led to a significantly lower use of exogenous insulin, and it can protect and preserve the beta cell function, which is anticipated to affect both short and long-term complications. And again, this particular study showed residual beta cell function was associated with a better, even CGM-derived metrics and a lower daily insulin dose. So there is a lot of data that is supporting that early intervention in stage 2 or even stage 1 of type 1 diabetes can help preserve the beta cell function, can maintain a better long-term metabolic control, and which would eventually translate into lesser glycemic variability and reduction in the risk of chronic complications. So we don't have a treatment that can prevent type 1 or avoid type 1 diabetes completely, but any preservation of beta cell function, any delay in the diagnosis, I think goes a long way in maintaining a good quality of life in type 1 diabetes. To summarize, type 1 diabetes is an autoimmune condition affecting children, adolescents, and adults, characterized by 3 stages of progression of T cell mediated beta cell damage, and presence of 2 or more autoantibodies constitute the diagnosis of early stage 1, and nearly everyone who tests positive for 2 antibodies will progress to stage 3 of type 1 diabetes, and screening and early detection will minimize the risk of ketoacidosis, empower the healthcare providers and people with diabetes and caregivers, and provides an opportunity to delay the progression of treatment. A lot of research is still going on, whether you can give 2 courses of teplizumab, whether you can combine teplizumab with other immune interventions, how soon can we intervene without increasing the side effect profile. All these need to be kept in mind, and there is a lot of work still to be done. Thank you so much for the opportunity.
Thank you, Dr. Naik, for this presentation, and it was very informative.
Now over to our next speaker, Dr. Parthakar. He's a national specialty advisor for diabetes in the NHS. He's graduated from Kolkata, India, and works as a consultant in diabetes and endocrinology at Portsmouth Hospitals. His national work in diabetes care has enabled the highest uptake of CGM in the type 1 diabetes population globally, as well as opening the widest access to hybrid closed loops in any healthcare system. He has also led in improving A1C levels across the T1D population in England and improving outcomes in pregnancy in type 1 diabetes. His other work has involved digital self-management platforms, championing language matters, as well as co-creator of type 1 diabetes comic. He writes a monthly blog for the British Medical Journal and has been recognized as one of the most influential figures from the ethnic minority population across healthcare in the UK for 4 consecutive years. He has received an OB for his services to diabetes care in 2021, and he has recently joined JDRF as a clinical ambassador to work with Indian colleagues on diabetes care. He is also an elected councillor in the Royal College of Physicians, London. So I was going to talk about type 1 diabetes index. Over to you.
Thank you very much. Thank you very much for the invite. I also need to remind myself to send a smaller CV. So that's always very helpful during these talks. So, first of all, I'm going to talk a little bit different. You've heard two absolutely amazing talks. You talked about the general landscape, and it shows the variation we have around the world when we talk about type 1 diabetes, right? We also have heard about what the future is, and there's a lot of excitement around immunotherapy, a lot of discussions going on around the UK right now. How do you screen population? What about the anxiety levels? Is teplizumab the thing? What will happen? Lots of things. I'm going to slightly change tack. I'm going to talk about type 1 diabetes in India. So my first question to anybody in the audience is, does anybody have type 1 diabetes in the audience? Anybody with type 1? One person. Okay, so does anybody know what happens if you got type 1 diabetes and you live in India? What do you think happens, ma'am? So there's a big difference between the India I left behind in 1999 and the India of today. Do you know what's the big difference? There's only one similarity left. So I left in 1999. The only similarity is Shah Rukh Khan. He was doing great movies in 99, he's still doing great movies now. But beyond that, India is a completely different country. There are two Indias at the moment. An India which can afford everything. It can put a rocket on the moon. And an India which struggles also to fund insulin and glucose strips. That's the two sides of India that we have at the present moment. And that's the challenge we all have, is how do you bridge that gap? So how is type 1 diabetes care in India? Well, it depends on your ability to pay. I've got colleagues who I know in type 1 diabetes who are on artificial systems, pancreas, doing amazingly well. And I've also been to places where you met people like Swami from the south or Archana and other people who are struggling to just get people their insulin and basic needs. So that's that. So let me talk a little bit about the T1D index, which is the first piece of work. It's not perfect, but it gives us some idea what's happening in India. It's a first of its kind tool. It's a website out there. You can have a look. You can have a look depending on different countries, what's happening in type 1 diabetes. So this was based on a bit of a modeling study, global incidence, prevalence and mortality of type 1 diabetes in 2021 with a projection to 2040. Here's the paper. That's the website. You can have a look and you can understand where we are, and whatever country you're in, you can put the country in and have a look what things are at. How do we get the numbers? You feed in 400 plus studies, you repeat every year for each country, you estimate the new cases, and thereby the T1D index is created, and then look at the estimated all-cause diabetes mortality. But here's the big thing of India across the board. If you live in India and you've got type 1 diabetes, compared to a global situation, you lose about 28.7 years of your life. That's what you do. Okay? And that doesn't take into account the people who will do very well because of their level of wealth and what they can afford and see absolute superstars in type 1 diabetes care. We're talking across the board in villages, rural areas. The bottom line across the country, that's what you lose compared to you being, let's say, in any other sort of European country or highly developed countries where you talk around. Okay. How does India compare? Here's the comparison to different countries. You can see Brazil, Russia, France, United Kingdom, Germany, United States. Okay. So as mentioned, I look after the whole diabetes sort of service, especially type 1 diabetes and everything in the UK. So UK now has gone up from 67 to 72. Do you know why that's happened? We didn't do anything dramatic. We just managed to give everybody with type 1 access to a continuous glucose monitor. So they lived with their type 1 diabetes better. It was not due to clinicians. Because I fundamentally believe type 1 diabetes is fundamentally about self-management. If you give people the right tools to live, they will do better. That's the sort of fundamental philosophy behind it. So that's where we have the differences. Obviously, you can see Sudan, you can see India, China, you can see the numbers. And that's the issue that we have. But why does India look like this? But here is some breakdown. As you can see, and we talked a little bit about the differing India. You have at the extreme end, the people who can fund their pumps and CGM. And we know people like that in metros and stuff, depending on their family. You have people who've got insulin strips and self-management, ration premix, feed tests, and people no care, non-diagnosed. So you still have today people in India who will diagnose with type 1 diabetes and simply, for want of a better word, die. Because there's no insulin. or somebody hasn't recognized it, right? So one of the things that a lot of people, and some people are involved in the audience here, are trying to do with different governments in different spaces is access to simple things like basal bolus insulin and glucose strips. A lot of people are working hard throughout the country just to do the basics right. That doesn't stop the work that's going on with AID, immunotherapy, everything. There's no need to stop progress, but there is a need to bring up everything else from the baseline. And that's the work that's happening. There are some great sessions that's happened. Some of the work being done by Sujoy Ghosh in Bengal. You got Archana working in Aurangabad. You got Swami in the south of India. You got loads of people are trying to put in their efforts to try and bring things together, which is good. But when we talk about India, which I've just shown you, where if you've got type 1 diabetes, you've got 28 years less. This is also India, as I was saying. So people always say that you come from the UK, which is a very rich country. Well, funnily enough, economically, India is actually ahead of India. So I think people need to stop calling me, I come from a rich country. You call from a rich country as well. It just needs to be distributed better, right? This is also the country, as I said, which can put a rocket on the moon. This is also a country which has done the fastest rollout of 5G around the world. You've also got a country which has got one of the richest person in the whole world, right? As I said, the only common factor between me leaving and me still being back. So this is also the same India, right? Where India has done all of this and is seen as a shining light in many countries because of the progress it makes on the railways, everything like that. But this is also the same country where I've just given the example. If you've got type 1 across the board, you lose 28 years of your life. That's the gap which we all should be closing. But this is also that other side of India. I just wanted to showcase one particular person, and I could showcase a lot of people. This is what this guy is doing in the Idangal Charitable Trust in the south of India, Swami. Look at that. 2,000 underprivileged children, adoption of government hospitals across states, free glucometers, 100 strips per month. And this guy is absolutely working flat out with their local government, charities, patients to change things. Look at that. All these little kids, underprivileged, he's been absolutely changing lives. And that is what we need. If you haven't had the opportunity, I would really suggest you listen to people like Archana or Sujoy to see what they're doing, where they're trying to close exactly that gap. And I'm not naming, obviously, a lot of people. Meenal herself on stage, all the work that's going on from different quarters is very encouraging. What we need to do as a country is come together to do that. So let me give you an example of that. Think as an example. BD mix insulin in type 1 diabetes. That makes literally no sense. Literally no sense. So when people go like, we can't afford it, I think we can. You can afford basal bolus. You absolutely need to train ourselves up and be confident about basal bolus. That basal bolus insulin makes your lifespan longer in type 1 diabetes. It's a fundamental thing. If you want to look at step changes in type 1 diabetes care, well, first of all, is give them insulin. Without them, they die. Then you move them from BD mix to basal bolus. Then basal bolus you need added on to CGM, and then you can get past to AID. That's the sort of philosophy around the world. BD mix should not be an acceptable means of doing so anymore, not in today's India. The fundamental has to be basal bolus insulin and access to strips. Why are we still doing it? International guidelines don't suggest so. Even the recent Indian guidelines don't suggest so. So why are we still doing BD mix? We all also do type 2 diabetes care. Nobody's sitting here in type 2 diabetes care and go like, do you know what I really like? Metformin and gliclazide only. That's all I do. No, you're all talking about SGLT2s, GLP-1s as you appropriately should. So should be the same for type 1 diabetes. BD mix is a thing of the past. Has to be basal bolus. If you're not sure about it, learn about it. There's nothing wrong in putting your hand up, and the professional development is also the ages. In the country that I am, we always have people coming around and saying that, oh, I'm a bit unsure about learning about technology. No problem, learn about it. That's what our lives are. You learn at all ages. So if you're not sure about learning about a BD mix, come to sessions, come to some of the stuff that Meenal asks, we're all organizing in Jaipur at the end of the year. Come and learn. Come and sit down, come and ask questions. There is nothing wrong in saying, I don't know enough about it. So when you say, and there's another reason people say, oh, well, people like to have 2 injections a day. Well, of course they do. If it depends on how you put it across to them. If you say to people, they would rather have no injections, right? So when you're debating with somebody with type 1, why should the debate be, do you want 2 injections or 4? But there's nobody sane in the world who's going to say, do you know what, no, 4 is good. Well, why didn't you then say to them, do you want one? And just give them background and forget about it. Why didn't you say, let's not give you any injections, let's give you best of luck and see what happens? We don't say that because that's unsafe. Similarly, if you say to somebody, if you had 2 injections, this is the outcomes you will get. If you get 4, this is where you will get to. I think lots of parents and lots of patients will choose what's right for them. Of course, people will like lesser injections, but that doesn't mean no injections either. So why in India should it be? And I don't think it should be any reason for it. As I keep on saying, I think we should absolutely forget the notion about India being a country which is still catching up. India is here right now. I showed you plenty of examples. You can't be proud of India on one hand and then turn around and say, hey, type 1 diabetes. Nope. You absolutely need to be on the front foot. And there's no reason you can't. Easier for whom, being on BD Mix? Is it for us as clinicians because it's easier to do? And it's something that is convenient, or is it easier for the person concerned? And why settle for second best? And I don't think we should. So, supporting all these efforts to change, these are the things that are happening across the country. You may or may not be aware of it. We have been working with different state governments, Madhya Pradesh, Tamil Nadu, West Bengal, and we're starting to spread it across. The fundamental thing is working with governments to increase funding for basal bolus insulin and getting strips, and education of professionals. That's what we're working at. As I said, that 28-year gap, I don't think is an acceptable gap to hold. So I'm not going to spend time on it, but these are the challenges throughout the lived experience people go through, and I think it's very important to recognize that. But I think I'm just going to share some of the work that is happening. There's an implementation plan. We are working with the Clinton Foundation, UNICEF, and Breakthrough Type 1 Diabetes, everybody together along with sectors of the government. And the idea is we have started with these states which are colored out, and basic simple principle: education, basal bolus insulin, glucose strips, and working towards it. And as I said, my job here is to come around and challenge everybody. 2024, 4 injections a day is not just a afterthought. That's how it should be. So I'm going to ask you a question at this point of time. Let's say your most loved one, whoever it is, your mother, your father, your child, your daughter, your son, it could also be your mother-in-law, depending on your love for your mother-in-law, develops type 1 diabetes. Would you like them to have the best possible treatment, or something that could just be lesser? And the answer to that should be that it shouldn't be lesser to anybody else. And if that's the case, that's what I think people with type 1 diabetes need to have. So as I said, those are the states we are working with. And the ambition is to make basal bolus a standard treatment across the country. We want to make peer support, so access. We've got a big group of developing people with type 1 diabetes. We had somebody with type 1 diabetes just speak in the last session, talking about their lives, talking about the challenges they face. It's not easy. And I think in the last talk, you heard a little bit about immunotherapy. The conversation that are happening with the people with type 1 diabetes and their families is critical to how it rolls out. So there will be parents saying that, I'm not sure I want to know if my child will get type 1. What am I supposed to do with that information? There'll be parents going, I really want to know. So it depends as to how you're going to give it to them. That conversation needs to happen. And similarly, what I always say as clinicians, you can only see people for only such a period of time. So peer support is very important to support each other. We are building an information portal and education in different languages to try and help as much as possible in the government sector. And models of care and evidence. Once again, I'd like you to have a look. For example, Dr. Ghosh is working in West Bengal. He's now spread it across to about 16 districts out of 28. And the data that's coming through on basal bolus insulin and strips is quite amazing. The drop in DKA rates, the drop in HbA1c, the improvement in quality of life, what parents are saying, what can be done with education from the state sector. So finally, I think I always will say this, and I always will believe this. A country which can put a rocket on the moon can certainly give the best care to those with type 1 diabetes. We can have a bigger debate about, is AID affordable to everybody? I don't think it is yet. But glucose strips and basal bolus insulin, 110%. That we can definitely afford as a country. Never settle for second best, and I don't think that's an India we want to be proud of. We all, quite rightly, India, are very proud to be Indians, and quite rightly, we talk about how powerful we are. Probably we should win a bit more Olympic gold medals, in fairness. But apart from that, I think we're doing really well, and I think that should reflect to our health system and should reflect in type 1 diabetes care. So let's try and change the statistic, is what I always say in this particular. We would love to have that 28 here disappear to 15, and then 10, and make it at par. So this is a big group of people. We're all working together. These are pictures of all of us getting together, clinicians, people living with type 1 diabetes, lots of people trying to do the right thing, trying to get people together, trying to build policies, and as I said, across government sectors. And I hopefully you come to these sessions, and if you want to take away something, I always say take away that message which I said, is that in India, if your child had type 1 diabetes today, and he didn't have the support or the wealth behind you, your child will lose 28 years of their life. Now that's a statistic that cannot be acceptable and which you must work to change. So I'll finish it there. That's the website if anybody wanted to have a look at some of the work that's been done about that. But it's about trying to sort of change the narrative around what we can do. So type 1 diabetes is a condition which is what it is. It's not brought on by anything per se, but I think we can do better in trying to improve their lives and helping a lot of parents and children and kids to live a completely healthy life as much. We have got patients who've got type 1 diabetes for 60 years, 70 years, doing well. And there's no reason we can't have the same narrative rather than saying, you got type 1 diabetes, so not quite sure where your life goes now. So I'll leave it there, and thank you very much for the opportunity to everybody for asking me to come around and speak. It's always very much appreciated. So thank you, and I can take any questions. Thank you.
So that was really wonderful hearing from you, Dr. Partha. And as Dr. Partha rightly said, we will be doing our second annual Type 1 meet at Jaipur closely in association with Dr. Partha, of course, Dr. Bansi, Dr. Archana, and myself. And as we all know, Dr. Partha is the force behind every type 1 child on pump is his ambition, and his present, I think, he's already done it, he's achieved it. And if you can go through his blogs and his Facebook account, you will find the testimonials, his patients and the children with type 1 really love him, adore him, I should say. So Dr. Partha will be there at Jaipur.
Please, first of all, सर तो मैं हूं नहीं, सर तो मत ही बोलिए. Better.
Completely reversible.
So the question is type 1 or type 2 completely reversible? So type 1, the answer is no. There's a lot of research going on to see whether it can be switched, the signals, very much in research and experimental stage. Nothing has been shown which can cure it or reverse it. Type 2 diabetes, I would say, very much depends on the individual and about sustainability. But if you look at the evidence base in type 2 diabetes, if you look at some of the studies done with the direct study and everything, it is possible in some cases. The issue is whether you can continue that, right? It's the sustainability of that, because you're asking people to change their calorie intake, whether it's carbs, calories, fats, whatever it is. That is the challenge. So yes is the short answer. It's possible in type 2, not in type 1.
Thank you.
Pleasure.
But still, I think the right word would be that type 2 is in remission rather than reversible.
Yeah, I mean, I think there is a problem with the terminology, and I'll give you one statistic on that. So what we have seen in the UK, which has been a big country of reversal, remission and all that, is that the people who were told they were in remission, they stopped all their tablets, okay? And the problem is they stopped their antihypertensive and anti-lipids as well. So that group now has got more cardiovascular events. Not because, so they are thinking, well, my diabetes is gone, everything is gone. And that's been a big problem. So we now got data spiking that the people who have gone into remission reversal has got more cardiovascular events. That's not because of the science, it's because they just stopped all their tablets. So I think the terminology needs to be absolutely spot on. What are we saying to people? We are saying, look, it's a bit like, I think what we are trying to do is make it like a bit like cancer. We were saying, yes, it's gone into remission, but please be aware you need to have all your checks done. It might all come back. So I think that's the terminology that people are doing. So but nobody's nailed it yet.
Simple terminology will be post-diabetes without tablet.
Yes.
Post-diabetes, meaning my diabetes was there once upon a time.
Diet and lifestyle.
Right. And now lifestyle, diet and checking continues, and rest of the thing remains as it is.
So thank you very much, Dr. Partha, for
Thank
being
you.
here.
Thank you.
Any more queries that we need to know from Dr. Partha, we can ask regarding type 1 or type 2, of course, but being very relevant to the session, let's keep it to type 1. So we can close the session if we don't have any more queries. Thank you, everyone.
So I would like to invite our esteemed chairperson and speaker for a photo session. We'll take a few minutes before we move on to our next session. Moving on to the ID of Joseph VIII Memorial Lecture, I would like to invite the chairperson, Professor Yako, Dr. Peter Schwartz, and Professor Shashank Joshi, sir.
Dear ladies and gentlemen, we come now to one of the, I must say, most exciting and most continuous part of the World Congress of Diabetes Prevention. It is a very cool meeting to be here and sitting in the sessions, but also discussing with all of you outside. This is innovation in diabetes care. This is passion for diabetes, and this helps to become a barrier against diabetes. Now we have the Joseph Hood Memorial Lecture, and Joseph Hood was one of the frontiers in the field, and we want to use this moment to honor one of the existing frontiers in diabetes prevention. But to introduce this in detail, I feel honored that together with Professor Jaakko Tuomelato, also one of the frontiers in diabetes care, and Professor Shashank Joshi, who is one of the frontiers in diabetes care in India, we are here to chair this session. And I just see that Banshi is also here. You are replacing Shashank, so from India to India. But we have to listen. Joseph Hood and the Joseph Hood Memorial Lecture, what does it mean? And it's a great honor to ask Professor Tuomelato to give some insights into the history of the Joseph Hood Memorial Lecture.
Yeah, thank you very much. Joseph Hood was a very important person in the field of diabetes. He especially was concentrated in the maternal effects on development of diabetes, and he was one of the persons who early on identified already the importance of intrauterine environment and risk of diabetes. He did a lot of studies. Mainly, he was doing the experimental studies, but also human studies as well. Now, Joseph Hood was a person who was a founder of the European Association of a Study of Diabetes, and later on he was a president of IDF as well. When we planned the first the Congress of WPCD, Joe Hood joined the organizers, and then we had a second meeting in Rome, 1999, and for the planning of that meeting, Joseph played a very important role. And unfortunately, just 2 weeks or 3 weeks before the meeting, he passed away. He was very active, healthy, and suddenly gone. That was a big loss to diabetes field and also to us in planning the prevention congresses. Now then, we quickly decided that we will make a memorial lecture in memory of Joseph Hood. And the first lecturer in Rome was Nick Hales from Cambridge, who also was very much involved in the research work with David Parker of a low birth weight and the risk of chronic diseases, including diabetes. So it was very pertinent to invite Nick Hales to have the first time the lecture. Later on, we had several important people who have been giving the lecture, and Joseph Hood Memorial Lecture at the Prevention Congresses. And this year, we have a great pleasure to have a person who has been nominated for this special lecture, and he is Professor Pablo Asner from Bogota, Colombia. And Pablo's CV includes many important points. He has been very active internationally in the field of diabetes and both epidemiology, prevention, and the clinical management of diabetes. He has been leading the Latin American diabetes epidemiology group for a long time, and also been very much involved in the ALAD, which is a Latin American Diabetes Association. And he is an endocrinologist and a clinical epidemiologist and professor of endocrinology of Javeriana University in Bogota. He has done many research works and many collaborations around the world, and also working as a scientific director of a Colombian Diabetes Association. So, Pablo, it's a great pleasure to invite you to give this special lecture. Thank you so much for coming.
Well, thank you, Jaco and Peter and all the organizers of this meeting. It has been a wonderful meeting. I feel really honored to have been selected for this lecture. I know it's a selection made by my peers, so that makes it even more honorable for me. So I hope it will generate some discussion and make us think about how to put this primary prevention of diabetes into practice. I have no conflicts of interest for this presentation. And I want to start by pointing out that the prevalence of impaired glucose tolerance, which we will see is the main target of primary prevention, is quite high in the world. In fact, if you see the prevalence and the number of people with impaired glucose tolerance around the world, and particularly in medium and low income countries, it's huge. And it's actually equal or higher than people with diabetes. So that means that for each person with diabetes, there's somebody waiting to become, if one might say, diabetic in the near future. So it's a huge task that we have ahead of us, particularly in medium and low income countries. I was trying to think how to describe what we call real life compared with ideal life. And yesterday they gave us a nice picture which showed what I would call ideal life, which is actually what as we refer the randomized clinical trials. They are the utmost proof of the effectiveness and safety of any intervention, including primary prevention. So the randomized clinical trials are the proof of concept and have been in primary prevention. We know from the works of the DPS, the DPP, the Indian DPP, how evidence has shown that it's feasible to prevent diabetes. There is a proof of concept, but usually they are done in a selected population with sometimes tight inclusion and exclusion criteria. They are randomized. That's the basis of the clinical trial. This follow-up is as strict as possible, and the outcomes are as specific as possible. So I would say it's like a Bollywood movie. In contrast with real life, represented in the picture they gave us by the Mumbai traffic, but I would say that it applies to many of our big cities. In real world, in real life, studies are not randomized clinical trials. They are usually quasi-experimental, pragmatic implementation trials. We need to do translation, transculturization. We try to get as many people as possible without too many exclusion and inclusion criteria. We do a follow-up as best as possible, whatever is feasible. We use outcomes, usually short-term or medium-term, difficult to do them long-term, and we're looking for the best scenario. So I would say that that's the difference between ideal life studies and real life, or what we usually call real world. So this is one of the meta-analyses that has been done on both randomized clinical trials and non-randomized clinical trials. We're analyzing the different interventions and the efficacy in terms of reducing the incidence of diabetes, which is the column to the right. And you can see that even that's good for Colombia, my country, but also here for Kerala and other places, that coffee can also prevent diabetes. But in fact, the best effect is that related to diet and physical activity in different ways as the best intervention to prevent diabetes. And what is the main component of that successful lifestyle intervention? What's what really drives the effect on reducing the incidence of diabetes? Well, this is a graph presented by Venkat recently in a seminar we had, showing that in fact you look at the blue line, which is what you would expect as the annual incidence of diabetes in people with increasing BMI, and in green you see what the change you can get by intervening intervening with lifestyle changes. And it seems that all is related to loss of weight loss. And you can see there that the bigger the loss, the bigger the weight change, the lower the incidence of diabetes at different BMIs. This was shown in most clinical trials. This is from the DPP, where you can see again that the incidence to the left is related to the change in weight from baseline. So the greater the change, the lower the incidence. And that point there is the mean weight loss in an average of 3.2 years. And their conclusion is that if you lose around 5 kilos or more, that would account for around 55% of the reduction in the risk of diabetes in the during the duration of the DPP, which was a mean of 3.2 years. And this 5 kilos has been selected or defined as the main target, the minimum target in any prevention strategy. Try to get people to lose at least 5 kilos. And what has been achieved in pragmatic lifestyle interventions in real life? Well, this is a meta-analysis of more than 5,000 participants, where you can see that the mean weight change in 1 year is around 2 kilos. It's quite modest, 2.1 kilos. This is another meta-analysis where they actually stratified by who led the intervention, whether they were medical and allied health professionals, or lay community members, or even by electronic technical intervention, like Ramu showed this morning, and they all work. And here it's more optimistical. The mean weight loss was around 3.9. That means 4 kilos, not up to 5, but almost. And that it's a mean, so there's a range. And apparently all the strategies, whoever led the intervention, they work. In fact, this is a meta-regression analysis where, again, you can see that the diabetes risk is related to the weight loss. And this is a meta-regression of studies, not randomized clinical studies, but studies also doing translational interventions in different parts of the world. Actually, they calculated that for each kilo loss, it was associated with a 43% lower diabetes risk. So again, losing weight is probably the main driver of reduced risk of diabetes in these lifestyle intervention studies. When analysis was limited to randomized clinical trials, that means ideal life, well, the risk reduction was around 29%, with an absolute risk reduction of 3%, which means a number needed to treat of 33, which is quite reasonable. Are all the people with intermediate hypoglycemia or pre-diabetes, as it's also called, respond equally to lifestyle changes? Well, this is an interesting study done actually here in India, the DECLIP study, where they actually did a translational trial, community-based, in Chennai, and they selected people with isolated IGT, with isolated IFG, and with both. And they actually did it in a stepwise manner, where people who had both IFG or IGT plus IGT, or IFG plus an HbA1c above 5.7%, they were given metformin. But actually, although 72% required metformin, the real fact was that only 54% received metformin. And you can see that the intervention was successful, 32% reduction in diabetes. But what I want to show you is that they analyzed whether it was the same depending on the type of diabetes. And you can see that those who had impaired fasting glucose had a lower reduction of the incidence of diabetes. That means that it didn't work so well in people who had IFG compared with IGT or both. It was not in neither case was it statistically significant, but anyway, you can see that the result is less in people with IFG. Also, here HbA1c with between 5.7 and 6.4 had also a lower result compared with above 6.5, but obviously above 6.5, that's already diabetes. So in this other meta-analysis of individual participants, it shows the same idea that the interventions on dietary and physical activity work less in people with IFG. And you can see there that it wasn't significant, while on those people with IGT, it was significant and higher, 35% reduction in the incidence of diabetes. And when they had both, it was almost 50% reduction in the incidence of diabetes. So definitely IFG, people with IFG do not respond the same. And actually, that's the highest prevalence of components of prediabetes in many parts of the world, including India. There are more people with IFG than people with IGT. There is a difference in the physiopathology of the developing of IFG and IGT. This is a study made from the Inter-99 cohort. NUT was involved in this, on people with normal glucose tolerance, and they studied them as they developed different types of prediabetes or intermediate hyperglycemia along 5 years. And you can see to the left that the HOMA insulin sensitivity was much lower in IFG than in IGT. On the contrary, the insulin sensitivity index, which takes on account both insulin sensitivity and also insulin production, was lower in IGT, lower than in IFG. So it means that the effect in IGT is different from IFG, and impaired fasting glucose is more related to insulin resistance at the liver level. So probably that difference in physiopathology may be the reason why the response to lifestyle changes is not the same. Do the real-life interventions reduce the incidence of type 2 diabetes? I've shown you that it reduces weight, but does it translate into less incidence of diabetes? Well, apparently, yes. This is, again, a meta-analysis, which includes a couple of the same study done by Noel and his group in Colombia. And what it shows is that, yes, you can actually reduce the incidence of diabetes by 25% in real life by doing those lifestyle intervention strategies. This is another, well, no, this is the same meta-analysis, but I just wanted to show you the change in fasting blood glucose, which is very modest. It's 3.6 milligrams per deciliter, just very low. HbA1c was reduced also by only 0.15%. Weight was reduced very modestly by around 1.5 kilos. But still, you can see, as I showed you before, that the risk of diabetes, the incidence of diabetes, was reduced by 25%. This is another meta-analysis. Again, the risk of diabetes is reduced, although this was not statistically significant. Weight was around 2 kilos. Change in fasting blood glucose also around 5.3 milligrams in this case, and HbA1c, this was in this analysis greater, around 1.2%. Now the question is, who should conduct the lifestyle interventions? And this is a meta-analysis where they divided the different strategies depending on who gave the intervention between people from the community and people from the health professionals, and individual counseling, and even technology. As I mentioned before, that was what Ramu presented this morning. And they all work. They all work. I'll refer to that a bit later. What should we use as indicators of success in real life? Do we test the patients a second time? When? How? How can we know that we are going in the right direction? Obviously, if the person doesn't develop diabetes, that's a success, but for how long? How long do we have to wait until we say that it was actually prevented? Some say that it has to be lifelong to really conclude that the person didn't develop diabetes. And this is interesting. This is from the DPP. And what they found was that people who at least once came back to normal glucose regulation or normal glucose tolerance, they developed less diabetes than people who never achieved normal glucose tolerance. So it might mean that if you test the patient and the patient regresses to normal glucose tolerance, maybe that patient has a less probability of developing diabetes. And what about drugs? Well, in real life, physicians prefer the easiest path. Usually, at least in my country, they prescribe low-dose metformin, just one pill of metformin a day, and some indications about lifestyle changes. That's the usual. It's the easiest, and metformin is the magical pill. But it's not so. In the randomized clinical trials, metformin works mainly in young people who are quite obese, and in people with prior gestational diabetes, and in people who have a higher HbA1c, reaching the limit of diagnosis of diabetes. Not in everybody. And still, the result is not as good as with lifestyle changes. The group in Chennai used a low dose, actually 500 milligrams a day, but they found that metformin had an equal effect to lifestyle changes, but it was still lower than in other studies where the lifestyle intervention was more intense. And in this analysis using a prediction model, you can see that with lifestyle, at any level of risk, and these are quartiles based on a nomogram, which includes fasting blood glucose, HbA1c, previous high blood sugar, triglycerides, waist circumference, waist-hip ratio, that divided people in 4 quartiles, depending on how much of that components they had. And in all the components, in all the quartiles, lifestyle works. But if you look at metformin, it only works in the highest quartile. Probably those people who are almost there in developing diabetes, high HbA1c above 6, with higher fasting blood glucose, with higher triglycerides, whatever. So it doesn't work in everybody. And if you look at the long-term effect, and you can see here those studies that had a long follow-up, up to 9 years in the case of lifestyle interventions, and down there you can see up to 52 weeks in the case of medications. At the end of the follow-up, after the active trial ended, 28% of the people with lifestyle interventions still were preventing diabetes, but only 5% on those on medication. And if you stop it, it's the end of the movie. You go back to the start. So that's what we've learned from real life studies. I'll show you what we've done in Colombia, and we did this study in Bogotá and Barranquilla, two cities, one in the mountains, our capital, where I come from, and the other one in the coast, Barranquilla. We screened almost 4,000 people using a modified FINRISC, which we adapted to Latin America. Mainly what we did was adapt the waist circumference, which is different for us. And around 50% had a FINRISC above 12, which we also validated as a cutoff point for high risk. And we did that, we offered them an OGTT, only a little bit more than half did the OGTT, and we got around almost 6% people with type 2 diabetes, and around 13-14% people with IGT, and the rest had IFG or normal glucose tolerance. This we refer to it's not the NIH in England, that would be too expensive to send them there, but to our own NIH, NHS. And the people with IGT, we offer them a structured program similar to the National Diabetes Prevention Program in the US. The rest, and we tested them 1 year later. The rest, we wanted to see what happened with a community intervention because we thought that there might be some so-called positive contamination between those who were in the program and the rest of the population, but we had a big problem and we couldn't actually test them properly, so we don't have results on that group. Anyway, the structured program offered by the CDC, and this is adapted for Hispanics in the US, it's called Prevenga Type 2, and it's 26 sessions. And the only people who succeed to attend 22 of those 26 sessions are actually recognized as having completed the work. It's too much for us. In our intervention, we adapted this to 10 group sessions. It's given by health promoters with coaches, and we kept contact with them through mobile phones. As I said before, the low-risk intervention was unfortunately not completed because of COVID. What we found in the 83 subjects who completed the prevention program, most of them actually lost weight. The mean loss was around 2.5 kilos, which is much the same as has been found in real life in those meta-analyses I showed. But in those who lost weight, which was almost 80% of the subjects, the mean weight loss was almost 4 kilos. Again, the best you can get in those meta-analyses in real life. Not yet the 5 kilos. I mean, this is the mean loss. And about what happened with their status, we retested them 1 year later, and as you can see, the majority regressed to normal glucose tolerance. I compared those with IFG, IGT at the beginning, and those with isolated impaired glucose tolerance, and it was more or less the same. So overall, the 83 subjects who completed the project, 63% regressed to normal glucose tolerance, and only 9.6% progressed to diabetes. Is that too much? Is that less than expected? Well, we don't have the reference figure for our country. We should, and it would be ideal that we all had the reference of what's our conversion rate. There is a meta-analysis of different studies, including people from our region, which shows that if you have IGT or IFG, as you can see here, your progression at 1 year is between 13% and 29% if you have both. So if you use that as a reference, we had less prevalence of diabetes, incidence of diabetes in 1 year. But again, we don't have our own figures. By the way, if you look at the HbA1c, it was those who had above 6% who mostly progressed. And this is in favor of the definition used by the WHO and IDF, and not the 5.7% used by ADA. So what have we learned? And this is the final part of my presentation. What have we learned from real-life studies? Well, we've learned that the prevention strategies in low and middle-income countries should focus on high-risk groups, mainly people with IGT, identified by non-invasive screening tests, locally validated, like the FINRISK. And people with IFG may not respond the same. Primary prevention programs, I call them 3P, should be in place before any screening strategy. That's a principle of screening. Don't screen if you don't have the solution for the people. 3P worked better. Their work, whether given by professionals, community workers, or through technology, but the former, that means health professionals, should be spared. They have too much work taking care of people with diabetes, and this would be an extra burden. We should train people from the community, coaches mainly, what I call lifestyle coaches. And technology may be useful to increase long-term adherence. 3P used in successful randomized clinical trials should be transculturized, as we did with the program of the CDC. We reduced from 26 to 10 sessions, for example. Most trials, real-world trials, have achieved a modest weight reduction, 4 kilograms, but we should aim at more than 5 kilos. We don't need any more randomized clinical trials in low and medium income countries. We need quasi-experimental or implementation studies. And we should find ways to assess the results of these trials, for example, using the percent of people regressing to normal glucose tolerance as a marker. Metformin is the easiest option, but not as successful and has temporary effect. Maybe it should be used as a second step in those who are at the highest quartile of risk. And obviously, primordial prevention of obesity would be the best solution. If nobody was obese, probably most of the people wouldn't have diabetes. Thank you.
Thank you very much, Pablo, for this enlightening talk. Knowing this, knowing response and non-response helps us to become warriors against diabetes prevention. And Adib, thank you very much for focusing on the aspect of the low and very low income countries, how to translate diabetes prevention. The International Diabetes Federation feels very, very proud of hosting this Joseph Food Memorial Lecture and to honor you for your achievements in diabetes care. Let me say, it's totally cool what you have done for diabetes prevention.
Thank you.
A big applause to Pablo
Pablo,
Aschner.
I request everyone for a standing ovation for Dr. Pablo. And now I request Dr. Manoj and Dr. Ramchandran to come up the stage, and we would like to felicitate Dr. Pablo for this wonderful talk and this oration. Please, Pablo, come. And thank you, Shukriya. You used the last slide with the Hindi word Shukriya.
So, thank you. I think with this, we break for lunch. We start the halls back again sharp at 2 p.m. So hope to see all of you back here at 2 p.m. for many more interesting sessions today, later this afternoon. So see you soon after lunch.
Good afternoon, everyone. Welcome back from the lunch session. We will be starting our next session soon on mixed bag of diabetes prevention. I would like to call upon our chairpersons, Ms. Neeta Farohi, Nebosa Lalik, and Mr. Sanjeev Indurkar. Thank you.
So would you like us to get going now? Okay. So a very warm welcome to this session, which truly is a mixed bag of things, therefore completely different areas, all related to prevention. And it's my great pleasure to introduce this session alongside my two co-chairs. Our first talk is on gestational diabetes, and opportunity to prevent type 2 diabetes. And if I could invite Dr. Maria Ines Schmidt to come to the podium. So, Dr. Maria is an endocrinologist and an epidemiologist, a great combination. She's a professor at the Federal University in Rio Grande do Sul in Brazil. She has many accolades to her name, but I won't read them all out in the interest of giving you full time for your talk. So with that introduction, very welcome, and we are anxiously waiting to hear what you have to tell us.
Thank you for this nice introduction. Good afternoon, everyone. It is really a great pleasure for me to be here today, not only in this beautiful country, but also in this specific session, which I think it's very relevant, and I have been working quite a bit of time now on these issues. So I will discuss make my presentation in two parts. First, I will discuss the opportunity that has been created. And second, I will discuss the evidence that intervention at postpartum reduced the incidence of type 2 diabetes. I think the first one is very simple. Since gestational diabetes is routinely screened during pregnancy, urine and oral glucose tolerance tests, which is the way that we usually do to identify high-risk individuals. Screening does identify high-risk women for diabetes prevention. But why is that? Well, I will just present one systematic review, which is a very recent one, showing that women with gestational diabetes compared to the ones that did not have gestational diabetes have a relative risk of about 10 of developing type 2 diabetes. It used to be 5 and then increased to 7, and then this one is showing it's 10. So I think this by itself is very convincing evidence that GDM is a great opportunity to prevent type 2 diabetes. Now the second part, it's a little bit more tricky and more difficult to really get the results, but I'll try to show you what we have so far. First, I'd like to mention that it was an inspiration to me and a great motivation during my first World Congress for the Prevention of Diabetes at Tennessee, when I saw these 3 classic studies being published, their main results. And this was really a good coincidence. It was also when I started attending these meetings, which I believe I only missed one of them. And more recently, not only these 3 classic studies, but many, many other studies around the world started to join in giving evidence for prevention of type 2 diabetes. And with a pretty good relative risk reduction. But what really convinced me even more the importance of doing this is the fact that I realized that the effects are sustainable over years, many years, in fact. So we definitely have to do something in a setting where screening is already occurring, So I then saw that the DPP, one of the 3 classic studies, actually evaluated 350 women in a subgroup analysis that had GDM. And they found that the reduction was pretty good, was 53%, the relative risk reduction. The point, which is relevant in this regard, is that the intervention that DPP offered was actually offered about 9 years, almost 10 years after pregnancy. So there was a decade of time that we miss for intervention. In addition, they all had IGT. So not only you had to screen during pregnancy to identify gestational diabetes, but then you had to find them at postpartum to screen them with another oral glucose tolerance test so that you could exclude diabetes and diagnose IGT to then start an intervention. And the intervention was very intensive. And we sort of realized with the experience of women at postpartum that this will be very difficult to achieve. So one of the big questions is it worth trying to do it earlier? Is it effective trying to do it this earlier? Well, as I said, I was very motivated with this, and we decided to plan such a study in Brazil, where we will enroll women during pregnancy, after they had a diagnosis of gestational diabetes, and then we will ask them to come for postpartum for a neuroglucose tolerance test, so to define high risk, offer them an intervention and compare them with a control. We even discussed the ethical issues of this, since we already knew that it was effective in other settings, was it ethical to even have a control group? And we discussed very well how to do that. And then we would follow them over years to find if they would develop or not diabetes and compare the relative risk in intervention and control. So we then went to pilot studies, and talking to these women, first we realized that they did not perceive themselves as increased risk of developing diabetes. Second, some women, in fact, told us that the label they received in pregnancy was so stressful that now when they would finish pregnancy, all they wanted to do is take care of their baby and forget entirely about everything they had to do during pregnancy. And most women were concerned with current problems, which were quite large, and not interested in learning about the future issues. They were more concerned with taking care of the baby and being able to sleep at night. So we had to change our study, and we decided to use not an oral glucose tolerance test to define high risk, but try to find a different way. And the reason for that is because about 30% only of the women did return for the oral glucose tolerance test. So what we did, we chose those that require insulin during pregnancy and used that as an indication of risk. That way we could already, during pregnancy, know which woman should be invited shortly after pregnancy to come for our trial. And the other thing is that we decided the only way to do it was to do a remote type of intervention, and at that time, the easiest for us to do was to develop a telephone intervention, rather than asking them to come to the health system to do the group activities or the individual sessions. So we started the study in 2015, and we did then a systematic review to find out what was the likelihood that we would actually find a good result in our study. And we were really surprised that we could only find 8 studies that had been addressing exactly this issue. And 5 studies actually started within 1 year after delivery. The remaining ones started later. They were all very small, and usually with very small number of events. There was one that was actually a little bit larger, but they only used the first year of their enrollment when they published these results. But we found that those that started earlier did have a reduction in risk, which stimulated us to continue. But when we put all the 8 studies together, as you can see here, the reduction was lower, the relative risk reduction, and not statistically significant. So we just continue the study. And I'd like to mention one large study that just published their results very recently. It has been mentioned already in this meeting here. It was done in South Asian women. It was a multi-center study. And the main outcome was not incidence of diabetes, but was deterioration in glycemic status. So going from normal to prediabetes and from prediabetes to diabetes. And as you can see, the relative risk here was 0.92 and non-statistically significant. They say that the intervention was very much affected by COVID-19. They did show in the same paper instance of diabetes, and although relative risk was lower, was 0.89, you can see that it's really non-statistically significant. Another systematic review that was done shortly after these results were published came to an estimation of 0.76 as a relative risk, statistically significant, suggesting that perhaps there is some benefit in lifestyle intervention. So what could be some possible interpretations for this smaller effect? Perhaps because they are often less intensive than what DPP did, more remotely. Perhaps they were adopted with less adherence because postpartum is a very difficult period. Or the adherence got worse during COVID-19, and just this was the main explanation. But we also must consider that the intervention is occurring at younger women, and younger women may be at having her diabetes that is of higher risk. So what's beyond the systematic reviews? Well, now we did some new search, and we found that some studies were missing this systematic review, so we are eager to put them together now. And also, as you can see here by the dates, some studies were published recently. And if you read the papers, you find out that most of them were affected by COVID-19, unfortunately. In the last paper, I mentioned that in the bottom is the Linda Brazil, which I mentioned that we are doing in Brazil, and that the results are not published yet, are still sitting in a journal for about 10 months. You know, peer review these days is a difficult thing. But I'll just mention you a few things that we found. Here to the right, I have the incidence in treatment and control, and then you can see there is a very small difference. But if you look at the slide in the bottom, you see that the lines are more separate between treatment and control, and this is when we split those that were affected by COVID pandemic and those that were not. Because since our trial started earlier on, we had quite a good number of people where the COVID affected only minimally. In terms of weight, which was a secondary outcome, we noticed that different from what we expected when we defined our outcome weight, we actually thought that we were trying to bring weight to what was before pregnancy. And actually what we saw is that they all gain weight after pregnancy. So there was no return to the weight before pregnancy. There was weight gain. However, the intervention group gained less weight, a difference of about 1 kilogram. And when we separated out by those that were distant from the COVID pandemic with the ones that actually were randomized close to the pandemic, the effect the difference was larger, almost 2 kilograms. So what can we conclude? First, that systematic review and meta-analysis of trials for diabetes prevention estimate that the intensive lifestyle intervention offered postpartum can reduce the incidence of diabetes, but the effect is only of moderate magnitude, 20-25% relative risk reduction. What I really like to call your attention here is something that I started to think more over the last year in particular. The estimates, as they should, are based on ITT analysis. But lifestyle intervention frequently has deviation from the intended treatment and frequently have problems with missingness, which actually jeopardize the correctness of ITT strategy of analysis. So we definitely need to look, particularly in this period with low adherence, which is the postpartum, we need to look at per protocol analysis as well And I think this is very important. So I think to complete the picture of the opportunity for prevention, I must emphasize that first we need to prepare women at increased risk before pregnancy, and to this, pregnancy need to be planned, and we need to have education for such a scenario to happen, which in Brazil, at least, we are still way behind. Second, screening for gestational diabetes must happen. And this we are doing quite well, regardless of the screening method used. The important is that to do screening. And I think we are doing pretty well in this regard in Brazil. Now, the other thing is, we thought that this strategy of identifying women by the need of insulin during pregnancy was actually a wonderful strategy to identify those who are really at very high risk. I don't have time to show you here today, but the increased risk of this cohort of women is really high. So we had a very high incidence of diabetes in the first 2 years, much more than we expected when we planned the study. So we can already identify those that are at very high risk while they are pregnant and already prepare them for the need to come for postpartum prevention. So those that are at high risk, we should use all means possible to bring them for treatment. And this is really only about 20% of them, even if we have to go to their homes, whatever method we can use to get them to do the postpartum reevaluation we need to do, because many of them will have already type 2 diabetes. And those that don't have, only have intermediate hyperglycemia, we could offer them intensive lifestyle modification. And those at low risk, we still need to give them lifestyle intervention, but more in the order of an orientation, and of course guarantee yearly follow-up for glucose testing. So this period from planning pregnancy to the postpartum period needs to be very carefully evaluated, and using OBGYN people, primary care physicians, endocrinologists, and even pediatricians. Because if we cannot get the woman to come to care for themselves, they go to take care of their baby. So if we adjust that moment for them to do their screening, that's already good. So it must be discussed together in the healthcare setting. Thank you.
That was tremendous. You've actually even saved us some time. So we were going to take questions at the end when there's a discussion time. We'll keep going on to the second speaker. That's...
Thank you, Neeta. Now in the mixed bag, we have next lecture on physical activity in prevention of type 2 diabetes by Dr. Noel from USA. He has received his academic training at University of Kuopio, then Karolinska Institute, University of Zurich. He is Master in Public Health, Adjunct Professor in Public Health at University of Helsinki. His research interests are prevention and control of hypertension, diabetes, cardiovascular diseases, tobacco control, and physical activity. He has worked as a consultant in non-communicable diseases for PIHO, the Minister of Health of Argentina, Colombia, and Paraguay. He has published more than 140 scientific publications. Currently, he works as Associate Professor at Herbert Wertheim College of Medicine, Florida International University in the USA, and he is the current chair of Faculty Senate. Over to Noel for an interesting talk on physical activity in prevention.
Thank you so much, first of all, for the organizing committee, for Purvi, Manoj, Amit, Bansi, and everyone else, also the international committee, for inviting me and having the meeting here in Mumbai in India. So my talk is about physical activity in prevention of type 2 diabetes. And it goes actually a very long way back. I mean, even Hippocrates, he said that if you could give every individual the right amount of nourishment and exercise, not too little, not too much, we would have found the safest way to health. This has been some thousands years ago, and we're still sometimes struggling in implementing this in our daily lives. So I'm going to go over a little bit on the effect of physical activity in preventing diabetes mellitus on follow-up study, cohort studies. Then I'd like to summarize the evidence from trials. And then in the end, some conclusion recommendations, the way forward, how we can get maybe physical activity more included in primary healthcare when we work with diabetes patients. So as a short introduction, this is usually one of my favorite readings when it comes out. I'm waiting for the IDF Diabetes Atlas like a little boy for Santa Claus probably, but it's always nice to see the recent estimates, and this is where we unfortunately are here today with the global diabetes prevalence and the prediction for the next couple of years. We also have information on prevalence of impaired fasting glucose in adults in 2021, with some regions more affected than others, and the same in regard impaired glucose tolerance in adults 2021, which I think is like sort of a time bomb, as these are the turning over annually from IFG or IGT into diabetes about between 4 and 5% per year. So we definitely have the population that we should intervene with interventions. Now, we know sufficient, like this is an incomplete list of modifiable type 2 diabetes risk factors. We see like obesity, central obesity at the top, then physical activity, sedentarism, later on sitting time, and there's a lot of different risk factors. But I think if we could control even the first 4, we would do really, really well. We don't probably have to take too much care or too much worry about the others, but controlling obesity and physical activity probably is the key. And you're going to see also later on one of the conclusions that they go hand in hand. It's an energy balance and space-based energy balance that we try to control. The good thing is physical activity has shown there's enough scientific evidence on the impact, on the effects of physical activity on the different organs responsible for diabetes. We know that exercise increases beta cell mass, insulin production, decreased glucagon production. It also has an impact on adipose tissues, so it increases insulin sensitivity not only in the fat tissues, also in the muscle and in the liver. It decreases glucose concentration in the blood, so by an uptake of the muscle for glucose uptake, it also in the muscle has an impact on glucose and fatty acid oxidations. So you see a lot of beneficial effects of exercise that has shown, like through the scientific evidence and different studies, how the mechanism work. Now sometimes we need to see, this is what we know about how to implement this into population studies. And we have a lot of evidence from cohort studies and from randomized controlled trials. So this was the Harvard alumni study, probably one of the first ones that showed associations in a follow-up study of Harvard alumni, those who had sports played, flights of stairs climbed, blocks walked per day. They showed basically that Harvard alumni that had vigorous activities only or moderate vigorous physical activity had a relative risk reduction of type 2 diabetes. The relative risk reduction ranged between 30 and 35%. They didn't find statistical significant association between flights of stairs climbed, even though there seemed to be a tendency that the more stairs you climb per day, that the lower the risk of diabetes, and blocks walked per day didn't find any statistical significant differences. However, they concluded that for each 500 kilocalorie of energy expenditure increase, the incidence of diabetes decreased by 6%. And this study is about more than 30 years ago. And this is probably one of the first real big cohort studies in that field. Then others have summarized systematic reviews and meta-analysis of studies. This is by Gion et al. Many years ago already. They explained that the relative risk of type 2 diabetes in people with moderate intensity physical activity. Moderate intensity is when you can walk, you can still talk if you do activity with someone, but you can't sing. That's more or less moderate. If you can't even talk, then that's vigorous. So as a rule of thumbs, but they revealed a 17% decrease in risk of type 2 diabetes, independent of BMI, for moderate intensity physical activity. Others have also investigated the effect of weight training and on incidence of type 2 diabetes and combining with aerobic exercise. So they saw that probably 120 minutes, 150 minutes of weight training per week, it decreased the incidence of type 2 diabetes. You see, as many cases in physical activity, there's first a sharp increase and then reaches a plateau. So after 180 minutes per week, the additional minutes of weight training probably doesn't give that much benefits. On the right-hand side, you can see physical activity weight training combined with aerobic activities and non-aerobic activities. So basically, the first one, no, means that people do not meet the recommendations for aerobic activity. Weight training improves, decrease the risk of incident of type 2 diabetes, but when combined with meeting the recommendations for aerobic exercise, which is about 150 minutes per week, then additional benefits were seen. And so we can combine weight training with aerobic training. I think that's important for many of our patients, especially when they say that they may not be able to do aerobic activity, at least they can do maybe some weight training. Other studies have summarized the evidence on total physical activity and risk of diabetes in cohort studies, and they revealed also a relative risk reduction of more than 30% compared to those who were inactive in leisure time. Others have measured or combined the scientific evidence in regard different intensity of physical activity. There you see like 20 med hours per week as apparently a linear dose response impact association with type 2 diabetes. Also 5 hours per week. In the lower boxes B and D, you can see leisure time physical in type 2 diabetes, like on med hours per week. And again, we see that there's a sharp decline, like in decrease in risk, but then probably for if you overdo it, you won't have any additional benefits. But again, there's enough evidence from cohort study that leisure time physicality decreases your risk of type 2 diabetes. Others compared like vigorous physicality, like in box A here on the left upper corner, a decrease of almost 40% of the risk of diabetes. Even low intensity physicality has a benefit with apparently about 30% decrease in risk. Moderate physical activity, decrease of 32% in risk of diabetes, and walking, which is probably the most natural, easiest form of physical activity. Even walking and the combined estimates of cohort studies have revealed a 15% decrease in future risk of type 2 diabetes. And all this evidence basically obtained by cohort studies. So we have enough evidence from cohort studies, but as usually the golden goal is to see how things work in randomized controlled trials. And you know most of these trials. I mean, anyone hasn't heard about a DPS? I thought so. So, okay, the Finnish diabetes prevention study. This is a Finnish diabetes warrior to see, to reflect like the logo of this conference. So the DPS had about more than 500 people at IGT on 2 oral glucose tolerance tests. They randomly allocated participants in a normal treatment group, intensive treatment group. The intervention consisted of nutritional changes, weight loss, and physical activity, 30 minutes per day. And as most of you already have seen that the development of type 2 diabetes between the intervention control group, there is a remarkable decrease or difference in the incidence of type 2 diabetes between the two groups. The follow-up study of almost 15 years revealed that these changes maintained over time. So the DPP, the US Diabetes Prevention Program, they published the results a bit later after DPS. They had physical activity as well as one of the intervention, the lifestyle intervention. So again, a combined dietary intervention. There was a 7% decrease in weight as an objective, but again, combined with physical activity, which was very similar than in the DPS. They analyzed later on a change in physicality between the 3 groups, the metformin, the placebo, and lifestyle group. Naturally, the lifestyle group, they increased their physicality as metformin alone doesn't really increase your physicality levels. unless you really have to walk to pharmacy, getting your medication every day and coming back. But it's basically the additional impact of physical activity probably plays an important role in the difference between the control group and the lifestyle intervention group. We all know the IDPP has been presented in several occasions during the last 24 hours with 3 intervention groups. We had lifestyle plus metformin, and metformin compared to the control group. Each group did very similar. We also learned yesterday about the differences, most likely due to baseline profile. They were younger, they were leaner, and the weight reduction was non-significant compared with DPS and DPP. The Da-King study in China, they had 3 intervention groups. They had a dietary intervention groups, they had an exercise intervention group, and a combined diet and exercise group. So they want to see whether there are independent effects, whether some groups maybe do better. Compared to control, they furthermore showed the analysis according to lean weight and obese. We see the control group, the highest incidence or risk of diabetes was in obese individuals who did not have any interventions. But then if you have a look at diet and exercise groups, each of these 3 groups did much better than the control group. And naturally, or what was expected, the lean participants did better than the obese participants. But even, for instance, if I look at the exercise group, a participant who was obese and practiced exercise did much better than the control group, an obese participant in the control group. Sometimes we hear from patients that I'm obese, even though physical activity, it won't help. Yes, it does. You still have a reduction in risk, even if you're obese and practice physical activity. Because the mechanism how physical activity impacts the risk of diabetes is not mediated by BMI, as I showed you in one of the first slides. They're independent impacts. That's why I really encourage you, talk with the patients independent of their BMI, that they should implement physical activity in their daily routine. This is a summary of most trials in people with pre-diabetes, and we see that basically most trials combined, the intervention consists of combined diet and exercise, and again, probably these 2 things have to be hand in hand, as we need dietary changes combined with exercise and vice versa. But each of these major trials showed convincingly that interventions, they work and they decrease the risk of type 2 diabetes. We had a study in Barranquilla, the Mojon study, where we screened about 15,000 with the FIN risks, people at high risk, and those who had IGT or IFG, we randomly allocate them to 3 groups. We had a control group. We had one group that started with nutritional interventions, 6 months, followed them by combined nutritional physical activity interventions. We had a third group that started with exercise interventions, and then we added the nutritional component. So this was a real-life world experience, probably rather pragmatic trial than a randomized controlled trial. You see, there are a lot of people, actually half them discontinued the study. And when we analyzed the data for the primary and secondary study outcomes, we didn't really find differences between the 3 groups. So we saw that the relative risk of nutrition physical activity compared with the control group was the same. Even seems to be reversion normal glycemia, a decreased relative risk, but no significant findings. But then when we analyzed a little bit deeper and we had a look at, okay, what were the fasting glucose levels before and after the interventions and the 2-hour glucose levels, we actually realized that 2-hour glucose level decreased in the nutritional intervention group and the physical activity group more or less the same. But the main problem was also in the control group, the 2-hour glucose level decreased. And we learned a lot from that study. I think there are a couple of ideas or hypotheses why we couldn't detect differences. One is maybe the Harn-Turn effect, that the control group people, they knew they're part of the intervention. We had some same family members, one member is in the control group, but the intervention groups. There were a lot of activities going on in Barranquilla this time on diabetes prevention, so there's probably some dilution of the impact of the intervention. But I think we showed that this is a trial done within primary healthcare. We showed that it's feasible, it's possible to implement the results of randomized controlled trials in primary healthcare. The Cochrane Library, the Cochrane Review, was concluded a couple of years ago that there's no firm evidence that diet alone or physical activity alone compared to standard treatment has an impact on the risk of type 2 diabetes. However, diet plus physical activity reduces or delays the incidence of type 2 diabetes in people at risk. Again, strengthening that we need both elements in order to be successful in intervention. Another thing in trials, we had compliance rate of almost 77%, which is a pretty high compliance. In real life, probably getting the same compliance will be very difficult as we have a heterogeneous population, but it helps if you have a high compliance, if people really adhere to the physical activity recommendations and to the guidelines. There's a couple of other studies, they analyzed like post-meal walking and glucose in people at risk for diabetes and IFG. They compared 3 different regimens, like one was 50-minute walk after each meal, so 3 50-minute walks, a 45-minute walk 2 hours post-meal in the morning, or a 45-minute 2-hour post-meal walk at 4:30 in the afternoon. And what they basically showed that the post-meal walks after the breakfast and the 50-minute post-meal walks after each exercise, they decreased the average 24-hour glucose level in the participants. The 45-minute walk at 4:30 did not have a big impact. Here we see the 24-hour average glucose levels. First of all, on the left side, at 10:30, we see a decrease in the exercise group of the 24 average glucose level. The 45-minute walk at 4:30, there was no differences, but 3 times 50-minute post-meal walk had an important difference. So even with 3 boosts, 50 minutes walking post-meal will decrease or can decrease your 24-hour average glucose levels. And knowing this, we may apply this to a sample exercise schedule for our patients or people with pre-diabetes. So we could even have, from Monday to Friday, 50-minute post-meal walks after each of the 3 meals we have. This will amount to 225 minutes of moderate physical activity per week, which is a bit more than recommended. If you really like to go with the recommendation, at least we can have at least twice per day post-meal walks, and that's going to help you to decrease the 24-hour glucose levels in those in people with pre-diabetes. Another thing you can do is physical activity prescriptions. There's a whole body of evidence, scientific evidence on the impact, the benefits of physical activity prescription. There was the green prescriptions, probably the first one in New Zealand, that showed it's effective, provided by nurses. There are other studies and there are systematic reviews that clearly showed that if you prescribe the patient's physical activity, that it has an impact. There's a lot of exercises medicine, a concept that came through the American College of Sport Medicine. That's a program that trains healthcare professionals in exercise prescription. And this is one of the concept intervention has been spread throughout the world. But there's enough evidence that exercise prescription actually works. And considering that patients usually wish, when they leave our general practice office, they usually expect you having a prescription. So prescribe exercise. A couple of conclusions. So these are like the current recommendations: 150 minutes of moderate intensity aerobic activity combined with at least twice per week muscle strengthening activity. And for older population, probably it's good to have activities as well related with balance training, like a mix of aerobic, muscle strengthening, balance activities. Every minute count. You can split it into boosts of 5, even 10 minutes. So it doesn't have to be 30 minutes in a row. And it's a challenge to getting there, I know, but this is probably the prescription's help. So to finalize, I think more is better than less, but something is better than nothing. And this is probably the most important message you can give to your patients. It's difficult to start. Once you have started with exercise, things become easier. Thank you very much.
Thank you, Dr. Noel. Thank you very much. Yes.
And now we are, of course, continuing the mainstream of this session and of different ways of preventing type 2 diabetes. And the next topic is primordial prevention of type 2 diabetes. And I thought all the time, should I present next speaker to the auditorium or not, because there are just few people that cannot recognize him and does not know all about all his achievement. But however, it's my duty, so I make my own selection in order not to take the time of your presentation, Dr. Sabu, and Dr. Banshi Sabu will be the presenter, and he is Chief Diabetologist and Chairman Diabetes Care and Hormone Clinic in Ahmedabad, Chair-elect of IDF Southeast Asia, Vice President of Diabetes in Asia Study Group, Secretary of Diabetes India and Indian Academy of Diabetes, founder of DTEC Diabetes Care India, India Suite Registry, Global Advisory Council member of the EASD, member of the advisory board, advisory group of, member of the advisory group of ADA, managing director of Sadikat International textbook on diabetes and metabolic syndrome, editor-in-chief of RSSD textbook of diabetes, honored with fellowships of American College of Endocrinology, American College of Physicians, International College of Nutrition, Royal College of Physicians.
Thank you, Neboja.
Edinburgh, and there are just two more. There are just two
So
more.
I can talk 1 minute more, you know.
Which I was impressed with. And I was impressed, okay, just one that I would not miss, and that you were awarded by American College of Clinical Endocrinology as a clinician, as a global clinician of the year 2024. Congratulations.
Thank you, Neboja,
And the
for
floor is
kind words
yours.
of introduction. Kind words of introduction. Thanks, World Congress of Prevention of Diabetes Scientific Committee and Organizing Committee for giving me this opportunity. What I'm going to talk in next 20 minutes, the primordial prevention of type 2 diabetes. And it's my great pleasure that I'm talking in front of Dr. Yagnik, because this is what the maximum work in this field has been done by Dr. Yagnik in this area in India, and my many of slides are what he has talked, whatever his presentations or from his papers. So it's really gave me great pleasure, and thanks Manoj for this wonderful opportunity. We all know this is the ICMR INDAB data. At present in India we have 101 million people with diabetes and 136 million people with pre-diabetes, and this is the other metabolic risk factor problem like dysglycemia, hypertension, abdominal obesity. And if you think of primordial prevention of diabetes, it means we are preventing almost all these problems which we have in diabetic patients. So I mean, other than diabetes, you are also preventing the central obesity, you are also preventing the dysglycemia, you are also preventing the hypercholesterolemia too. This is the prevalence rate which is increasing. If you see the data from 2000 to 2021, we have many epidemiological data which has been published. It has been published in International Diabetic Federation also. Last IDF in 2021, it was showing 74 million and then there was 79 million. But then ICMR recent data published, which I had already shown in 2023, has talked about that we have almost 101 million people with more than 12% adult population having diabetes. The problem is not just that we are having diabetes in 50s or 60s. We are getting diabetes almost 2 decades earlier. And you can see here, even below the age of 30 or below the age of 25 also we are getting. Recent publication with Rakesh and our group from RSSDI, we had shown with that we have a lot of people even below the age of 25 first time detected diabetes in our country. And that's the reason we have written one paper to that in India it is advised that they should get their regular checkup above the age of 30, but rather it should be below the age of 25, or even every adult, whenever there is an opportunity, they should be screened for diabetes. And as number of people increasing, even in 20s and 30s, they should be screened also more. This is one more very interesting data of IDF Atlas from 2021, that out of different regions, and being I am a chair-elect for Southeast Asia, we have also the highest age-adjusted prevalence in our Southeast Asia as far as hyperglycemia pregnancy is concerned. That's again a challenge for us. These are some of the papers which is talking about the diabetes and its complication in India. The incidence paper from Kerala, one more paper, incidence and pathophysiology of diabetes in South Asian adults living in India and Pakistan with US blacks and white. But what are the key points? The key points are, we are getting diabetes in younger age, we are getting diabetes with lower BMI, we have higher coronary artery disease, we are having diabetes in India which is increased both in urban and rural areas of India. We have diabetes which is, if we understand the diabetes epidemiology of India, rather other low income countries or middle income countries can have the similar type of methods of preventing diabetes in their country. So the learning is that India has been surpassing all its projection or prevalence of diabetes. Whatever has been prevalent or predicted or projected that in 2020 we will have those many numbers, probably those numbers we achieved already in 2015. As we had already talked about 2021, the data, Indians develop diabetes at a younger age with lower BMI. They have higher risk of conversion from pre-diabetes to diabetes, higher risk of complication, and incidence of diabetes continues to rise despite all efforts of prevention. There is a multi-pronged approach. The approach is for primary prevention and secondary prevention, we all know. We do the prevent development of diabetes in high-risk population, and this is what all diabetes primary prevention studies we had heard yesterday. Amit had talked about the all different studies which is all talk about the primary prevention of diabetes. Then we have secondary prevention. It means those who have diabetes, at least to complication to be prevented for them, and treating the individuals with complication, that's what the tertiary complication. But what is more important is preventing the risk factor for development of diabetes. So primordially you are preventing the diabetes. Someone is developing diabetes because he is becoming obese. Like in the keynote lecture, Pablo has talked that, if we can reduce or we can reduce the incidence of obesity itself, which is a major risk factor for it, then we can have a primordial prevention of diabetes. And so preventing risk factor for development of diabetes, that's what the primordial prevention which we have to think for the persons with diabetes. This is one paper which Dr. Yagnik had published in 2002, where he talked that small, thin, fat Indian baby. And even at the time of birth, the average British baby have a birth weight of 3.2 with a fat percentage less than 20, and while the Indian baby, which he had shown from KM Hospital, Pune, with the average birth weight of 2.7 with higher fat percentage of more than 25. So it means we have small size, more fat, less muscle mass, less viscera, high insulin, high leptin, and low adiponectin, and this makes them susceptible for diabetes and CV disease even at the time of birth. So the body composition of newborn, from the time of birth, they are thin fat Indian. They are one who are having high insulin resistance and low adiponectin from that. And then he had shown also in one very important paper is YY paradox, which he had shown that his BMI and Professor Yudkin BMI both are same, but still the fat percentage is high. So not only with the newborn we have high fat, even throughout the lifetime, those who have with a normal BMI also have a high fat percentage throughout the lifetime. That's what the Indian fat or Indian thin fat Indian, that's what a phenotype which we have. And we have developing diabetes with a 2 or 10 years younger. We are developing diabetes with a BMI at a lesser BMI, maybe at 23, 24, 25, and we are having diabetes with mid-arm circumference, which is 20% less with that. This is one also very interesting, that we have a birth weight data. If it is WHO, this is a international map, which is talking only about the Indian subcontinent having the lowest birth weight. The average birth weight of this Indian subcontinent, which includes India, Bangladesh, and some of the other neighboring countries, is around 2.8 kg. With the same he had shown the average birth weight of that baby was 2.7. And you see in other parts of the world, in the North America or even in the Northern Europe, it is averagely around 3.3, 3.4, 3.5. So, we are the one who has lowest as far as newborn birth weight is concerned. But at the same time, we are capital of two. One side we have undernutrition with lowest birth weight under the age of 5, highest number of people in our country. And other side, we also have highest number of people with diabetes also. That's what the precipitating factor is, obesity. The persons with a BMI of 22 or 23, suddenly he increases BMI by 24 or 25, or suddenly some increase in his abdominal girth because of his physical inactivity or some stress, he becomes a diabetes. So we are the capital of two, both sides undernourished as well as we have highest number of people with diabetes. So the major cause, what is the reason why we are having the capital of 2? One is that our mothers are not healthy. Our mothers are not healthy in terms of they are healthy mom. They develop premature delivery. We have more cesarean section because of short stature of the female itself. In utero environment is also poor. Maternal nutrition from macro and micronutrients both poor. We are also having hyperglycemia in pregnancy, which is the other side. The obese female who are overweight and obese, having history of PCOS and then developing hyperglycemia in pregnancy, that also leads the problem. We have more anemic, more hypertension in pregnancy, and then other antenatal factors like obesity, PCOS or past history of GDM. So these are the major causes for them to have a low birth baby. And if we change that, probably we can think of something primordial prevention. So what's the key issue? We have an Indian female which is thin fat phenotype, short stature, malnourished with history of PCOS or obesity. What we are getting, the Indian mother, not healthy mom, the preconception planning is inadequate, antenatal care is poor with poor nutrition, then hyperglycemia in pregnancy, eclampsia, preeclampsia and anemia. Then what we get, the Indian newborn, which is low in birth weight, high body fat, low muscle mass, high insulin resistance, that baby which we are getting. And then what we have in childhood itself, early exposure to sugar. We all, family starts feeding that a child which is low birth weight is already 2.8, 2.7. Full family starts feeding the child to increase the weight, and that overfeeding, rapid postnatal growth, and ultimately leads to a thin fat phenotype, which is the typical of Indian phenotype. And then many of them, they develop even the central obesity, which is what 353 million people with the central obesity in our country. And then they develop diabetes even with a slightly increase in BMI with their 23, 24, 25 BMI. And then this continues. The same, those with, they become young adults, and then again these Indian female who are again thin fat phenotype with short stature, and this continue to have. And that's the reason we are not primordially preventing, or rather our incidence and prevalence is increasing day by day. So the Indian scenario is very typical with a poor maternal nutrition, a low birth weight child, rapid postnatal growth, and this is increasing prevalence of metabolic syndrome. The urbanization and changing lifestyle definitely, which increases the further risk for them to develop diabetes. It's that someone who is already at the stage where he can develop diabetes at any stage, but further changing lifestyle and urbanization, maybe because of high carb diet, processed food, sedentary lifestyle, and inadequate exercise leads to them a diabetes for them. So the life cycle is that F1, who is a gestational diabetes, the short, and then this picture will show you very clearly there are a lot of epigenetic changes because of this low birth weight child which is we are getting. Postnatal, it is having high adipose tissue, increasing body weight, waist circumference is increasing, macrosomic child. Adolescent is a twofold increase incidence of pediatric diabetes and increased rate of CVD even in the young age also. So these are the also two more problems we are now getting, not only pediatric obesity, but even pediatric type 2 diabetes too. And then in adulthood, we are getting all insulin resistance, metabolic syndrome, and many of them, they develop diabetes. And then this intergenerational, the next generation, again, the same cycle continue to repeat, and it is increasing. So the womb may be more important than home. This is what the Barker in 1990, he talked that adult diseases are programmed by the environmental developed in fetal and infant life. So it is the mother womb which is more important. It's the healthy moms will give the healthy baby, and that's what our concept is, that if we want to do the primordial prevention, we have to make the mother healthy. That's what the healthy mom concept should be there. So the solution is the prevention of diabetes in India, rather I will say primordial prevention of diabetes in India. We have to target the female child, every female child, for a healthy motherhood. So not just now when she is already at the age of 20 or at the age of 25 and she goes to a gynecologist for to become the pregnant, not at that stage. We want that every female child who is just now 8-year-old, maybe 10-year-old, and then preparing that female child for healthy motherhood, and then targeting maternal malnutrition, GDM, hyperglycemia in pregnancy, targeting childhood overnutrition, obesity, and targeting the lifestyle of adolescents and adults too. So the life course approach for prevention of non-communicable disease, we have at every stage. There is a possibility of prevention of diabetes at every stage. And this is very important. What we are talking at only at this stage, when they have already accumulated risk, they have already developed so many problems, and now we are talking of prevention of diabetes because they have already, centrally obese, they are thin fat Indians, just because they are now increasing in their central west or increasing in their BMI, they develop diabetes. But we have to start working here from the fetal life, even in the childhood also, and even adolescence also. So not that prevention diabetes, someone who develops pre-diabetes, not at that stage we have to think of, or not someone who is already having the risk factor for developing diabetes, who is at high risk of developing diabetes. We have to think for prevention at this stage, not at the stage which is only decreasing with 1/3, whatever the data which we had shown by using metformin, by lifestyle modification, by glitazone, by acarbose, by all those molecules, or we had shown 30%, 35%, there is an increase. So even at early childhood, promote breastfeeding, avoid sugar, responsive feeding, controlling screening time, risk assessment, age appropriate physical activity, sleep hygiene, growth monitoring as per birth weight. So these all are very important aspect of even in early childhood for thinking of prevention of diabetes in adulthood. The school going children, and this is very important because we talk to the government also for the NCERT that a health science booklet in a school curriculum is important. If we can give them, they understand, they educate, they know that what diet they should take, and then during school time, the growth monitoring, healthy diet, discourage fast food, physical activity, promoting sports, screening for obesity, all these are also very important if we are thinking for prevention of diabetes. Not just like someone who had already diabetes, pre-diabetes, and then you are thinking for pre-diabetes. Even for teenagers and adolescents, the high risk of developing obesity, they have to counsel, digital health engagement, doing nutritional workshop for them, lifestyle choice campaigns, community involvement, and mental well-being. This is what many of the doctors, they do. They go to the college, they go to the schools, giving the lectures for everything, but that's what our primary aim. We have to think diabetes to be prevented at that stage. The young adults, reinforcement of all those healthy habits, whatever they learn in their school or in their early adolescence in the college time, they have to reinforce that same healthy habits, education on obesity and diabetes, comprehensive health monitoring, fitness challenge and incentives. Now, this is something which we thought of and we had written a paper on it, and we are working, Rakesh is working, and again, the guidance of Dr. Yagnik and senior person like Dr. Ramchandran, and everyone is involved in that. And we had thought that, this incentivizing the young people and a standing culture in our country may change them, because the central obesity is a major challenge for us. So if we have a culture of standing, working more with a standing way, and if we incentivize those who are more fit, probably this will also help for us. The middle-aged people who are already developed diabetes, or some of them are already at the risk of developing cardiovascular disease, that is what primary or secondary prevention. For them, someone who had developed diabetes, now we are preventing them from complication, or somebody who had developed complication, we are now doing the tertiary prevention diabetes, but that we should continue to them for even middle-aged people also, and the same, all other things are to be done. Other than that, we have to screen them for cardiovascular disease. We have to screen them for other complications which they have. Those who have above the age of 65, because we develop diabetes, even in the age of 60, 65, because of the sarcopenia, because the muscle mass is already less. Already in his paper, he had shown that the muscle mass is very less, and that prevention of sarcopenia, that's a major challenge for our patients. Even they may have normal weight, they may have BMI normal, but because of our poor nutrition or because of less protein intake, we have the sarcopenia, which is a major challenge, muscle strengthening exercise and nutrition that we have to continue. So we should have a very multi-pronged approach for that. We all are working and talking about these: urbanization, unhealthy diet, sedentary lifestyle, lack of exercise and stress, and they are responsible for making them diabetes. This is what we all are working. This is what the primary prevention. But we are forgetting completely the maternal health, maternal nutrition and in utero environment, which is responsible for getting a normal birth weight of child, getting a healthy newborn, getting a child with a less fat percentage, getting a child with a less insulin resistance, getting a child or a young adolescent with less risk of obesity and diabetes throughout the lifetime. So this is what we need to work on this part. we all are working. It's that complete WCPD or a conference is on primary prevention of diabetes, but not on a primordial prevention, something on which we have to work. And this is going to give you the generational impact. This is going to give the impact not for one generation, maybe for second or third generation. The next generation may still have the low birth weight child, still have the higher fat percentage, but if those children, again, if they are, these young females are changed, and then the next generation, probably we may get a normal birth weight, still the fat percentage is maybe less, but not like the Caucasian child. Again, working on those generation, again in the next generation, maybe after 2 generation or 3 generation, we may see that we also get a normal birth weight of a child with a fat percentage which is comparable with Caucasian. So that improve the health of every female child, that's the only key message which we can do for primordial prevention of diabetes. This is something which we had 2017 in Fab when we were doing Diabetes India in Delhi, New Delhi, and with the group of doctors and some international experts, we met Pranav Mukherjee. And that time we had given a concept of diabetes-free India. Why in 2017 we thought of that if we start working for those female who are just now 10-year-old girl, 11-year-old girl or a 9-year-old girl, if we start working for them, probably when they will become mother, maybe at the age of 20, 25, 23, and when they will be giving the birth of a child, we may change the phenotype. And that's what the concept was. A child born after 2030 should not see lifetime diabetogenic risk factor in her or his lifetime. That's all the idea of conceptualizing of a diabetes-free India. That does not mean that we will not be having diabetes, mean that someone who is having probably a normal birth weight with less fat percentage will not able to see and continue. You have to continue all those things. It's not like that they will not have to do the exercise throughout the lifetime. You miss the bus. Suppose you have born with a 2.8 kg with a higher fat percentage, you can't do now anything. You can do what? You can continue to exercise to decrease your fat percentage. You can continue to remain more active. So we have to work on a young girls. We have to make them a healthy mom. Then we have to work in a school kids for healthy school kids, healthy youth, and probably then we can think of a disease-free adults, maybe preventing diabetes. So it's not like that someone is already at this stage with a high risk and you are working only this. We have to work continuously for all of them. This time again, in 2024, we again met the President of India, and in between we had work, whatever work which we have done. We met the health department, we met the government of India, we met the, I became the part of the health ministry as one of the experts in the technical committee also, and we met and we had given and we had an opportunity to discuss our mission and Honorable President with Draupadi Murmu about the diabetes prevention. We had given a white paper to them also that primordial prevention of diabetes for future generation is possible. To conclude my talk, that invest in health of every female child, and we have to develop the healthy habits in early childhood with a school curriculum with a health and fitness, workplace, sit and standing culture, incentivize healthy habit, above the age of 45, definitely a regular health checkup, early screening, even at the age of 25, and preventing sarcopenia. That's what we should do. We can stop the diabetes. We can close the gates for diabetes. Diabetes is a preventable disorder. Yesterday also in inauguration, I talked that Yako is the first one with this paper in 2000 had shown that diabetes is a preventable disorder. When I was studying medicine in 1993, we understand diabetes is a progressive disease. Now we know diabetes is a preventable disorder and diabetes is a reversible disorder, also with the Roy-Taylor data too. So we can change the natural history of diabetes, and let's close the gates for diabetes. With this, I invite all of you for World Congress of Diabetes, which is with the Diabetes Asia Study Group, along with our Diabetes India in city of Ahmedabad, in 13th to 16th of Feb 2025. Thank you. Thank you very much.
Okay, thank you. That was absolutely a snowstorm.
Thank you.
Of information and beautiful summary. So we will now move on to the last talk of this session. We will come back to questions in the panel discussion. Now, the next speaker is so well known that the pack actually does not contain a CV for him. So that indicates that Yako needs no introduction. We've heard from Yako several times through the seminar, through the conference, and We've also just heard from Dr. Sabu also that you were a pioneer in showing the world that diabetes is preventable. I think you need no other introduction, Dr. Jaco Tumoletto. Over to you. If somebody could help Professor Tumoletto with his slides, please. आप स्लाइड में थोड़ी मदद कर दीजिए, आ नहीं रही हैं.
Yeah, thank you very much, but I don't see my slides
Yeah,
here.
we're just trying to get them organized, Jaco. They're working on it over there. Please bear with us. Technical glitch. Jaco, while you're waiting, you can tell us about Finland.
Well, incidence and prevention of diabetes. We heard fantastic talk from Dr. Bansi just a couple of minutes ago about primordial prevention, but the genetics is still one step earlier. That already is in the germline of our parents before anything happens in utero. So these are findings from the diabetes prevention studies show very clearly that there is a possibility to prevent diabetes. And same in Finland and in India, the more you practice healthy lifestyle, the better it is. But still, there are people who are developing diabetes even in the diabetes prevention studies. Now the question, what is today very often asked is that can we use somehow the personalized or precision medicine in the prevention of type 2 diabetes? And type 2 diabetes is one of the best examples of chronic diseases for the development of precision medicine, because we know many predisposing genes, we know the lifestyle and environmental factors that we have discussed here earlier, biomarkers, a lot of biomarkers, and we have these simple diabetes risk scores. So basically we can tailor diabetes prevention very well. Now the genes may be in multiple ways involved in the development of diabetes. Of course, the genes are already important for risk factors like physical inactivity, early nutrition, diet, and even intrauterine environment. Now then we have genes for insulin resistance, obesity, and most of the genes that we know today for diabetes are actually somehow related to insulin secretion. The first thing where a genetic effect can be identified is a family history. And this is from the large Interact consortium where Nita has been involved. This study shows very clearly that there is more than twofold increased risk of diabetes in those individuals who have a family history. Whether it's a paternal or maternal, it doesn't make a big difference, but if both parents are diabetic, then there is a fivefold increase in risk. We did in Finland a large twin study about more than 12,000 twins and looked at the monozygotic and dizygotic twins. And you can see here For instance, if you take this proband-wise concordance rate, that overall in monozygotic twins, the concordance rate was 0.28, while in dizygotic twins, 0.12, so that it was more than double in monozygotic twins, but still it was only about 30% of monozygotic twins that were concordant for type 2 diabetes. So 70% of the other co-twin did not develop diabetes by the age of 60. So that means that whatever genetic effect there is, the penetrance of these genes is incomplete, and partially this is due to environmental factors. Now, the first genome-wide association study that was carried out in the mid 2000 pointed out several genetic effects and alleles that could be identified by genotyping. The most important being the TCF7L2, which had the highest risk, and then many others that some of them had already been identified in the earlier studies, some of them only in this first stage genome-wide association study. Today, we know more than 1,200 alleles that are associated with type 2 diabetes. Each of them have a small effect on diabetes risk. And these susceptibility genes do not cause type 2 diabetes. So the current analysis, the paper that was published this year earlier, included impressive more than 2 million individuals that were from our different studies throughout the world put together, where the genome-wide association was included. So there were almost 500,000 cases of type 2 diabetes in this study, identifying 1,289 independent association signals, and 145 were new ones not reported. And then in this analysis, it was possible to identify 8 genetic clusters for the signals that were distinct by the cardiometabolic trait associations. So it seems to be that there are genes that are working together in a certain way, but still we have to see what these clusters actually do in the future. So what about these genes? We have to remember first, it is not possible to get rid of these genes. All of you are carrying a couple of them. It's impossible to use any genetic manipulation to get rid of 1,200 alleles that are associated with diabetes. And then, number 2, these genes that are producing diabetes or associated with diabetes in humans, we see already in mammals. We know that the cats and dogs can develop diabetes, even whales. There was a movie, Free Willy, and this Willy actually was a female Keiko whale, and she was diabetic because she could not move too much in the small pond she was living. Now, the one thing is that we can put these genes into the score. The more you have these susceptibility alleles, the higher is your risk of diabetes. However, like in this paper 10 years ago, looked at the Framingham offspring score, the diabetes score, and then added a gene count score to that. And you can see from the ROC curve here, it did not change at all. So the genetic effect did not improve the prediction that was already by some other lifestyle and biochemical markers. And then, however, in a more simple risk assessment, just looking at the age and sex and the area under the curve among the Indians in the UK Biobank and then Genomega in India. And you can see here that in this situation, the PRS, which is polygenic risk score, improved the prediction significantly after the age and sex had been taken into account. A Chinese cohort recently looked at the association between the lifestyle and the genetic risk, dividing a genetic risk by the polygenic risk score into 3 categories. And in the low genetic risk, the poor lifestyle doubled the risk, whereas intermediate and ideal lifestyle or intermediate lifestyle did not have any effect. Whereas in the individuals in the intermediate genetic risk, intermediate lifestyle already doubled the risk and poor lifestyle almost tripled. And then in the high genetic risk, even the ideal lifestyle already doubled the risk compared with the low genetic risk and ideal lifestyle. And there was, with the poor lifestyle and high genetic risk, there was a 4-fold increase in the risk of diabetes. So there seemed to be an interaction in a way between lifestyle and genetics. This lecture was actually going to be presented by Oscar Rodriguez, but unfortunately he was hospitalized for some acute operation, so I promised to replace him for this presentation. And I go through a couple of things that may be interesting. The first thing is that the genes actually are your side. They are not only harmful, but many of the things actually of the genes are to help us to remain healthy. And also, as I said, the genotype and phenotype relationship and lifestyle are important. And then there are clinical applications from genetic tools. And I go through a couple of genes, what they do, like the FTO gene, the first one with the obesity. We can use FTO gene for the personalized weight loss programs. And then this important TCF7L2 is important in the way we know that with the interventions with diet, we can improve insulin sensitivity in the carriers of this gene. Same, the insulin growth factor binding protein 2. Again, the diet would be helpful in the individuals who are carriers of these genes. These genes are related to insulin secretion, and we know that the neonatal diabetes is one where the problem is that these individuals have a diabetes at birth. It is not type 1 diabetes, and they are very well tolerating sulfonylureas because that's the place where this gene is working. And then comes the cardiovascular effect with another potassium channel gene, which is KCNQ1. Another one related to sleep, which is important for diabetes. Again, the carriers of this, the alleles of ADCY5 may benefit from therapies targeting sleep regulation. Now then, the cancer is common in type 2 diabetes, and then we know that, for instance, this JASF1 is associated with cancer, so cancer risk monitoring carriers of this would be helpful. More to go in different, I'm not going to very much details into this, but take this PPAR gamma, which is the first candidate gene identified for type 2 diabetes, and this is benefiting from a treatment that are actually affecting the PPAR gamma in the cells, which are the glutathione very well tolerated, and then there are other genes still. Not going into the details, I just will show that we know a lot of things where the genetic effects exist. Now, go to prevention. We looked at the different candidate genes in a diabetes prevention study. For instance, this PPAR gamma. Individuals in the intervention group who were carriers or homozygous for 12 allele, they lost most weight and nobody became diabetic. Whereas in a control group, no weight reduction and 43% in 4 years' time developed diabetes. Then this TCF7L2, TT, homozygous individuals had the highest risk to develop diabetes compared with the G allele carriers, but in the intervention group, the carriers or homozygous for the TT genotype, they had a 5 times less risk than the control group. So the high-risk individuals benefited very much from a lifestyle intervention. Yet another one, alpha-2 beta-adrenergic receptor gene in the control group, 9 homozygous, GLU9 homozygous individuals, they had a more than 30% incidence of diabetes, when in the intervention group, only 2%. Fantastic effect in this high-risk population. We looked at the different effects of physical activity and diet with this gene, and we could see that in people who were 9 carriers, they benefited from diet. With a healthy diet score, the risk was 80% lower, or reduced by 80%. 9 homozygous individuals did not benefit at all from physical activity, whereas the low-risk allele carriers, 12 homozygous, benefited from physical activity. So we know that there are many different ways we can make use of our genes. It is early still to find out what to do, how to do. As I said, 1,200 alleles are known to be associated with diabetes. The one thing which is my colleague, the Oscar Rodriguez, has been working is the Diabegen, the genetic work for early and precise intervention. They developed the genetic prediction model using first in Broad Institute in the US, the large cohort and cases and controls, the panel of genes that could be used, and then it has been validated in other cohorts as well, and they came up with 16 different SNPs where the area under the curve with this combination of these 16 SNPs was 0.82 with a good sensitivity and specificity. So this test then has been used commercially, and this can be identified a low, medium, high genetic risk as this company is producing. They don't want to have a precise, although they can calculate the precise percentage, but they prefer to have a low, medium, high, so that people can send the saliva samples and then they will get the results this way. And what these 16 gene variants are doing, some of them are related to insulin production, some of them to insulin resistance. And as I earlier explained, then the intervention can be decided with the lifestyle or pharmacotherapy, which one to use based on the outcome of these different genes. Now, it has been discussed now that these polygenic risk scores have a potential benefits. They have a potential risks, and the knowledge has gaps. So it can be, as I pointed out, that the genetics can be used to enhance primary prevention, better diagnosis, and improved precision medicine. But there are many potential risks, uncertainties, misunderstandings, misuse, and so on. And therefore, there is a common alliance of polygenic risk or task force that is recommending that more work is needed, and one has to look at the genetics, laws, ethics, and so on before widespread use in the clinical settings. But going back to this Patia Diabogen results, they are providing, based on their findings, when the patients or people are getting the results, the company is providing information what this person should do with the nutrition, physical activity, some food supplements, for instance, and what the pharmacotherapy could be best for these individuals. So they try to balance not only providing genetic information that you can buy in the internet yourself, which doesn't tell you anything, you just give the panel that you have these and these genes, but this Patia test gives reports also in that way. So I would like to thank very much for everybody who has been organizing this meeting, myself included. So thank you very much.
So thank you very much, Professor Tumiletto. Could I request all the 4 speakers to be up here? We will take just up to 5 minutes at most to answer any questions from the audience. So we've had a mixed bag of diabetes prevention. We've gone from gestational diabetes to the role of physical activity, to primordial prevention, the importance of the female child and women and pregnant women, and we've had the genetics. So, any questions? Okay, please go ahead. Please say who you are and where you're from, briefly.
I'm Partha Faruhi. I'm a surgeon from Cambridge. What we've heard here has been although it was called a mixed bag, actually it was quite a cohesive mixed bag and very, very interesting. What I wanted to ask from the panel, and particularly Dr. Sabu, according to the World Inequalities Database, India is one of the most economically divided countries in the world. The top 10% of the population of India control 80% of the wealth, while the lowest 60% have access to about 5% of the wealth of the country. My question is, do epidemiological studies based in India can they be reliably used to make policy if they're not stratified for wealth? We've traditionally seen stratification by urban and rural India, but if they're not stratified for wealth, can they really be reliably used to make policy for the future of India?
So it's really difficult, but there is a lot of disparity, as you have very rightly said, that, the 20% of the people who are advantaged and they get everything, while the 80% of them, they can't get everything. And to make the policy for them is again very difficult for that. So at this point of time, I don't think in the immediate future that we will able to make some strategy for them also. But still, if someone wants to give answer like Dr. Yagnik or Dr. Shashank wants to make the comment on the same.
Okay, last year I contributed two inequity articles. One is a series in Lancet, driven from New York. And I have talked about inequity in the intrauterine life. And last month I have written a comment in Lancet about double burden of malnutrition in India. And that's a very stark example of inequity. And in the GBD paper, which was published before that, they said Southeast Asia and India are the prominent examples of double burden of malnutrition. So everyone, like say in general a physician or a surgeon, look at adults, but my plea is to look at inequity even before you're born. And that to me, I'm going to ask Jaco. Jaco talked about gene-environment interaction. You didn't mention about any interaction of genes in the intrauterine environment, where the epigenetic programming is very active. And within first few days of conception, your susceptibility to whichever non-communicable disease is established quite high. So I think actually that's the area which has been forgotten. And we have been talking of either smoking or physical activity in adult life, diet in adult life, but not in the early life.
Yeah. Yeah, you're having a very important question. What I showed, these genetic effects, they mostly were just a cross-sectional data, just a snapshot one time and the information. Of course, in our prevention study, we had a modification of lifestyle with that. But what you are saying that, well, what happens to the next generation and to what extent these genetic effects may be modifying what happens to the next generation offspring. And more importantly, of course, as you have shown, the epigenetic effects that we have inherited through our mother certain things that actually are not by DNA inheritance, but something else, and these are extremely important that for the future as well. So my presentation was oversimplification of genetic findings. I just wanted to show that there are important findings.
Yeah,
And in Jaco's defense, in 20 minutes, we can only cover so much. We need a whole session on it.
As a DOHAD person, I feel we should stress DOHAD
Yes,
more than what we do.
absolutely. And I think we need more sessions on that, for future. I think that's something we'll take on board.
I have similar comment for Maria. Okay, Maria, we have now 30-year follow-up in our birth cohort and 3 generations. And I can now trace glucose of a girl born between 1993 and 96 up to 2024, a total of 5 readings. At 6 years of age, 12, 18, in pregnancy, and 3 years after pregnancy. And what I find is the glucose in pregnancy is only a window in what's happening from 6 years. I presented this at ADA last year and said that diagnosing GDM in pregnancy is like closing the door after the horse is bolted. And therefore, one of the reasons, which you mentioned other reasons, is that actually it's all happened before. And what we are doing is we have different cut points in and outside pregnancy. Then we arbitrarily classify them based on different outcomes and then try to find some solution there. Instead of that, if we just look at it as a continuum, then I would say the intervention which you mentioned should happen before pregnancy. But you are trying to make it high risk, those who are on insulin treatment. I am David Barker's, he is my guru. And David Barker's guru was Jeffrey Rose. And Jeffrey Rose said if you concentrated more on the population than the individuals who are outsiders, then the benefit to the community will be much more. And therefore my plea is we concentrate on the community, and Banshi summarized many of these, then we might have a much better effect in preventing diabetes and cardiovascular disease.
I could not agree more.
Thank you.
Yeah, and putting together the previous question with what you are saying now, almost everything we are doing just increases inequities. So we really have to think more about ways of doing prevention that it makes it in a more equitable way. But I agree entirely with you, and I remember our conversations in Denmark years ago about this.
Okay, thank you for that. And on that note, I think we will bring this session to a close because the next session needs to start. And a round of applause, please, for our 4 presenters.
Take a picture.
Please come photograph and for your gift if there's one.
Thank you for the wonderful session. We would now have a small debate. Can diabetes epidemic in Asia be prevented in the near future? I would like to call upon the chairpersons, Dr. Knut Bosch Johnson and Dr. Pablo Ashner. Thank you.
Thank you. And we'd like to start this session in a slightly different way than the others have started. So before we invite the speakers to the podium, we would like to make a vote among all of you sitting in the room. Because the question raised is, can diabetes epidemic in Asia be prevented in the near future? Yes or no? Who in this room would answer that question with a yes? 2, 3, 4, 5, 6, 7, 8, 9. Please keep your hands up. 9, 10, 11, 12, 13, 14, 15, 16, 17. And
the 2 speakers voted in the same direction, didn't they?
that may make it a dull session. Who still dares saying no? 1, 2, 3. So, Mohammed, you will have a hard job. If we start off with Shasnik Joshi, would you like to introduce the this discussion?
Yeah, I think, Mohammed and me are both on the same page. So this is not a debate, but we have to debate because we are good friends. So diabetes is absolutely preventable, and this is why this conference is here. So I don't have any duality on conflict of interest for this meeting. My only conflict is Mohammad Hasnain, who is my very close friend. And they have deliberately put the two of us to debate for the sake of debate. And Amit showed in the morning yesterday that very clearly Jocelyn, said that prevention of diabetes was very doable in 1921. But historically, if this debate was held 100 years back, Mohammed would have won. Because, that time it was discussed, there were lack of rigorous trials, prevention efforts were small scales, they lacked experimental design. So Mohammed, all this is for you. Okay, reliance and limited evidence was there. And then, as diabetes prevention advanced, we have Yako in the audience who's a guru in prevention, Peter in the audience who's a guru of prevention, Ramu from here is a guru of prevention. Population studies and RCTs, more and more robust research came. And we have Professor Yagnik who says now we can even in utero prevent it. There were lack of agreed definitions. So early studies were hindered by absence of standardized definitions. There was limited use of behavioral interventions, and evidence-based medicine came very late in the 70s. And by that time, diabetes type 2 was epidemic. So clearly for successful diabetes prevention, the prerequisite is agreed diagnostic criteria, understanding risk factors and natural history, affordable and acceptable screening, and influencing the modifiable risk factors. Some factors can't be modified. We clearly need proof of concept to population level trials, and we have evidence in that direction. In interventions and even policies now, and postponing type 2 diabetes onset is today possible. We can delay it successfully. And WHO started this endeavor in 1980s. We had a lot of people. Then, of course, we had the King study very clearly showing interception and intervention. And this is Yako's paper here, seminal with Eva Wolf, saying primary prevention of diabetes is very doable, 1987 diabetes care. And clearly you can see World Assembly adopted it as a recommendation at a population level for prevention. The WHO study group was formed in 1994. The UN had an NCD summit, and clearly they looked at diabetes as a target. Then, of course, the Finnish study again came from Yako's group, the type 2 diabetes DPS from Finland. And again, a very, very seminal paper, very, very clearly showing the impact of healthy diet, physical activity, and weight reduction. And their long-term data of sustained lifestyle post-intervention was there. And then came the DPP program in New England Journal of Medicine, which clearly established beyond reasonable doubt that this is something which is very doable. Whether it's lifestyle, metformin, placebo, you can at least in 60% of cases get compelling evidence. What about Asia and India? We have studies from China, from Japan, and of course from India. IDDP-1, IDDP-2 from Ramu's group, and Ramchandran very, very clearly showed that it is possible. In RCT fashion, we can make an impact. So we have data from China, Daching study, Finland, United States, and India, and clearly Japan, all of them clearly recognizing the fact that diabetes prevention is very, very doable. So what did all these trials on type 2 diabetes prevention show us? Well, eat less, restrict food, fat restriction, physical activity, follow up, and clearly we can see there is some degree of ethnic variability. But the data is very clear cut and compelling to show that this is something which is very clearly. So the consistent risk reduction across all RCTs is so compelling that it compelled Mohammed also to put his hand up because he's an evidence-based person like me. The preventive impact is very rapid. The gender equality benefit is there and it is effective across all ethnicities. So I think this is something which we need to recognize. It's independent of the initial body weight. The benefit is multifactorial. Postponement of onset and residual risk, as well as even if there is a high genetic load, there is a possibility. The Chinese study actually had a 30-year follow-up. And you can see from the 30-year follow-up also, you can clearly see the risk of complication, and this is a prevention congress and a complication prevention congress, that data also has very compelling evidence. So long-term effects of type 2 diabetes prevention programs in meta-analysis show that a good 1 on 5 or 20% risk reduction of type 2 diabetes during non-intervention follow-up periods is also seen. And the DPP outcome study also showed that clearly we can see post-trial, and Darjeeling study from China showed 49% reduction. And the sustained durable effect after a decade was seen in the Finnish DPS also. Again, this is the DPOS study. Even in the youth, we have the same thing. And then, of course, we have the Fin D2D or the DECO program. And clearly, you can see that the real life setting, the translation is possible. So, Finland showed the way, both for type 1 and type 2 diabetes, but risk factor scores also became a tool. And you know that US and even now India has a diabetes control program. It is possible to prevent. The challenge is that the geography of South Asia, East Asia, which is the debate, has a disparity, unlike the West, because 80% of the diabetes is now in the low and medium income countries, and emerging studies show that the impact of intervention is probably much more compelling in these geographies. And the only debatable issue is the implementation approach. Whether to use an individual-based approach with community health workers or a broader population-wide strategy. And the role of NGOs in service provision, advocacy, and supporting health initiatives. So clearly, landmark trials have shown that prevention is very compelling. It has a global impact, national and international. Benefits are sustained, and real-world implementation is a challenge. And my worthy opponent will try to see how to beat me to the post. In fact, the best of this came when the ADA-ESG adopted the 5 S's. We all are sitting. Sitting is the next smoking, sweating, stepping, sleeping, and muscle strengthening. The 5 S's, they got ingrained. And you know, from our own ICMR in-depth study, Dr. Mohan and many of us who are a part, Bansi, myself, we tried to show that if you just cut carb, add protein, we actually can even drive remission. In fact, we have shown that remission is possible. The STAGE program, in fact, Dr. Bansi and me are authors on that. At a stage level, we can even look optimistically for remission. We have done an RCT in remission space, where now we have moved beyond even prevention into the remission space. And we have our own lifestyle. In fact, India has got its own physical activity. We need to promote that. We need to ensure that we use the simple mantra for prevention. And my simple mantra for prevention as a warrior of diabetes, which Manoj has very nicely put with Purvi, is that we all need to eat slowly, we all need to eat less. Though I'm talking fast because of brevity of time, okay? We all need to eat right, but we all need to eat slowly. I all saw each one of you what you all were eating today, and we are all eating extra fat and extra carbs and not adequate proteins. Hardly anybody was in the gym. We definitely need more physical activity, some yoga, some sleep, and we also need some smile. And we also need to understand that we are not just looking at prevention with a health outcome as a metric, but also as a happiness outcome as a metric. So I am certain that my worthy opponent will try to put some bullets in me, but I'll be happy to counter them. Okay? But I think it's a no-brainer that type 2 diabetes is preventable with evidence. The challenge is implementation. And the second caveat, which I want to tell each one of us, is that if we don't prevent type 2 diabetes in our geographies, they'll bankrupt us. So it's an economic consequence which is very huge to the population, which is a young population, because these are young countries and developing nations, and therefore the threat of economic bankruptcy is very high if we don't make urgent footsteps towards prevention. Thank you so much for a patient hearing. Please do an hour digital detox today.
Thank you, Joshi. And now, your opponent. I want to call Professor Mohammed Hassanein. He's a consultant in endocrinology and diabetes in the Dubai Hospital in the Emirates. has authored and co-authored many research papers. We didn't do the same with Joshi because he's local, right? But you're almost local. And so he's has been very instrumental in many guidelines, particularly in Ramadan guidelines. And your argument now is that we are not being able to prevent diabetes epidemic in Asia.
Thank you very much for this absolute humongous challenge. I think it was only 3 people who said no. Okay. So I honestly think that my very good friends at Scientific Committee hates me. And that's why in a prevention conference they put me to debate against my friend and one of the gurus here on a prevention conference to say no. So what chance I have? I also would like to share a disclosure that personally I'm very passionate on prevention of diabetes. Indeed, we have already a study that has been submitted for a grant on prevention of diabetes with Mohammed bin Rashid University, the university where I work. But I'd like to go back to important point. The debate is, can diabetes epidemic in Asia be prevented in the near future? So the title is very important and every word is very important. I'm not debating the science of prevention. I'm debating what I've been asked to debate, which is, can it be implemented in the near future in Asia? So 2 factors here, near future and the location. And certainly I'm not debating, because one of my colleagues was saying to me, metformin works, Mounjaro works, Ozempic works. This is not prevention of diabetes. This is treatment of pre-diabetes or treatment of obesity. So I think we first need to go to reality and some numbers. Numbers talks. You've seen this, I don't need to show it to you again. And you also have seen the fact and the reality. The Southeast Asia and Asia in general are among the reds, which means the highest proportion of pre-diabetes. So we need obviously to act. And the question is, why is the region, as well as many other regions, Middle East have the same problem, Africa have the same problem. I worked half my life in UK and the last 11 years in Dubai, and I can see that I've been exposed to the Indian food when I was in UK. It's lovely, it's delicious. You've all been experiencing whether you live here or whether you're guests. But it's also very rich in carbs and fat, and specifically carbs. And what we know from some of the data of Pure, which was published, that the highest consumption of rice is in this region, globally. This is data that's published by the ADA. I think the Pure group is very well known, and Professor Mohan was the second author on this important paper. Professor Mohan from Chennai did this beautiful data on the, I'm sorry it's not very clear, but you will soon see, this is data on the glycemic load versus family history. So glycemic load is almost equivalent to the family history of diabetes. So clearly it's our behavior. It is it's our nature of what are we eating and what are we drinking. And on top of the lovely Indian food, we also have the explosion in fast food. And similar sandwiches are in my home country, Egypt. I didn't grow up when I was young to have fried potatoes in sandwiches, but it is existing now in many places, as you can see in this very nice photo. So double whammy of carbohydrate. Urbanization comes with lots of advantage, and the motto for the conference, as you can see in the bottom line, is signs of urbanization. And urbanization also comes with a big price. Again, this is data from Professor Mohan on the comparison between rural and urban, with the impact on central obesity and the other factor of the sedentary lifestyle, which make the prevalence of diabetes between rural India 0.7, and urban India being 11.3. So this is again not the genetics, this is the behavior. Behavior of the lifestyle that we're exposed, what we eat and what we do. This is data from UK, from the Public Health England report. Prevalence of diabetes in Asians in UK is double the white population. Why? The genetics has not changed. It's the same genetics. It's the environment. It's the lifestyle. This is data that I published with my colleagues from Dubai Household Survey on pre-diabetes in Dubai. The vast majority of expatriates in Dubai are from Asia, India, Pakistan, Bangladesh. And as you can see, it's very unfortunate that we have 4% of pre-diabetes in people in their 20s or 18. By the age of 60, almost 1 in 2 have pre-diabetes. And the prevalence of pre-diabetes of expatriates in Dubai is equivalent or slightly higher than UK. And we did a study which very similar to what was said before. In those who are physically inactive or low physical activity, it is 1 in 4. 1 in 4 persons have pre-diabetes. So again, it is the physical, it is the lifestyle of the individual. This is data published by the IDF. Prevalence of diabetes in Mauritius, which is mostly people of a similar genetic background to India, but it is triple the level of diabetes. So again, it is the environment. So prevention plans. This is what the ADA says 6 years ago. You need annual monitoring. You need intensive behavioral lifestyle intervention. And you need technology-assisted tools, and of course, it has to be cost-effective and covered. Now, we also, in Emirates Society guidelines, we simply said, for treatment of prediabetes, 6 months of intensive lifestyle modification program. But the reality is very different. The reality is we talk the talk, but are we walking the walk? This is the reality. So I do not disagree with any word that Shashank has said. The science is definitely there. But the question is, could it be implemented and in the near future prevent diabetes in India? And I would like for you to see again, what did the Finnish diabetes prevention study do? What was the intervention? The intervention, as you can see here, is a heavy exposure with a nutritionist. The vast majority of us are working in places where a dietitian or a nutritionist is not existing. And here, it is not just they saw them 7 times within the first year. And then on top of this, voluntary session, expert lectures, cooking lessons, visits to supermarkets, between visits, calls and letters, and not just the education for the person with diabetes, but the spouse as well, the person in control of the shopping and the cooking. And then the second part of the intervention, the exercise. Comprehensive advice by the nutritionist and the doctor for what? Supervised, individualized, progressive, tailor-made exercise that offered free of charge on an intensive level, and on top of it, motivation and competitions among the group, and voluntary walking and hiking. Wow, I would love to have this for the population. We certainly can provide it in a study. We can provide it in maybe a setting that is very good with support, with motivated people. But can we apply it for the community? Well, the UK government have tried. Since 1991, they have 14 UK government strategies containing 689 policies for obesity prevention. Yet, obesity is getting worse in UK. And in fact, the report on tackling obesity says, despite 3 decades of strategies, policies, and institutional reforms, obesity in the UK has continued. Every target has been missed. So this is a government that is trying very hard in a Western society with NHS, with very good support for the whole community, not as mentioned by the massive disparity between some groups and other groups, and the same in so many other countries. But having said that, unfortunately, it was lost. Why? Look into the beautiful Look Ahead trial. The beautiful Look Ahead trial have shown us that we can reduce weight, we can reduce waist circumference, we can increase physical fitness, and we can reduce HB1C only for the 12 first year, or the 12 months of the first year. And then everything went back to pre or baseline level. Why? Well, I asked myself why, and I had to go to the supplementary of the document, because simply the intervention was for the first year. What was the intervention? The same as the Finnish and the DPP trial. Intensive exposure for the first year. But then, when it faded out, everything went back. So we don't need just intervention. We need sustained intervention. And the motto of the conference, we need warriors for prevention of diabetes. Of course we need warriors. Definitely we need them. But warriors need weapons. Now, are we providing our warriors with weapons? Are we the target for the prevention? We are part of the equation, but we're only the small part. Look into what IDF, as well as the European group, have said for cities, scoring cities for suitability for prevention of diabetes. What would be the ideal, or not the ideal, the requirements in a city that would be good for prevention? Suitability of outdoor environment for sports. I work and live in Dubai for the last 11 years. It's not possible in many places to walk because there is no walking path. It's mostly for drivers. The streets are for drivers. And then, of course, access to healthy food, access to drinkable water, education on healthy choices in schools. Implemented prevention policies, implemented, not a document, implemented. And of course, accessible information on healthy choices. When you look into what is required as an action, it's not just us as healthcare professionals doing prevention conferences. We need the input of every health secretary, as well as health authorities and private sector and insurance companies. We need the input of the Ministry of Education, the Ministry of Trade, and the Ministry of Sports. So many things need to change. The media, the diabetes societies, locally and internationally, the pharmaceutical industry to help, and so many others, as well as prevention programs that are evidence-based, culturally sensitive, acceptable for all ages, and accessible to the majority of those at risk, rather than a motivated group in a well-structured program in a university or in a diabetes center, and then publish a study. Of course, the answer is to prevent the problem, so prevent the weight gain and the pre-diabetes, rather than try to treat it afterwards. And of course, as Banshee said earlier, the healthy women and the children in general to prevent the problem. So I'm afraid we have to walk the walk, not just talk the talk. And unfortunately, in many countries, there's been lots of studies, lots of talk, but the implementation has been a challenge. I personally would love to break that challenge. And the study that we're trying to do is to try to see whether there is something that could be done on a bigger scale that would be implemented. So thank you all. And Shashank, I hope I didn't disappoint you too much.
Thank you very much, both of you. And we have very limited time now for the discussion. So I would just ask Shashank whether you have a short comment before we take a second vote.
So, very, very short comment. For science, look global, not local. For implementation, have local ideas, not global.
Thank you very much. And on that basis, unfortunately, I'm sorry, but we'll have to do the vote once again. Who would then, at this stage, say, yes, it is possible? 25. And who would say no? 6. That is 9 or 10, so 11, including you. So
From 3 it was, an increase of 8 from 3.
yeah, so you definitely have increased. I just, at this stage, would like to remind you about two things. Back in time, there was a discussion why people in the fleet were developing scurvy, and you all know it's due to vitamin C. I don't know whether you know, but it took 97 years from the observation until it was introduced in the Royal Army. And it took 156 years before it was introduced as a mandatory equipment in the rest of the commercial fleet. So that says something about the delay in implementation. And even with smoking, the big studies by Hammond and Peter and Dull were done in the late 40s or published in the late 40s and early 50s. And we are still struggling with the problem of young people starting smoking all over the world. I have to say I'm also an optimist, but I also think we have to be a realist and facing the challenge in addition that South Asia is an aging population. You have a very, very large young population that is going to get older and is going thereby to be exposed to chronic diseases. I'd say you really have a hard job going back and prevent the diabetes epidemic. Paolo, you also have a few comments in the end.
Well, I would just say that we haven't defined what's near future. And so if it's tomorrow, probably the answer is no. If it's day after tomorrow, who knows? And the other point is that this is a bit like the glass is half empty or half full. So I think both made good arguments, and we have a lot to think about, and particularly a lot to work about. The Cambridge way to define who won is not who got most votes, but who changed the most. And so Mohammed managed to triple his votes. Yoshi increased like 50%. So I think there's a truce. That's the diplomatic way. Okay, thank you.
Thank you so much.
Thank you, speakers and chairpersons. That was indeed a very great debate. Moving on to the next session, which is a very interesting symposium on global solutions in diabetes, for which I would like to invite chairpersons Dr. Smita Patil, ma'am, from Mumbai, and Dr. Jean-Claude from Cameroon, sir. Please welcome. Over to you, chairpersons.
Hello, good afternoon, one and all.
After hearing so much about prevention of diabetes in Asian region, now let us move for the next session, which is very interesting, about the global solutions in diabetes. For this, I like to invite Dr. Neeta Farohi. She is Professor of Population Health and Nutrition, Head of Nutritional Epidemiology Program at the Medical Research Council Epidemiology Unit, trained in medicine, diabetes, endocrinology in Newcastle, earned a master's and PhD in epidemiology, elected Fellow of Academy of Medical Science, and authored more than 350 scientific articles. So she will be talking on a very interesting topic on carbohydrates in diet.
Thank you very much, ma'am. So, low carbohydrate diets, are they good, are they bad, or can they be balanced? I have no conflicts of interest. All my funding is from government agencies. So, firstly, how do we define what is low carbohydrate? Well, there's one definition given in this particular paper in 2015. There are some others that exist, but this has been commonly adopted. And in this, if we start from the bottom, high carbohydrate intake is seen as above 45% of your total energy intake, and on a 2000 kilocal diet, that's more than 225 grams of carbohydrate per day. Then moderate is 26 to 45% of energy. Low carbohydrate, which is what everyone talks about, is less than 26% or 130 grams. And then there is the keto diet that a lot of people talk about. Very few actually achieve it, but that is very low, and it's ketogenic for that reason, because ketones are produced, ketone bodies, 20 to 50 grams or around under 10%. So why are we interested in low-carb diets? Is this scientific progress, or is it shifting popularity? Now we know, and we've seen again and again through this Congress, the slides about primary prevention. What were those diets? Professor Tumiletto is sitting here. What was the diet in the Finnish diabetes prevention study? Was it a low-carb diet? No. What type of a diet was it? A low-fat diet. Saturated fats and total fats were under the recommended limits, but it was a high-fiber diet. So we've gone from an era for decades since Ansel Keys first talked about the benefits of the low-fat diet in the 1950s and 1960s, all the way the pendulum has swung into now almost a craze, and for some people almost a religion around going low-carb. And in this paradigm, the advice is actually eat fat, and eat fat liberally, because in fact, shown in that little dice is the fact that within what we call an isocaloric diet, your energy is fixed. So if you're going to reduce carbohydrates, you're going to eat more of the other two macronutrients, which is fat and protein. So there's a lot of interest and passion, but there's also confusion. But what's the actual evidence? So here our job is made easy. This was a nice meta-analysis which looked at the dose-response relationship between carbohydrate restriction and glycemic control in people with diabetes. So this included a humongous 29 RCTs in it. And at 6 months, you can see that there's a tremendous dose response. The lower the intake of carbohydrates, 10%, 15%, 20%, and here's 25%, which would kick in that definition of low carb, and under 10% would be the ketogenic. There's a very impressive dose response. Glycemic levels are well controlled and HbA1c levels are down. But by the time of 12 months, and only 13 trials of those 29 had that data, the effect is non-significant. So we lose the impact that we saw in the shorter term. So we had a look at all the trials that were available for this up until 2021. And here is a summary on one slide of all the RCTs conducted in the world. This one slide represents billions of dollars of research money on one slide. And what does it show us? What it shows us that, again, at 3 months and up to 6 months, in some of the RCTs, we do see an impact on reduction in HbA1c levels of about 0.5% in HbA percentage units or 0.4%, but by 6 months, it's already beginning, the impact or the effect size is decreasing, and by 12 months, we do not see it. Okay. So in the UK, we, as a national committee, came together to appraise this evidence, and I was a member of this working group for the Scientific Advisory Committee on Nutrition, working with Diabetes UK and Public Health England. And we pretty much said what I showed on the previous slide, because we reviewed all those, all that evidence. So for body weight, there was no convincing evidence of a difference between a lower carbohydrate and a non-lower carbohydrate diet even at 6 months, and certainly there was adequate evidence that at 12 months there was no sufficient difference, significant difference between them. And for glycemic control, just really confirming that at shorter term there's an impact, but in the longer term there isn't. So the conclusion was that a lower carbohydrate diet can be recommended, but it's not the only diet that's available. So what diet works best for weight loss? Now this is moving outside of diabetes. Any thoughts in the audience? Which do you think will work best? Any particular favorite? Low carb, low fat, moderate macronutrients? Well, they all work as long as you stick to them. So it doesn't matter which particular diet you follow. It's about whether you can lose weight and what you can sustain. And here's another appraisal which included 53 different randomized controlled trials, and this showed that low fat versus usual diet does work for weight loss. Low fat against low carb, yes, low carb had a greater reduction, but before we get too excited, after all this enhanced effort that is put into trials, you just heard in the debate, how much effort goes into those individual coaching sessions and group sessions. The magnitude of difference between the two was only 1 kilo. That really is not this is statistically significant, but biologically it's probably meaningless. So the point is, there is no single best nutrient type. Adherence over the long term is the biggest challenge, and the best diet is the one you can stick to. What about long-term effects of low-carb diets? So this is going below 45% to 26%, or even below 26%. So when a score is created of a low-carb diet, this takes into account high carbohydrate intake gets the lowest score, and the lowest carb intake gets the highest score, whereas for protein and fat, it's coded the other way. So higher your protein, the greater the score. Now, this analysis published in the European Heart Journal was rather alarming, because in fairly rigorously adjusted analysis in prospective follow-up of 9 studies with nearly 500,000 people, the highest consumption of the low-carb diet, meaning the greatest low-carb diet, was associated with an adverse impact on total all-cause mortality by about 20%, on cardiovascular mortality by around 13%, and even for cancer by 8%. Now, this threw up a whole load of alarm and debate, and the usual dialogue of, oh, well, this is prospective evidence, and RCT evidence tells us different. But we've seen the RCT evidence, and the RCT evidence does not give us the long-term impacts. Now, these findings were actually replicated in other meta-analyses. Several meta-analyses have been done. I'm showing you only one. Mechanisms for this have been discussed at length, and we can talk about it if there's time, but they're not proven. Of course, some of them, the most likely, are through lipid levels, intakes of other foods, lower fiber intake, macro and micronutrient status, and so on. Now, therefore, all this research, pretty much exclusively done in Western populations, from that we can conclude that lower carb diets can be part of a menu of options to manage type 2 diabetes and its prevention through weight management. They can work, but they're not the only diet that works. And there's not a massive difference between them, particularly in the longer term. For long-term effects, those adverse impacts that I just showed you, further research is needed. But what about other populations? We're sitting here in India, and we've just been talking about South Asia. So when this was looked at in a global context, this was a very nice meta-analysis that looked at all the available evidence at the time in terms of carbohydrate intake, and it included the pure study findings that have been referred to earlier. Now, what this shows is that both lower carb diets and very high carbohydrate diets are associated with increased mortality. So there's a U-shaped, and in some studies a J-shaped relationship, and there's a sweet spot in the middle of optimal intake, which is somewhere around 45 to 50%, it seems. Now, this study is another meta-analysis that looked at carbohydrate intake, and it also found a J-shaped association. And you can see that the lowest risk, this is for diabetes now, is at around 50% of energy intake from carbohydrates. And what this usefully then did, it showed us a dose-response relationship in the Western cohorts and in the Asian cohorts. In the Western cohorts, you can see that there is no significant association. The confidence intervals overlap the line of 1. And you can also see that the intakes are generally lower. Carbohydrate intakes maximum across these studies was only up to about 60%. Whereas in Asia, it's completely the opposite picture. So here, you can see that the intakes are much higher, and at above 70%, the risk for incidence of diabetes massively shoots up. So there are differences by population, and it's not a one-size-fits-all. So what is the population intake? Well, in most of the studies which are from Europe or USA that were part of those earlier meta-analyses I showed you, the intakes are actually around what is considered okay. And it's in line with what the dietary guidelines, for instance, in the UK, for the population is to consume around 50% of your energy from carbohydrates, and we're pretty much around that. And our protein intakes are pretty adequate, and in fact, slightly above the recommended intakes overall in the UK, and similarly in the US. Come to South Asia, and the PURE study shows us that this is entirely different. So here, if we look at the median intakes in the Asian region, the intakes are at least 10% higher than non-Asian regions on average. And very helpfully, just in the previous debate, you saw something from South Asia in terms of the different intakes. And here, of many different regions that were compared, carbohydrate intake is the highest in South Asia, even higher than in Southeast Asia, Latin America, and all the other regions compared. And what's really alarming is that protein intake is the lowest in the world in South Asia. Okay, so this is a problem. Let's look at a case study. Now, the work of Dr. Mohan and team, this was also shared yesterday, showed very nicely in their modeling study, using real data from their work in the ICMR INDIAB study, and then together with computer modeling, they showed that to achieve remission of newly diagnosed diabetes, one would need to reduce carbs from 62% on average, which was the sample intake, by around 10% to about 52%. And for protein, it would need to go up from under 12% to around 20%, a near doubling. Now, it's easy to say, just as we heard in the debate, well, all we have to do is reduce carbs and increase protein. But how on earth do you do that in a society and in a culture, and also economically, what is feasible, what is affordable, what is available? How do you achieve that? And you can see that for India, the acceptable macronutrient distribution ranges, even with these proposed changes, are matched for carbs and fat, but for protein, this is a far-reaching goal. So India has amongst the lowest protein intake in the world, and much of South Asia does, and the conundrum is that cereals account for 60% of protein intake in South Asian diets. So if you cut down carbs, you're also cutting down protein, and that's the challenge. And this is where the importance of quality really comes in. Quality matters. So this is just one study I'm going to show you. There's a plethora of information, but this was an interesting one from a US population, which showed that not all carbs are the same. So starch, higher the intake, the higher the risk of incident diabetes. But for fiber, whether it's from cereals or from fruit, there is a lower risk of diabetes in the future. And this type of work has been done for many different outcomes. I'm focusing on diabetes. So the fiber content, whether the foods are whole grain or refined, they have been processed or not, what their glycemic response is after consumption, the glycemic index and load, and even the food structure, whether it is solid or liquid, makes a massive difference to glycemia after ingestion and then to longer term to diabetes. And we eat food, we don't actually just go and purchase nutrients, we go and purchase or cook foods, and we eat food within dietary patterns. So I'm going to show you just a handful of pieces of work that we and others have done. Now, the humble fruit and vegetables, the message has been around for decades, eat 5 a day. We did this work to add to that evidence to make it more robust, and instead of the usual food frequency questionnaire, we did very detailed 7-day food diaries, and we showed that quantity certainly reduces. The higher the intake, the lower the incidence, but variety is very important. Now, if most people are only able to afford, let's say, apples and bananas and oranges, and that's it, that is very low on variety. So the greater the variety, the lower the risk. Well, sweetened beverages tell a completely different story. And there's been a lot of discussion about fruit juice versus, and smoothies versus fruits as well. So in our hands, this was an 8-country study in Europe. We collected, ascertained nearly 12,500 cases of diabetes. And in massively adjusted analyses, we found that total soft drinks and sugar-sweetened soft drinks are associated positively with the incidence of diabetes. And what's really interesting is that even the artificially softened drinks, the artificial sweetened drinks, are also associated with higher risk, in fact, of a greater magnitude. It's only when we adjust for BMI that it comes down, but that could be reverse causation, right? So people who are more obese or overweight consume these as part of that control. So we went on to build this evidence base, and beyond the scale that I just showed you in that 8-country study, we went for 7-day diary analysis and for breadth by doing a meta-analysis, and the results were absolutely identical. Now, what did the food industry say? They said we were masquerading as academics and we're on a health crusade. But the government thought different, and the WHO thought different. They took our evidence very seriously and cited it in policy documents. And wind forward, that plus other evidence, we now have policy and taxation on sugar-sweetened beverages in the UK. So coming back to those differences by region, the PURE study also showed us that of all the world regions, the intake of fruits and vegetables is pitifully low. I mean, it is massively lower in South Asia, 46 grams on average per day, whereas the other places, the lowest is 84, or, it goes up to 300 and something elsewhere. And similarly for vegetables. And you already just saw, if you were here in the last session, that rice intake is off the scale. It's at more than 600 grams per day in Asia. And there is a link with diabetes. Now, what I want to finish with here is to say that low carb intake is not just about low carb. Going back to that dice that I showed you, when you roll it, it's got protein and fat in it too. And when you have low carb diets, what else are you eating or not eating? Well, this is just one example. Your cereal fiber intake goes down because you, by and large, consume fewer fruits and vegetables, which is also shown here. So in the most low-carb group, you can see that fiber intake is nearly halved here, and fruit and vegetable intake is considerably decreased. And red meat intake is increased from just 0.8 servings in the higher carb group to 2.4 servings per day. Now that's a massive increase in red meat intake, and whole grains intake are lower as well. And this was a study from UK Biobank that showed similarly that if you have under 26% of calories from carbohydrates, what are you eating? You're eating more proteinaceous food and you're having more meat. Now, very recently, just earlier this month, we published this paper in the Lancet, Diabetes Endocrinology, with nearly 2 million people from 31 cohorts in 20 countries. And this shows that throughout the world, there is a positive or an adverse relationship between habitually consuming more meat, red meat, and processed red meat. So there is a potential price to be paid for having low-carb diets, and one needs to be conscious to replace them with more plant-based protein sources and healthier sources of animal source of proteins. So summarizing this, not all carbohydrates are the same. The low-hanging fruit for dietary intervention, well, so what's the good? We've talked about fruits and vegetables and whole grains and high-fiber foods and legumes. Don't forget pulses, lentils, and beans. And then the bad carbs, the added sugars, the free sugars, sugar-sweetened beverages, refined carbs. And healthy swaps are really important. Brown rice instead of white rice is a useful strategy. Whole fruit versus fruit juice. And don't forget protein, because in an earlier talk we heard, and I very much want to emphasize the point about protein intake, because we are not just interested only in whether low-carb diets help with obesity or diabetes. Think about the entire lifespan. We're talking about frailty and sarcopenia with low protein intakes. So when there are high carb diets, protein intake is low, so we do need to do that. And I want to end with just saying, reinforcing what some other speakers have said, that we talk to people as if food intake is a choice, but is it really a choice? Yes, ultimately we decide what we put in our mouths, but there are so many influences on, price and cost, and fruit and vegetables in India are massively unaffordable compared to in the UK. On the usual income. And then there are all sorts of endorsements, and the money that is put into advertising foods, the research and policy simply doesn't keep up with that. When you've got the Khans of Bollywood promoting these drinks, what are the youngsters and others going to do? So I just want to leave you with that. And yes, there is absolutely a place for low-carb diets, but in the short term, they certainly are a convincing strategy, but there are other options available too. Longer term, we need to look at what the health impacts are. And in places like Asia, where the intakes are extremely high, the priority has to be to bring it down to around 45 to 50%. But how is the question? Thank you.
So thank you, Dr. Neeta, for enlightening us on a very practical topic. Any questions?
Can I ask a question?
Please.
Yeah. When you take low carb diet, inevitably you see the LDL level goes up. Does it nullify the effect of the benefit that you get with low carb diet?
Okay, so in individual patients, LDL may go up because the fat intake goes up, because if you have low carb, you have higher fat, usually, rather than higher protein in many places. But the RCT evidence, if you put it all together, at least at 6 months and even up to 12 months, there was no significant difference in the LDL levels. There was in triglyceride levels. They were better off in the lower carb, as you might predict. So for individual patients, yes, you do have to check whether the LDL is going up, and you would need to recommend that their replacement diet is not high saturated fat diet, but higher in polyunsaturated fats and higher in protein. And if the LDL needs management, obviously that should be implemented.
And the pure study you mentioned, that if you look at the consumption of carbohydrate, the higher the consumption of carbohydrate, higher the incidence of ischemic heart disease. Now, how do you explain that?
So in the pure study, that was not the pure study. Actually, in the pure study, it was the opposite. So in the Western cohorts, if you have low carb diets, there is some indication that longer term, there might be adverse impacts, and those might be from some of these mechanisms like LDL and lower fiber and so on. In the pure study, when they replaced carbohydrate diets with polyunsaturated fatty acids, there were benefits for heart disease and for total cardiovascular disease. But when they replaced carbohydrates with saturated fatty acids, there were actually benefits for stroke incidence, which means in that context, lowering carbohydrate intake, even by having saturated fat, was potentially good for you. And the mechanisms are likely to be that the intakes in Asia are just so high that those higher carbs are really having a health impact.
No, in fact, I remember Salim Yusuf talking about the pure diet.
I think we have to stop.
Just 1 minute. Just 1 minute, sir.
Yeah.
Because this is a very important part of the discussion.
We have a discussion session later.
Okay.
Yeah, we'll come back.
But just ask your question.
Sure.
Right. Thank you very much, Nita. We have to move on because we are running late, but we'll be able to, if we have time at the end, we would take more questions. The next speaker is Suresh Kolese, who is from Mauritius. Is going to discuss with us on diabetes, prevention of type 2 diabetes in Mauritius. And we know that there are so many colleagues in this hall who work in the Mauritius data. Please. He is the Director of Health Promotion and Research at the Ministry of Health. He's hosted also many times in Mauritius. And of course, he has specializes in non-communicable diseases, strategic health sector. As I said, he's involved in Mauritius NCD and nutrition surveys and coordinates the Mauritius type 2 diabetes prevention study, which was 2013-2016. He's published a lot and he's been recognized in his country as one of the leaders in contributors to health promotion. Please, you have the floor.
Thank you, Professor Jean-Claude. Good afternoon, everyone. So my presentation today is prevention of type 2 diabetes in Mauritius. So worldwide in 2021, 1 in 10 adults, that is 20 to 79 years, that is 537 million were living with diabetes, a global prevalence of 10.5%. And diabetes was responsible for 6.7 million deaths in 2021, 1 death every 5 seconds. So in Mauritius, a national NCD survey is systematically conducted nearly every 5 years since 1987 with the standard methods, giving an indication of the diabetes status, and all the surveys has been carried out in collaboration with international professors, and one we have here with Professor Timulato is here. So the standardized prevalence of diabetes for 25-74 years was 19.9% in 2021. And the pre-diabetes is 15.9%, hypertension 27.2%, obesity 36%, high cholesterol 34%, smoking 18%, and physical activity 40%. So there was a peak in the prevalence of diabetes in 2009, that is 23.3%. And after an aggressive campaign for diabetes prevention, we reached the prevalence of 19.9% in 2021, because the government, especially the Minister of Health and Wellness, is making a lot of emphasis on the prevention of type 2 diabetes. So we have a multi-sectoral approach, which is very essential, and due to different lifestyle risk factors of diabetes, diet, physical activity, tobacco, weight management, high alcohol intake. So preventive measures include action plans, policy, advocacy, and legislations, NCD screening program, community engagement and participation, communication strategies. So we have 3 important main documents. We have a health sector strategic plan 2020-2024, that is strategic goal 5, to reduce preventable and premature morbidity, mortality, and disability due to NCDs, including diabetes, by addressing the risk factors. And the second document, we have a national integrated NCD action plan, where we have a roadmap to improve health and well-being across life course of people through healthy choices and maximizing primary health care outcomes. And we also have a national service framework for NCDs with a policy set to define standards of care for NCDs within a service protocol with appropriate quality standards. And we have several action plans. We have National Action Plan for Tobacco Control, where the main objective is to prevent tobacco use, prevent exposure to second-hand smoke, and promote smoking cessation. We also have a National Action Plan to reduce the harmful use of alcohol, and the main objective is to reduce alcohol consumption and alcohol-related harm. And we also have a lot of policies and legislations for the promotion of diet. We have food regulation under the Food Act, which includes maximum permissible level of fats, prohibition of soft drinks sale in schools, ban of unhealthy food sales in schools. And we also have introduced sugar tax in soft drinks, including non-alcoholic sugar sweetened beverages. In 2021, the existing sugar tax doubled from 3 cents to 6 cents per gram of sugar. And we have regulation use of tobacco and alcohol. We have regulations under the Public Health Act, which include bans on tobacco, advertising, promotion and sponsorship. And we also have sales prohibition to minors, restrictions on consumption in public places. Tobacco control since 31st of May 2023 were reinforced. Plain packaging was implemented. No new tobacco vending license was issued for retailers within 200 meters of educational institutions, sports, leisure facilities. We have the promotion of physical activity. We have a national sport and physical activity policy 2018-2028, which was developed in collaboration with the Prime Minister's Office and other ministries. And the main objective was to foster a culture of community, sport and physical activity in Mauritius. We have the early detection of diabetes on any NCDs, which is critical to delay or prevent costly complications. We have the NCD screening program was set up for early screening of the population through mobile clinics in the community at their doorstep. And we have static measures were undertaken to reach different level of populations. We have a program at community level. We have work sites level, where we visit about 295 work sites and 270 community levels localities, where we screen about 40,000 adults every year. And also we work a lot with the non-government organizations to fight diabetes and to reach people different socioeconomic background. We also have a secondary school health program at the secondary schools, where we visit about 180 secondary schools every year, and we screen about 40,000 students between 11 and 17 years. We have a local health committee to undertake our health promotion and prevention activities at community level. We have a local health committees with different views of the localities, and we have the local health committees help us to sensitize on NCDs and their risk factors, and also organize health promotion programs and screening activities in optimized use of healthcare facilities available to the community. We also organize a lot of workshops for housewives on nutrition and healthy lifestyles to help them to choose healthy foods, meals for their families. And for the last year, we have organized for training for the workshop of the housewife about 1,500. We have launched Know Your Number campaign to fight obesity. And we have, for the Ministry of Health and Wellness, we have the physical activity. We have extended everywhere. We have 6 health tracks, 5 outdoor gyms, 22 health clubs, 77 localities with yoga, aerobic and physical activity sessions. We also have health promotion campaigns to increase awareness on health-related issues, including diabetes, where 4,500 to 5,000 visitors at each session we have it. We also have health education program through regular talks at community work sites and secondary schools, where around 113,000 talks has been delivered every year. We have 80 health promotion clubs at different ministries and departments to encourage public officers to practice regular physical activity, to sensitize on NCDs and risk factors and on healthy lifestyle through health club to organize NCD screening. We also have a communication strategies. We have a TV program, we have a radio program, we have a Facebook page, and we have just launched an application called Mo Bien-être. And we are also coming with a national strategy for adolescents' health. The main objective is to prevent risk factors for communicable and non-communicable diseases. And we are also coming with a national plan of action for nutrition. And the main objective is to promote appropriate diets and healthy lifestyles and to protect consumers through improved food quality and safety. So, achievements. So, if we compare our NCD survey 2015 to 2021, we have seen that there is a decrease in diabetes. Pre-diabetes has been decreased from 19.6% to 15%. Hypertension is stable. Overweight has been decreased. Obesity also has been decreased. And the total cholesterol also has been decreased. And smoking decreased. And alcohol we cannot compare because the methodology was not the same. And the physical activity has been increased from 23% to 40%. And also we have undertaken a national nutrition survey where we have seen that the daily soft drink consumption from children 5 to 11 years has been decreased, and the prevalence of obesity among adolescents has been decreased from 24.6% to 9%. And also we have seen that 94.5% of the population is consuming fruits. So, and also we have seen that death due to diabetes decreased from 26.5% of all death in 2012 to 21.8% of all death in 2022. And these figures show that the implemented strategic interventions and policies have been effective in preventing diabetes in Mauritius. So as per the 9th WHO report on the global tobacco epidemic 2023, Mauritius has joined the prestigious list of countries having implemented all the empower measures as defined by the WHO Framework Convention on Tobacco Control. So conclusion, we can beat diabetes. However, this ongoing fight against diabetes requires the engagement of different stakeholders, that is ministries, NGOs, civil societies, public and private sectors, academia, as well as the engagement of each and everyone to bring forth positive results. So before I end, I quote from the 26th US President, Theodore Roosevelt, "Believe you can and you are halfway there." So before I end my presentation, I would like to acknowledge directly or indirectly all those has contributed to combat diabetes. Thank you.
Thank you very much. I think we've seen how Mauritius has moved the ladder, you know. My only regret is that you don't publish it in peer-reviewed journals so that people would be able to cite them. But you have been especially an example in WHO country where you've done a lot in NCDs. We'll move on to the next speaker so that, thank you for finishing on time or before time, so that we have enough time for discussion at the end. The next speaker is Shenaz, who is from Turkey, with over 30 years experience in ophthalmology, with a focus on systemic diseases, and especially the eye. Is a founding member of the Board of Trustees, a member of the Turkish Diabetes Foundation, practicing ophthalmologist at the Ophthalmology Department of Istanbul, Florence Nightingale Hospital, joined the board of International Diabetes Federation Europe, and then served as chair of Europe from 2015 to 2019. She's teaching at the University of Istanbul. Shinaz, can you give us your presentation, please, in terms of systematic screening of retinopathy? Thank you.
Thank you. Thank you so much for this kind introduction, Jean-Claude, dear moderators and dear colleagues. First of all, I want to thank to the organizing committee for inviting me and giving me the opportunity addressing you. I have no conflict of interest to declare. I believe we need to set the scene right before discussing the solutions to tackle the burden of diabetic retinopathy, and I want to start with the numbers and their pattern. As the number of people with diabetes is skyrocketing, more and more people are at risk for diabetic retinopathy and other micro and macrovascular complications of diabetes. An alarming fact is that 1 in 2 adults with diabetes is unaware of their. It doesn't move. It moves here, but not there. Just a minute. Yeah, okay. I will go. Okay. Okay. So we know the numbers. The estimated global prevalence of retinopathy was 23% in 2020, which corresponds to approximately 103 million people. While assuming the rate of retinopathy prevalence to be constant over the next 25 years, the group who published this meta-analysis estimated that the global number of adults with diabetic retinopathy would increase by 26% in 2030 and by nearly 56% in 2045, with significant increases in the Middle East and North Africa, Southeast Asia, and Western Pacific regions of IDF. The Western Pacific will remain as the region with the greatest number of people with retinopathy in 2045. According to another meta-analysis, diabetic retinopathy was the only cause of blindness that showed a global increase in age-standardized prevalence between 1990 and 2020, among other leading causes of avoidable blindness. Diabetic retinopathy is an end-organ response to a systemic disease. Currently, we cannot prevent the development of the diabetic retinopathy, but we can prevent related visual loss by timely diagnosis of the vision-threatening disease, together with the good control of the systemic disease. For many years, we defined diabetic retinopathy as a microangiopathy with microvascular occlusions and increased vascular permeability. Today, we more and more define diabetic retinopathy as a highly specific neurovascular complication of diabetes. Since its first classification till now, the screening and grading of diabetic retinopathy and the decision for treatment of so-called sight-threatening disease still depends on the observed lesions at the back of the eye and do not include other parameters like functional changes of the retina. New insights from ongoing and future research, newer screening and treatment targets will pave the way for improved classification of the disease. This is the screening criteria for a disease as defined by Wilson and Jungner in 1968 and still valid today. So screening for diabetic retinopathy justifies all of these criteria. One of the main issues around the low compliance to screening recommendations is that people with diabetes, with diabetic retinopathy, may have no complaints till late stages. Therefore, many people are diagnosed at a later stage, and at the time of the intervention, they already have some visual impairment. Therefore, regular screening for retinopathy is a key issue in saving sight in people with diabetes. Ideally, every patient should have an initial detailed eye examination, including fundus examination through dilated pupil, and then followed up at regular intervals as recommended. There are several tools to do the fundus screening and also to do further retinal examination if needed. In order to tackle the burden of diabetic eye disease, systematic and quality assured screening services, their maintenance and monitoring must be developed and implemented depending to the resources available in the relevant healthcare systems in different countries and contextually appropriate to the needs of the person with diabetes. The WHO European region published a guide back in 2020 that includes the most important points in designing and implementing an effective screening program. In 1990s and 2000s, the introduction of fundus camera and further advances in fundus digital imaging paved the way for mass screening programs in diabetic population. In teleophthalmology, we either use store and forward mode and transmit images to remotely located healthcare professionals or human graders for reading, or use the real-time mode that involves a live telemedical consultation with simultaneous transmission of the image. Currently, the artificial intelligence-assisted screening is a very popular topic. The mobile health, with its sets of apps and devices, is again another emerging area in the practice of medicine and healthcare. Smartphones or other devices are used to capture the images. The UK is the largest country that started a nationwide screening based on teleophthalmology for all patients over the age of 12 years in England, Scotland, and Wales in 2003, and in Northern Ireland in 2008. Each UK country sets its own screening policy based on the recommendations of the UK National Screening Committee. Currently, the diabetic eye screening program has a grading pathway with 3 levels of human graders, except in Scotland, and has an uptake of over 80% of the diabetic population. In 2011, Scotland started using an automated retinal image analysis system as a level 1 grader in the screening program. Actually, the UK National Screening Committee reviewed a major program modification, namely the implementation of automated retinal image analysis system in the screening program in all UK nations back in 2021. But the committee recommended that further evidence is needed on the accuracy, clinical utility, and cost effectiveness of automated retinal image analysis system. They also made an emphasis on the need for further work on social and ethical aspects of AI implementation. I want to go over 1 or 2 of the existing automated retinal image analysis systems. The iGrading M classifies the images as retinopathy present or absent and is used in Scottish diabetic eye screening program. FDA approved IDX as an autonomous detection software, and also back in 2018, and also granted IDXDR as a breakthrough device designation. iArt has received a Class 2A medical device in EU in 2020. Singapore Eye Lesion Analyzer Selena Plus, designed to detect diabetic retinopathy, glaucoma, suspected age-related macular degeneration, has received CE marking certification approval for market access in EU in 2020. And as far as we know, it will soon be deployed as part of the National Diabetic Retinopathy Screening Program in Singapore. Actually, AI technology using deep learning systems is one of the most promising areas for AI application in ophthalmology, and this particularly in diabetic retinopathy screening. I would prioritize two things as the advantages of AI-based screening program. One is reducing the healthcare inefficiencies, the other is reducing the costs once the system is established. On the other side, there are many challenges in its implementation. Some of them relate to AI-based systems, and some others specific to the retinopathy screening. The cost of the system is high, so the establishment in low-resource settings may not be easy. Human graders are still needed for low-quality images. The sensitivity and specificity of the system needs to be assessed according to the different outcomes, like presence of any retinopathy or referable retinopathy or sight-threatening retinopathy. Legal and ethical aspects are among the leading concerns about the AI-based systems currently. But aging populations, growing burden of chronic disease, rising cost of care are challenging both for the people with diabetes, with the disease, healthcare providers, governments, and payers. Therefore, effective and safe AI systems have the potential to address some of these challenges in the healthcare delivery. When we speak about the future of screening for diabetic eye disease, we need to speak about the biomarkers as well. There are several possible applications of biomarkers in the diabetic eye disease. Several clinical, biochemical, and molecular factors contribute to the risk of development and progression of retinopathy. Therefore, several of these factors are becoming screening or therapeutic targets or considered as potential targets for the future. On one side, it's exciting to have such a big pool of existing or potential biomarkers, but on the other side, there are several challenges about their development and their use in diabetic retinopathy. Some of them are, diabetic retinopathy is a multifactorial disease. There are too many pathways involved. Therefore, we need a panel of biomarkers instead of an individual biomarker. Retinopathy is a long-term complication of diabetes and has a rather slow progression rate compared to acute events. Retinal response to glycemic control continues 4 years after the glucose control improved or worsened. This metabolic memory may also modulate the relationship between the biomarkers and the clinical status. Retinal vasculature can easily be visualized, and the access for more sophisticated investigation is much easier than any other vasculature in the body. But availability of a sample is a major challenge. The eye is considered as an immune privileged site. There are mechanisms to limit local immune and inflammatory responses, which are not yet fully understood. As a summary for screening, easy, reliable, accessible, and affordable screening tool is the only way out for the early diagnosis of the sight-threatening disease. Plus, retinopathy care should be integrated into all diabetes policies and national health strategic plans in order to make a change on the ground. We very much emphasize the importance of screening in saving sight of people with diabetes, but screening will be only effective if there are treatment facilities available for the sight-threatening disease. Today, there is firm evidence about the vital importance of good systemic control, both in the development, progression, and the treatment of diabetic retinopathy. So I will more focus on the ocular treatment. Nearly since last 4 decades, laser photocoagulation has been considered as the effective approach in the treatment of proliferative retinopathy and also clinically significant macular edema. But today, antivascular endothelial growth factor agents are considered as the first-line treatment in center involving diabetic macular edema. In 2012, FDA approved an anti-VEGF, the ranibizumab, for the treatment of diabetic macular edema, the first approved treatment in nearly 30 years, and others followed. Among them, bevacizumab is used off-label in ophthalmology, but for wider access and availability, WHO has included its intraocular use in essential medicines list since April 2013. Corticosteroids have also been extensively evaluated as a treatment for center-involving diabetic macular edema, but it's mainly used in unresponsive cases and in pseudophakic patients because of its related complications like cataract and glaucoma. Panretinal photocoagulation is still the first-line treatment in proliferative retinopathy and also in some cases of severe non-proliferative diabetic retinopathy. Anti-VEGFs alone or in combination with laser photocoagulation are now also considered in the treatment of proliferative diabetic retinopathy. In the past, non-clearing vitreous hemorrhage and fractional rhegmatogen retinal detachment were main indications for a vitrectomy in advanced proliferative retinopathy. But with the advancements of the technology and the instruments, indications for vitrectomy surgery in retinopathy is also widening. As a summary for the treatment part, diabetic retinopathy remains as one of the most complex, heterogeneous, multifactorial disorders. Timely intervention for the sight-threatening disease is critical in saving sight in people with diabetes. The major treatment challenge is to develop an efficient therapy that can target multiple pathways involved in the pathogenesis of diabetic retinopathy. Continued research in this field can undoubtedly offer new insights into diabetic retinopathy prevention and treatment, and one day for the cure as well. On the other side, there is a big gap between all these favorable evidence base and real life settings. So we need to improve also the translation of favorable outcomes in studies to the real lives of people with diabetes. So thank you for your attention.
Thank you, Dr. Shehnaz. Questions, Dr. Neglur, sir, you're asking some, there was some doubt. Sir is a senior diabetologist and a very good orator.
I think the other speakers should just go up, please, so that you can ask questions.
Yes, hello.
Yeah, Anita, what I was referring to was the paper presented by Salim Yusuf,
Yes.
where he looked at the quartile of the fat content, the carbohydrate content, and looked at the cardiovascular outcome.
Yes.
And he showed a linear relationship with the higher the consumption of carb, higher were the incidence of cardiovascular disease. Versus if you look at the fat consumption, it was not so. Does it mean that the guidelines should change, that we can consume fat versus carbohydrate?
Right. If only it was so linear and so straightforward, it's not. Firstly, the population matters because, as I was trying to show, there was that very nice slide that compared an American study with the Pure study. And what that showed is that the intakes of carbohydrates are much higher in the countries represented by Pure, particularly the South East Asian and South Asian countries. So the highest quartile was related with, of carbohydrate intake, was related with total mortality, but that was intakes of more than 60 or even 70% of total energy from carbohydrates. So the message, take-home message is carbohydrate intakes at the population level, almost it seems, whether you're Asian or you're white and living in the US or UK, optimal is around 45 to 50%. But in Asia, the problem is that the intakes are way higher. On average, we know from the ICMR INDIAB study, it's around 62% in India. So that's a massive high intake, and that's why the relationship. And why is mortality increased? What's the mechanism? Well, it's mostly refined carbs, and that means it's low fiber, it's low nutrient density, it's it's high energy dense but low nutrient density with refined carbohydrates. Mostly people are having potatoes, they're having refined grains, white rice, that sort of thing. So that explains the mechanism. Although it wasn't studied, that's the speculation.
Dr. Shainaz, I'm not an ophthalmologist, but we have in our country, in India, little less prevalence of retinopathy per se. We have, but less because of the genetic DR4 and other relationships. But we have a lot of maculopathy, and I was excited maculopathy, and it's a type 2 diabetes phenomenon in our country, and you sort the treatment with the various MABs and the corticosteroids, and possibly also coagulation. I would like to know your experience with the MABs and the corticosteroids. Maculopathy, diabetic maculopathy.
Yeah, macular edema and corticosteroids. So we are mainly using the anti-VEGFs. Only in unresponsive cases to anti-VEGFs, we use the corticosteroids because there is a problem. One of the complications is glaucoma, and the other in the long term, and also the cataract. So therefore, if it's unresponsive cases, and especially in people who has already undergone a cataract surgery, then we prefer the corticosteroids, intravitreal corticosteroids.
Thank you. And may I ask one question, Dr. Sudarshan? We also have a National Diabetes Control Program, Dr. Sudarshan from Mauritius. What are the challenges you face in this program? Because, we have launched NCPDCS, National Control Program for Diabetes, Cardiovascular Disease and Stroke, as a composite program in 2004. This is 2024. Achievements I'll describe later, but we have a lot of challenges. I wanted to know from you, learn from you the challenges, Dr. Sudarshan.
So where we organize conferences in Mauritius, it's been organized by the government, so we don't have any challenges. Totally.
I have a question for Nita. Very nice presentation. I'm wondering if you can give some more information about high carbohydrates as opposed to high refined carbohydrates. Are there studies with people that eat that much carbohydrate as the Indian population, South Indian populations eat, but as complex carbohydrate? And what do you find in those situations?
Okay. Yeah, that's a really interesting point. Thank you for the question. Most populations where the carbohydrate intakes are high are basically consuming higher proportion of refined carbohydrates. And mostly, if you take the South Asian context, it is things like potatoes, which don't, by the way, count as healthy, because when we talk about 5 a day, fruit and vegetables, potatoes are not part of that, right? So it's potatoes, and then rice is consumed massively. The average intake of rice in South Asia is, according to one estimate, 600 grams per day. That's totally off the scale. And there are some nice analyses, including from the PURE study that we've talked about, comparing just 450 grams versus 150 grams per day already has a relative risk of 60% greater risk of diabetes. So it is mostly processed and simple carbs. It's added sugars. It's even the beverages. Tea is consumed with 2 spoons or even 3 teaspoons of sugar in much of South Asia. So it's unfortunately not complex carbohydrates. Now, in populations like Japan, where potatoes are eaten, the potatoes are very different. They're also, these purple potatoes that are very high in anthocyanins, one of the sort of flavonoid class of phytochemicals. So by and large, whether it's the US or it's India, high carb equates with refined carbs.
And what's the solution to that?
Well, the solution is back to that dichotomy that we have. Even in the debate, the question was posed, should it be individual level approaches, the high risk approach, or should it be the population level? Well, it's not should it be this or that. It needs to be absolutely everything across the spectrum. So, for sugar sweetened beverages, which of course are refined carbs and unhealthy plant-based diet, we need all the individual level approaches, education and all of that, but we also need the collective interventions. And I really think that, when the pandemic happened, all governments, including the government of India and South Asia and everywhere, they stepped on it and there was action. I know people criticize it wasn't good enough, it wasn't whatever, but for non-communicable disease, that urgency is simply not there. And it takes forever for people to sort of wake up to the fact that this is a real and imminent problem. And, it'll happen in a few decades is not good enough. So, I wish I had a straightforward solution. But yes, we can advise people in our clinics on reducing, giving them education, what are complex carbs and how to increase protein intake in particular. Because what people forget, and doctors aren't trained in their medical curriculum on nutrition very much in most curricula. So people just say, oh, well, have low carb, but they don't say, what does that mean? What should you eat instead? And that's what we need to educate. Protein, protein, and protein is going to be really important in Asia. In the UK and in USA, protein intakes are exceeded on average, but in India, protein intakes are pitifully low. So yeah, that's the challenge.
Single augmentation of what Nita said.
I'm sorry, we
Yes,
have run out of time, and we want you to congratulate all the speakers and then the co-chairs. Thank you. We have a photograph here, please.
Thank you so much, speakers and chairpersons. That was indeed very insightful. Moving on to the next session, which is on the 1-hour plasma glucose concept. And to chair this session, I would like to invite Dr. Bruce Duncan from USA. Welcome, sir. Dr. Vijay Neglur, sir, from Mumbai, and Dr. Rahul Dope, sir, from Pune. Welcome, chairpersons. Over to you.
Should we start? Yeah. So welcome for this session of 1 hour PPG, a new concept in clinical application. Now we go back in 2016, the article which came in Atherosclerosis, which talked about the value of estimation of 1 hour post-pandemic glucose, which can talk about the future problems of cardiovascular disease, intima media thickness, and so on and so forth. To discuss this topic in a great detail, we have three talented speakers here. Let me introduce the first speaker, who is the giant of this country, who is the tall speaker and has the accolades of being a versatile speaker, and is none other than Dr. A.K. Das. He is consultant physician endocrinologist at the Pondicherry Institute of Medical Science. He is the patron of RSSDI. He is the co-chair of ICMR in Diabetes Study. He is the chair of diabetes in the Young Registry, former national president of RSSDI and API, and the former dean of Indian College of Physicians, and former professor of head of endocrinology at JIPMER and PIMS Pondicherry. With these words, may I
Thank you for this very generous introduction, and thank you, chairpersons. And I'll straight go to the topic. You know, what we are discussing this afternoon is a game-changing concept. And if this is taken up, maybe it will be easier for many countries in the world to diagnose prediabetes and to also prevent prediabetes going into diabetes. So my focus of the topic is today on the 1 hour PPG. How is a new concept? What are the clinical applications? I have a brief outline. We'll discuss how this 1 hour plasma glucose concept came in, how did it emerge, what is the background for recommending 1 hour post-load PG, 1 hour post-glucose load, blood sugar estimation, plasma glucose estimation, why it is recommended. And can this 1 hour plasma glucose can be used as a diagnosis of diabetes, and whether it can be related to the complication of diabetes. We'll also discuss regarding very important RSSDI IDF position statement. What I have today with me is the combination of the RSSDI and IDF position statement on the 1 hour plasma glucose and the summary. Dear friends, you know, there is a rapid increase in the global prevalence of type 2 diabetes. Calling a long story short, today we thought today in 2024 we'll have about 79 million diabetics. We have overcrossed that. Today 102 million diabetes and 115 million pre-diabetes. So there's a very rapid explosion in the global and the national prevalence of type 2 diabetes mellitus. So what it calls for? It calls for a tool in our hands for a rapid detection of the individuals at risk, and that is critical. Whether this 1 hour plasma glucose provides a tool in our arms. Number two, we'll also examine whether the pre-diabetes, which can be a major risk factor for type 2. In the morning we discussed, this is the only risk factor through which we can apply our tools of prevention. So whether pre-diabetes is a major risk factor, can it be 1 hour post-glucose? And number two, reliance on the established pre-diabetes criteria like IFG, impaired fasting glucose, and impaired glucose tolerance, we may miss many individuals who are at high risk of developing type 2 diabetes. Now, there's a short table which shows that we have different criteria by 3 different world bodies to diagnose intermediate hyperglycemia, IH, that is same as the pre-diabetes criteria. You look at the IFG criteria by the ADA, it is between 100 and 125 milligram deciliter. If you look at the criteria given by the WHO, it is between 110 to 125. You look at the IGT criteria, it is about, it remains more or less same, 140 to 199. The WHO also 109. You look at the IEC. IEC is the endocrine group, is a position statement, not a recommendation. H1C, it is 5.7 to 6.4 by the ADA, but IEC, endocrine society position statement says between 6 to 6.4. So dear friend, there is currently no international consensus to define intermediate hyperglycemia as the ADA, WHO, and the informal IEC, International Expert Committee, have proposed different criteria. Now, therefore, these current diagnostic criteria are possibly inadequate. So, reliance on the fasting plasma glucose or HbA1c to diagnose intermediate hyperglycemia and type 2 diabetes can lead to missed opportunities and early diagnosis and prevention. We'll miss opportunity. Now, I did not describe what HbA1c to this august audience. We know that it can vary between the anemia, within pregnancy, renal failure, hypertriglyceridemia. I have omitted those tables because it is too simple to bring in here. And there is also lack of standardized assays. So, is pre-diabetes status sufficient? Now, if you have 40% of those who progress to type 2 diabetes mellitus over 5 years, who have 40% of population today who are NGT. NGT I'll be using for normal glucose tolerance today. At baseline, 40% of these will develop type 2 diabetes mellitus over 5 years. I'll repeat again, 40% of this. Therefore, pre-diabetes status is not sufficient in identifying a large portion of individuals at risk of diabetes. So that's my play, that this NGT, 40% of them are not pre-diabetes according to criteria we have, but they pass on to become full diabetic. If you look at the oral glucose tolerance test pendulum, we have extremes, we have equilibrium, and the other extreme. What I'm proposing here is the fact that intermediate time points have long been eliminated. We used to have previously 0, 30 minutes, 60 minutes, 90 minutes, 120 minutes. I'm not proposing we should go back to that. But my simple plea today to the august audience is that we omitted those time limits. But accruing evidence that I'll present today, and we all know about it, possibly says that one of them can be reinstituted. Maybe 60-minute IGT, 60-minute measurement of the glucose, I'm just suggesting in this symposium, can be reinstituted to look after the things I'm talking about today. Now, to make again a very strong statement, heightened sensitivity of the 1 hour post-glucose level for detecting type 2 diabetes mellitus, and its use in clinical practice can be there to avoid undergoing, by underdiagnosing high-risk individuals. It can improve sensitivity and opportunity to potentially prevent type 2 diabetes and its complications. Now, how it has emerged as a very important criteria. Higher level of 1 hour PG associated with increased risk of type 2 diabetes mellitus. The cutoff that we have taken for this talk and taken globally is 1 hour PG of 155, more than 155 or 8.6 millimoles, has emerged as a reliable glycemic marker, recognized among diabetic individuals with NGT, those at increased risk for future T2DM. They cannot be having the diagnosed criteria of IFG and IGT as we have today. That is, impaired fasting glucose IGT, but this can be a criteria to diagnose them. What's the potential role? It reduces time, we take only 1 hour, reduces the labor, reduces the cost in performing a 2-hour OGTT, increasing the convenience for the patient and provide greater utilization, detect individuals at risk of progressing to type 2 diabetes mellitus, and identify the individuals who will also develop micro and macrovascular, mostly cardiovascular complication. I think Chairman spoke about the carotid intimal thickness, the paper on the atherosclerosis. Professor Neglu spoke about it, and identify individuals at risk of mortality. Now, it is very important. And also to diagnose the individuals with type 2 diabetes, identify antibody positive individuals, this is for type 1 diabetes, who are at risk of developing type 1 diabetes for participants in the prevention trials, diagnose GDM. You know, today we have got early GDM diagnosis, and 1 hour can provide some tools, predict adverse neonatal outcomes, and identify the pregnant women at risk of developing future diabetes and also future CVD, as the intermediate hyperglycemia can give rise to cardiovascular disease. Now, 1 hour glucose is a very important earlier marker of this glycemia. I'll just show that it is a earlier marked risk glycemia in the various age group, and it has been shown that 1 hour post glucose 155 is an earlier marker of elevated risk for pre-diabetes and type 2 diabetes than 2 hour post glucose values, which is 140. So this is the summary of the various graphs and the pathophysiology of the mechanism of underlying 1 hour post load hyperglycemia. I will not describe it, it is too well known. But you know, a 1 hour post load hyperglycemia may arise, what you're looking for, defective beta cell function, impaired insulin action, accelerated gastric emptying, and increased glucose absorption in the proximal intestine. And all these are the markers, we call it biomarkers, clinical markers of type 2 diabetes. So 1 hour post-glucose gives a good diagnosis of the type 2 diabetes mellitus. It also identifies insulin resistance and beta cell dysfunction in the people who have apparently, I'm telling apparently normal glucose tolerance because doing fasting and 2 hour. Therefore, the higher values of 1 hour plasma glucose may identify an intermediate condition between NGT and IGT, characterized by greater IR, insulin resistance, reduced beta cell glucose sensitivity, and reduced beta cell rate sensitivity. We'll come to the background why we recommend as to the clinicians or to the us. We'll not details of this. I'll not go. I'll just say that numerous studies have worldwide have consistently demonstrated that a direct association between 1 hour plasma glucose of 155 during an OGTT with incident type 2 diabetes. Notably, this association is more robust compared to the association of 2 hour 180. I mean, 2 hour 1, whatever you take it, 2 hour FPG and 2 hour PG, whatever 199, whatever you take it. You come to the 1 hour PG and the NCEP ATP3 criteria. Again, you look at the diagnosing metabolic syndrome. Combining 1 hour post-glucose of 155 with the NCEP ATP3 criteria for the METS, metabolic syndrome, significantly improve the identification of high-risk individuals type 2 diabetes mellitus. I will not go through details of it for interest of time, but suffices to mention that this also helps in diagnosing the metabolic syndrome. And NGT, normal glucose tolerance apparently, but the high 1 hour post-load plasma glucose exhibits decreased beta cell function, and subjects with NGT who have higher 1 hour position glucose level have a compromised insulin sensitivity and also adjusted compromised beta cell function, and it's very important to identify them. Is 1 hour PG value, can it give some more benefit than HbA1c? Comparing the accuracy of HbA1c fasting plasma glucose to our post glucose with an elevated 1 hour plasma glucose during the OGTT study, the agreement, it was found, is twofold greater for the elevated 1 hour PG compared to HbA1c. I think I'm clear. If you compare the accuracy of HbA1c, FPG and 2 hour PG, elevated 1 hour PG during an OGTT, the level of agreement was twofold greater for the elevated 1 hour PG than HbA1c. Now, is the 1 hour PG level preferable to HbA1c? Dear friends, although the H1C alone is a significant predictor of the future risk of type 2 diabetes, but its predictive power is weaker when compared to 1 hour PG with a significantly lower area under curve, as I have shown in this graph. Now, there is enhanced predictive capability of a 1 hour OGTT. In a 1 hour blood glucose level is a powerful predictor for future type 2 diabetes mellitus with a net reclassification improvement and detection rates significantly better than 2 hour blood glucose measurements, especially with longer duration of follow-up. Therefore, in the various studies, the Botnia study, Shah study, 1 hour PG and this type 2 diabetes mellitus have been correlated. The sensitivity and the specificity of the various diabetes prediction models have been worked out, and it has been shown in the Botnia prospective study. It has been confirmed that 1 hour PG had area under curve, higher sensitivity and specificity, and predicted progress type 2 diabetes mellitus more accurately than fasting plasma glucose. Now, can it be used for diagnosing diabetes? Now, it has been also redefined the high-risk type 2 diabetes mellitus in adults, children and youth, association with worsened metabolic and atherogenic profiles. This was also referred to by the chairman, identifying risk of micro and macrovascular complications and mortality. It has been also correlated by dear friends and the esteemed chairpersons with the OSA, with CFRD, with the NAFLD or MASLD, the NASH and severity of hepatic fibrosis. So there are evidences today, I'll show very quickly, that it has been correlated to all the complications. Now, the 1 hour PG of more than 155 for diagnosis of hypoglycemia and type 2 diabetes mellitus occurs before the onset of 2-hour IGT. It merits identification before the IGT occurs. It is cost effective for the high risk screening and provides opportunity for earlier detection and intervention of high risk population identified with primary screening. And it may benefit from lifestyle and for the pharmacological interventions to reduce type 2 diabetes mellitus, reduces diagnostic complexity and confusion, and it shortens OGTT from 2 hours to 1 hour. And in our country, it is very important. Two things here in our country. Number two, that we have a very high rate of conversion. If you take from the study in the Denmark, first conversion is only 41%. Our conversion is about 78%. The only conversion rate is higher than us is in the studies in Nauru and others, where it is 82%. So we need a simple test to identify the intermediate hyperglycemia to prevent this conversion to full-blown diabetes. So that is very important. So the accuracy of the 1 hour plasma glucose during OGTT for diagnosis of type 2 diabetes mellitus has been studied, and it has been produced by Dr. Ahuja long back, and it has been shown it has a good sensitivity and specificity for detecting type 2 diabetes mellitus. And also in the youths and adolescents developing type 2 diabetes or at high risk of type 2 diabetes. You know, we have a huge problem of type 2 diabetes in the young in our country, which we have termed malignant type 2 diabetes in the children and young adults, obese young adults. And this is a great sensitivity to diagnose them. 1 hour glucose more than 155, independent predictor of beta cell deterioration and progression to pre-diabetes among these fat type 2 diabetic, we call it type 2 diabetes in children. And so in various studies, San Antonio Heart Study, the Botania Study, Katamari Study, the Israel IO Study, Malmo Study, it has been shown that the risk to develop T2 diabetes in subjects with IGT and 1 hour post-load glucose levels are quite high. It correlates very well. So we are saying that the efficacy of 1 hour post-load plasma glucose as a suitable measurement of predicting type 2 diabetes mellitus is important. That's what we want to impress in this presentation. It can also, in a study, identify the elderly Chinese male at high risk to develop future diabetes. And no, it has been also used for identifying, as I told some time back, METS, metabolic syndrome, and the future type 2 diabetes mellitus, and is a strong predictor of type 2 diabetes than impaired fasting glucose. Impaired fasting glucose alone, vis-a-vis 1 hour, 1 hour is much better. And look at the complication correlation. It associates with the cardiometabolic risk factors and target organ damage is very significant. Individuals with NGT, but not having elevated 1 hour PG exhibit, but the individuals with normal glucose tolerance, but having 1 hour PG values high, exhibit unfavorable cardiometabolic risk factors. Elevated 1 hour post glucose is sufficient stimulus for several cardiovascular risk factors, most important the inflammation, the thrombosis, the endothelial dysfunction, and it has been also related to insulin resistance, obesity, visceral adiposity, metabolic syndrome, pro-atherogenic lipid profile, and the increased uric acid. And it has been also correlated to other risk factors like increased viscosity, reduced vitamin D, increase in the pro-inflammatory markers, increase in the oxidative stress, we discussed some time back how it is important, and the reduction in the molecules with anti-inflammatory properties. This is the reference to the paper that subclinical atherosclerosis, increased pulse pressure, vascular stiffness, left ventricular hypertrophy, impaired diastolic function, right ventricular dysfunction, subclinical left atrial marrow dysfunction also has been correlated. So therefore, this is the thing we are discussing some time back, the correlation with the carotid intimal thickness with the 1 hour PPG. You see as the 1 hour PPG rises, the carotid intimal thickness CIMT also increases, and also it is related to incident metabolic syndrome. Now it has been shown that 1 hour post OGTT glucose improves the early prediction of type 2 diabetes by clinical and metabolic markers and provides a window of opportunity to diagnose type 2 diabetes better or provides a tool in our armamentarium to intervene in these patients to prevent type 2 diabetes. Thank you very much for a patient hearing.
So I think we will hold questions until the end. So it's now my immense pleasure to present the next speaker, Jaakko Tuomioja from Finland. I've known Dr. Tuomioja for approximately 3 decades now, have followed his career closely through papers, through presentations at meetings, and through his never-ending championship of the prevention of diabetes. More specifically for us now than a champion of diabetes, he is the soul of the World Congress of Prevention of Diabetes. So it's my immense pleasure to invite him to talk now on the detection of prediabetes and the diagnosis of diabetes by 1 hour as opposed to fasting in 2-hour glucose. Dr. Tuomioja.
Try to get the presentation mode, but it doesn't go. Okay, thank you very much, ladies and gentlemen. I will continue the discussion about the 1-hour glucose, and I would like to start pointing out that the diabetes, as it is defined today, is based on the prevalence of retinopathy, starting to increase at a certain threshold of fasting glucose, A1C, 2-hour glucose, or actually 1-hour glucose in the same way. Now we have these 3 current ways of defining or detecting diabetes, and this postprandial glucose is based on 2-hour glucose now, and the problem has been, as we all know, that the 2-hour oral glucose tolerance test is not commonly used, and the main reason is that it takes 2 hours, and hardly any other problem with that. And therefore, this diabetes matrix now, we have pointed out that we may delay the diagnosis of type 2 diabetes, and the diagnosis will be too late. We have to consider alternative ways to have earlier detection. And we also know that we need postprandial post-challenge glucose to identify undiagnosed diabetes in the most sensitive way. The same is for prediabetes or intermediate hypoglycemia. Now, when we have a glucose tolerance test, this is a typical picture of people who are normoglycemic, who have ICT and diabetes. So we classify them now based on the 2-hour glucose. But what about if we use 1-hour glucose? Well, the results are not so much different. So the question is that why to wait 2 hours, and what is the reason for that? 2-hour glucose was defined by the National Diabetes Data Group in 1979, and then confirmed by WHO 1980, and they proposed to use 2-hour glucose. It's not clear from the original report why 2-hour glucose. The 1979 report gives also criteria for 1 hour, but the 2-hour glucose was recommended anyhow. So a couple of years ago, there was a paper to look at the pre-diabetes with the 1-hour glucose, and the data were quite clear that if you use 1-hour glucose, we can identify people with pre-diabetes who otherwise, in the current way, would have been classified as a normal glucose tolerance. And yet, based on the 1-hour glucose, there was a fourfold increase in the risk of pre-diabetes compared with those who were normoglycemic with the current criteria, and the 1-hour glucose was less than 8.6 millimoles, or 155 milligram per deciliter. So we collected then data from 15 population studies to actually compare mostly cross-sectionally the data of a diagnosis of diabetes based on a 1-hour glucose when it's compared with a 2-hour glucose of 11.1. And this is the main result of the meta-analysis of these 15 studies. And you can see, first of all, that the results all cluster in the high corner here. So the sensitivity, specificity are pretty good. And the optimal threshold for sensitivity and specificity was 11.6 millimoles. So this was a result. And then we did another study in the coronary patients in Europe. The study is called the EuroAspire study with about 8,000 individuals, 8,000 coronary patients. And we did a glucose tolerance test on everybody who was not diagnosed with diabetes earlier. And in the same way, when we looked at the comparison between 2-hour glucose 11.1 and 1-hour glucose, we identified the ideal sensitivity and specificity at 12 millimoles. So basically very similar to the one from the meta-analysis. The other thing we looked at when with the 1-hour glucose using 11.0 and to exclude diabetes, and if the fasting glucose level was less than 6.5, we could exclude actually 99% of cases of diabetes. So again, this is a way, the other side of the coin, how we can exclude diabetes very efficiently. Now, as pointed out already by the earlier speaker, 1-hour glucose can identify earlier the cases who might benefit from preventive interventions earlier than with the current definition of pre-diabetes, which would be IFG and IGT. Now, these prevention trials that have been successful, they all were based on IGT, people with IGT, elevated 2-hour glucose. What about the intervention effects if 1-hour glucose would be used as an outcome? We have a data from the Finnish diabetes prevention study because we measured also 1-hour glucose. And here you see the area under the curve of 2-hour glucose was 0.94. The diagnosis in our study was based on either fasting glucose or 2-hour glucose. That was the original one. And then if you use 1-hour glucose as the outcome, then the area under the curve is 0.9. Ideal cut point in this case was 13.3, but we have to remember that all of them had the IGT to start with, so they are not population reference values. Now the other way is to just to compare, exclude those who had diabetes based on fasting glucose during the follow-up, but just to compare 2-hour glucose with the 1-hour glucose. Then we come up with the area under the curve again, 0.89, and the ideal cut point is 12.5. So pretty much the same range as the other studies, like a EuroAspire had 12.0. Here is also the agreement between the different categories, having a true positive, true negative, false positive, false negative, blah, blah, blah. So it's a question that the both, if you use 13.3 1-hour glucose, there is an agreement with the 2-hour glucose about 84%. And again, the false negatives are very, very few. So we are not missing cases of diabetes using a 1-hour value. So these are all unpublished so far, so we are writing the paper at the moment. Now, there is one trial where 1-hour glucose was used in the recruitment of people for prevention trial, and it is called the Stop Diabetes in California, carried out by the group of Ralph DeFronzo and Mohammed Abdul Ghani. So they randomized people to lifestyle therapy and then added metformin or pioglitazone and then even the GLP-1 receptor agonist. And the best result was with the combination treatment here. And but even in the lifestyle intervention group, the cumulative hazard at 80 months was only 0.4. So pretty much the same as in our diabetes prevention study in Finland with the lifestyle intervention. The incidence rate would be about the same there. So it seems to be that 1-hour glucose can be used as an early marker for preventive measures. And this is again the original study from Abdul Ghani. It was referred already earlier to look at 1-hour and 2-hour glucose. And this study showed that the area under the curve was actually better for 1-hour glucose than 2-hour glucose, and the fasting glucose was inferior to both of them. And more data have been published to compare 1-hour glucose with hemoglobin A1C, and as we know that hemoglobin A1C is really insensitive in identifying prediabetes or diabetes compared with the post-challenge glucose. And another study from China, where the data were compared for 5-year, 10-year, and 20-year follow-up with 1-hour and 2-hour glucose, and at each time point, the area under the curve was better for 1 hour than 2-hour glucose, although the significance values are here only when 20-year follow-up was done, but numerically there was already at 10 years better finding. Malmö Preventive Project looked at the very long follow-up, 39 years, and the individuals here who had normal glucose tolerance and normal 1-hour value, normal 1-hour value, only 8% developed diabetes in 39 years, And those who had a normal glucose tolerance, not IGT, and about 1 hour glucose was elevated, then 22%. And actually, when you look at these red lines here, whether people had normal glucose tolerance at baseline or IGT at baseline, then the incidence curves were almost identical. So to have a 2 hour value for IGT did not improve the prediction. So the 1 hour value itself was important. So in summary, it looked like that the 1 hour glucose is a useful, cost-effective way of screening for undetected diabetes and pre-diabetes. And lifestyle intervention seem to be operating in people with a high 1 hour glucose and can be used also as an outcome measure in prevention projects. So the cut points 11.6 or 210 or 12 if you like, somewhere in that range is the diabetes, and the pre-diabetes is 8.6 or 155 milligram per deciliter. So shortening the OGTT from 2 hours to 1 hour is realistic, practical, and definitely time-saving and therefore clinically more acceptable. Thank you very much for your attention.
Thank you very much, sir. That is very good overview of 1 hour postprandial or post-OGTT. Now, for third lecture, I'm going to introduce Dr. Rafael Gabriel. He is currently Professor of Public Health in Spain. He is also Vice President of World Community for Prevention of Diabetes, that is WCPD. His main research areas are epidemiology and prevention of diabetes and cardiovascular diseases, epidemiology of aging, and he is author of more than 200 peer-reviewed original research publication, and he is principal investigator for major international research project. Over to you, sir.
Okay, thank you, Mr. Chairman. Good evening, ladies and gentlemen. So let me okay. So let me just make an outline of my presentation today. So I will try to address the association of the information, the relation between 1 hour plasma glucose and micro and macrovascular complications. So you know the in pre-diabetic individuals, so microvascular involvement is quite common. So in most of the observational studies, so any impairment of microvascular at the retinal, kidney or peripheral nerves is around 10%. And in the US DPP, around 8% of individuals with pre-diabetes also have retinopathy at baseline. And between 7 and 16%, they have peripheral neuropathy based on the National Health and Nutrition Survey in the US, and similar 10% with kidney impairment in the same population. So, in addition, microvascular dysfunction is quite common in pre-diabetes. So, in the Maastricht study, so they were able to show, to report that a great big proportion of participants have a generalized microvascular dysfunction. And there is increasing evidence that these people with prediabetes has a microvascular impairment, lesions, which are typical of the end organ damage of diabetes. So these are the results in some of the microvascular function at the retinal level. You can see in the bars, so in the black or the white bars, clear differences between the pre-diabetes, diabetes, and normal glucose tolerance people in some parameters like the flicker light induced retinal arterial dilation in the upper panel, or heat induced skin hyperemia in the lower panel. So therefore we have a challenge with the definition of pre-diabetes, and the main question would be is if should we still consider pre-diabetes merely a risk factor for diabetes or an established disease, especially in those people with microvascular complication. So this is why some authors has proposed that the definition of pre-diabetes should no longer be glucocentric, and we should focus more in the microvascular and macrovascular, particularly microvascular involvement. So how can we identify early these people with higher risk of microvascular impairment? So 1 hour glucose is a promising candidate, and there is a lot of evidence. This is a narrative review of many studies backing from last century, from 1999 to this time. So I'm showing that there is a lot of studies with a positive association. Some of them are negative, but the majority shown a positive association between postprandial glucose or with several vascular and microvascular parameters like vascular stiffness, brachial ankle pulse wave velocity, and so on. But Jakob pointed out before that the definition of diabetes and the states of glucose status is based on some particular data regarding the presence of retinopathy in the population. The study of Paddock was one of the first studies in the literature. It's a cohort study, it's a prospective study comparing 2 hours glucose and 1 hour glucose for the development of diabetic retinopathy in American Indians. So you can see in the panel B and C, so there is a improvement of the detection, the prediction value in the area under the curve when you use the 1 hour compared with 2 hours, or very, very similar. So you can substitute 1 hour for 2 hours. The Malmo study also has been shown before. So it's one of the studies, the cohort studies with the largest follow-up, and after almost 40 years, so the association or the prediction of the IGT based in 1 hour or 2 hours, or IGT versus normal glucose, so increase the risk of having vascular peripheral vascular retinopathy, for example, retinopathy or peripheral vascular complications. Also, so there are some data, still cross-sectional data of the Katemari study, so in which they show there is a quite nice positive association based on 1 hour glucose for the detection of kidney impairment compared to the red line, which is 2 hours, or the green line, which is the fasting plasma glucose. Also, there is other studies like the Katemeris study in Italy. It's also cross-sectional, but showing 1 hour post-load plasma glucose levels are associated also with kidney dysfunction based on estimated glomerular filtration rate. These are the preliminary results of collaborative European clinical trial, primary prevention clinical trials to prevent complications in microvascular complications in Europe, using lifestyles, some anti-diabetic drugs, and the combination compared with lifestyles alone. So we measure the skin conductance in these people, high-risk people with pre-diabetes, and we were able to see that the skin conductance estimators were lower, which mean higher risk of developing peripheral neuropathy in those with 1 hour IGT, those with IGT and elevated 1 hour plasma glucose compared with only isolated IGT or IFG. So there is an inversion relationship, and that this is important and preliminary data as well. What about macrovascular disease, pre-diabetes and macrovascular disease and mortality? And what about the association with 1 hour post-glucose? So back to the first studies, the DECODE study in Europe, so was a pool analysis combining data from several cohort studies, and they combine the fasting plasma glucose and the 2 hours glucose, and they were able to demonstrate that the combination or the increase only in fasting, but particularly in 2 hours, increased the risk of cardiovascular mortality. So they developed the DECODE. It has been discussed here before in this Congress, the DECODE risk score, and combining different parameters of glucose status and also the diabetes status and non-diabetes, or the combination of diabetes with IGT, IFG, etc. So you can see in the breadth square there is an increase of risk of macrovascular disease, any complication, including stroke, compared with normal glucose tolerance people. What about the last updated evidence? So this is a updated meta-analysis published 3 years ago. So about the association between pre-diabetes, IFG or IGT after 10 years, and the risk of all-cause mortality or cardiovascular disease. You can see all-cause mortality, composite cardiovascular disease, coronary heart disease, or stroke are positively associated with 1 hour and also with IFG and IGT 2 hours. So there are several studies, and some of them quite old studies, like a Helsinki businessman study, the Erfurt male cohort study, the Israel, the Malmo prevention project, the Chicago Heart Association Detection Project or the Honolulu Heart Project. These are classical prospective population-based study who measured some years ago the association and the prediction of 1 hour plasma glucose, 2 hour plasma glucose, fasting plasma glucose for the development of heart points, cardiovascular heart points, composite heart point, or mortality. All of them some positive results. So even in the patients with coronary, hospitalized with coronary heart disease, the association, not only the risk, but also the severity of coronary heart disease is very well associated with 1 hour plasma glucose. These are the results of the risk of readmission 1 year later of, after hospitalization, after discharge, in those people with only with 1 hour plasma glucose, elevated 1 hour plasma glucose, compared with fasting or 2 hour glucose. Now, at the foundation of the World Community for Prevention of Diabetes, we are conducting an individual-based meta-analysis for the prediction not only of new cases of type 2 diabetes, but also cardiovascular outcomes. So we have been able to combine and to collect data and to aggregate individual participant data of 7 studies of the meta-analysis Jaco presented before of AUJA and collaborators. And in total, we were able to obtain 17,000, almost 18,000 data for people who have at baseline fasting plasma measure fasting plasma glucose, 1 hour glucose, and 2 hour glucose. So these are very, very preliminary unpublished data, but we can see when you just pull the data and without any adjustment, so all the classical risk factor, age, sex, total cholesterol, LDL cholesterol, BMI, fasting plasma 1 hour, 2 hours, all of them are associated with the outcome, with the cardiovascular. This is a composite outcome of all fatal and not fatal cardiovascular disease. So, but when we adjust by sex and we control for the collinearity among the different glucose parameters, the fasting, the 1 hour and 2 hours, you can see that only 1 hour, I mean, among the OGTT variables, only 1 hour plasma glucose became positive and significantly associated. And we lose the association of fasting and 2 hours. So you can see the relative ratios, the hazard ratios. They are not very impressive, but they are in the line, or they are in the way of the same argument that has been discussing in this session before. So as conclusion, I will say that on average, the absolute risk in people with pre-diabetes versus people with normal glycemia is 7 times higher for all cause of mortality and 9 times higher for composite cardiovascular disease. There is an increased body of evidence on the association between impaired glucose tolerance based on 1 hour post-load glucose with an increased risk of all-cause mortality and cardiovascular disease in the general population, but also in patients with atherosclerotic cardiovascular disease. So by then, the screening of pre-diabetes using 1 hour plasma glucose seems to be cost-effective and might be appropriate, delaying the progression of type 2 diabetes. Thank you very much for your attention.
Okay, our speakers have generously left us with plenty of time for questions. So I'd invite all three of them to come up to the podium again. And while they're arriving, let me make a first question. It's probably a stupid question, but it's one that comes up. If 1 hour is better than 2 hours, what about a half an hour? If 1 hour is better than 2 hours, what about a half an hour? A 30-minute test.
Yeah, that 30 minutes is of course possible. We can have the, especially 30 minutes, we need an insulin measurement then, because it all depends on the insulin secretion, what happens, if first phase insulin secretion, what happens in the 30 minutes. So the 30 minutes alone, glucose may not be a very useful thing. But 1 hour value is already, is not only depending anymore from the first phase insulin secretion, because second phase insulin secretion starts also if there is an insulin secretion, but if there is not proper, then the 1 hour value will be high. So yes, 1 hour is good, 2 hour is good, but 1 hour is better because it's easier. And quite a bit of data shows that like Rafa just pointed out in the last slide, that for the cardiovascular outcome, it seems that compared with the fasting and 2 hour glucose, 1 hour glucose outperforms.
Okay, thank you. The first microphone.
Sir, can I just say something, sir, about the 30-minute, 60, 90, and 120? It has been compared, but the 30-minute, as has been expressed, is too early for the insulin secretion, its action, and transit time of the glucose and all that. That's why there is a suggestion to resubstitute the 1 hour values in the OGTT.
Yes. So the last slide you showed that 1 hour has a significant correlation with the cardiovascular thing and 2 hours was not. So what is happening in this postprandial state, that why this 1 hour is getting associated or as a kind of a causative thing for a, or maybe association for cardiovascular risk? What is happening?
Well, if I start saying that 1 hour value is the highest value of glucose after a meal or after the glucose load, and obviously the higher glucose go, the more toxic it is to the tissues. But please, Rafa.
Yeah, I agree. I agree with this answer, but also the confidence interval and the precision of 1 hour is much better than 2 hours.
Yeah, I know. So that's what my question, what you answered. Maybe it's more toxic to the vessels and...
Yeah. So what Rafa also mentioned here was this confidence interval that he showed that is more narrow. So the variability in 2 hour glucose is bigger than in 1 hour. That is also making a 1 hour more stronger predictor because of the lesser variability.
Yeah.
Thank you.
So both.
So I'm Dr. Shekhar from Madurai, sir. Just as you use 1 hour glucose for the management of to diagnose pre-diabetes and all, even when the patients come to you routinely for follow-up, even after 5 years, 10 years, can you routinely ask them to have 1 hour fasting, 1 hour and 2 hour glucose every time, or is it be feasible, or is it recommended?
What we have discussed today is to show that there is a good correlation between 1 hour, and there is a strong case to use 1 hour as a diagnostic tool for type 2 diabetes, also diagnostic tool for pre-diabetes, because it fulfills all the criteria. Now, it has not yet entered to my mind in the routine clinical management yet. I think we still are relying on the 2 hour values, even though I don't know why, but many societies, many position statements from IDF, position statement from our own society, RSSDI, we have spoken about it, but I will tell you, sir, in Madurai and anywhere, this has not entered into routine clinical practice.
And one more comment, sir. for 1 hour post-glucose actually reflects the GLP-1 and GIP action more than your other drugs. Once your incretin effect goes down, it has a sharp increase in the first phase of insulin secretion gets affected. You have 1 hour rise in the glucose. Does it reflect that if we give incretins for that patient, and if his 1 hour glucose is quite normal when it comes to follow-up, it means that drugs are working fine in that fellow?
I think, Dr. the correlation of 1 hour post-glucose is not only with the glucose. It has been also shown, it is also the lipids after 1 hour, it's the inflammatory markers, and few other things, IR, the insulin resistance has been taken as a central cause for all cardiometabolic disease, including type 2 diabetes and pre-diabetes. So they are correlated to that.
Okay, sir. Thank you, sir.
Sir, my question is very simple, sir. When we are doing the studies for 1 hour impaired glucose tolerance, do we consider the obesity of the patient, the lifestyle of the patient cohort that we are studying? Because quite a lot of factors are already present in those individuals because of their lifestyle, obesity, and their habits. So, if I study a cohort who's already having high BMI and very bad lifestyle and stress, and the other cohort who are actually maintaining a good BMI and they are very active in their day-to-day activities, and I do 1 hour glucose tolerance here and 1 hour glucose, I may get an absolutely two end of the results, two contrasting results. So do we have taken that into consideration when we are giving a presentation where 1 hour IGTT is supposed to be a very good gold standard to diagnose diabetes or pre-diabetes?
Well, there are data coming out from a number of studies that were presented here, looking at the cardiovascular risk profile in people with a high or pre-diabetes by 1 hour value compared with a 2 hour value, and it's clear that the cardiovascular profile is worse in individuals who have a 1 hour pre-diabetes, and it was also shown by Dr. Satman here from a huge Turkish study, population study, where also the 1 hour people with a high 1 hour value had a worse cardiovascular risk profile.
So that was very evident from the presentation sir had given us, microvascular and macrovascular. Sir, can I just go one step forward? If I find a patient who's got retinal changes with 1 hour impaired glucose, then I will say that he's more likely to be treated, should be treated immediately. And person who has got no retinal changes, no microvascular, no kidney changes in there, no proteinuria or albuminuria, and no neuropathy, and otherwise all parameters normal, but impaired glucose tolerance of 1 hour, but 2 hours glucose tolerance is normal. Can I still label him as a pre-diabetic?
I think Professor Gabriel beautifully referred to the 6th of those list of studies they have included for the WPD, and the 6th study was the Mohan study. It only addressed what you are exactly saying. That is from the CURE study. CURE study, you took that. And that study has taken various population, not only the slow eaters, rapid eaters, chew count,
yes,
and all that, and has shown this 1 hour, to make a long story very short, 1 hour plasma glucose is a good indicator of pre-diabetes, diabetes, and diabetes complications. Over to sir.
In addition, as I saw at the beginning of my presentation, so we have a problem with the definition of pre-diabetes. It's not very clear what pre-diabetes is. So, and we prefer to call intermediate hyperglycemia. So, because all of them are at high risk.
So we start treating them.
Could we go to the next question, please?
Sir, excellent presentation by all the three stalwarts in their field. My question to all of you is that now we are also using CGM in our patients. And do you think last year in ADA there was a debate CGM for the diagnosis of pre-diabetes. So do you think 1 hour glucose variability using a CGM can also throw some light on the development of pre-diabetes or diabetes?
I think Amit is one of the technology man, and he is the technology chief in our country. But you know, Amit, I'll give a different answer, not avoiding your question. The greatest things in the world are simplest. Let the diagnosis of diabetes, pre-diabetes be simple. Then CGM, glucose variability, and etc. That's my answer.
There has been some discussion here around whether to use the ability to predict cardiovascular disease to define diabetes. The reason why historically retinopathy was used all the way through all the different groups in WHO that has set the diagnostic criteria is that retinopathy is specific to diabetes. And that is why retinopathy has been used as the marker. And when we looked at it back at the DECODE study, the outcome actually was that the 2-hour value was a better predictor than the fasting plasma glucose. But when we in the expert committee looked at or compared fasting 2-hour value and HbA1c, HbA1c was actually the one that best predicted retinopathy and even microalbuminuria, with the limited data that were available on prediction on microalbuminuria. We have had several changes in the diagnostic criteria over the last 25 years, and each time it's caused a lot of confusion because you identify quite different types of individuals dependent on which diagnostic criteria you use. When ADA introduced the predominant use of fasting plasma glucose, it turned out that it was very useful in a severely obese American population, but not very well in a lot of other populations. So I'm not here to say that 1 hour should not replace the 2-hour value. We never had the data on 1-hour values when we did the previous work in the other committees. But we need to know that it is not only in some ethnic groups, but it really goes through and is robust through all the different populations, because at least that was the message we got with all the other studies we did, looking at different populations. It behaves differently in different populations.
Thank you.
Yeah, that's a good point. We really need a data in the different ethnic groups, different age groups, and so on. So that's typical for epidemiology, that is not what is seen in the one population group. It can be generalized necessarily to the whole world. Somehow the decision in diabetes field has been that men, women, black, white, whatever, all have the same cut points and so on. It may not be so in real life, that these are exactly equally important in different places. So this is certainly something like. Typical example is that obviously the postprandial glucose it may be different based on a different diets. Like here, you have a much more carbohydrates or in China than in the European population. So it may be that the response is somehow different, but it needs studies with a very detailed physiology. The epidemiology is not enough to sort it out. We actually need a mechanistic studies in that. And what comes to the point of using a retinopathy for the diagnosis of diabetes, the criteria, I'm not quite sure that I like this idea that you take one issue, one complication, how specific it is. It's specific, but it's not sensitive. Cardiovascular disease is more sensitive. You identify more people based on when you actually classify people by cardiovascular outcome. Then you identify, like we did in the DECODE study, we actually can show that the threshold where cardiovascular disease and several other studies starts going up. It's much earlier than the current level of 11.1 diabetes in 2-hour glucose and the fasting glucose as well. The fasting glucose is not behaving that way, but especially 2-hour glucose. So we really need to consider whether this is right because of a sensitivity issue, and sensitivity is the most important for public health point of view. We want to help people, and then specific is not good enough. We can identify high risk people, but we are missing the people, half of the people who actually would benefit from whatever interventions properly.
Okay, thank you very much. Our time is unfortunately up. It's a round of applause for our speakers.
Thank you so much, speakers and chairpersons. That was indeed very enlightening. And I think we'll be starting to ask our patients to get the 1 hour postprandial instead of 2 hours from now. So moving on to the last session of the day, which is the keynote lectures. And to chair this session, I would like to invite none other than the president of IDF, Dr. Peter Schoss, sir, from Germany, and our very own tech guru, Dr. Jyotidev Kesadev, sir, from Thiruvananthapuram. Welcome, sir. Over to the chairperson.
Can we have the introductory slides? So very delighted and honored to be there along with our honorable president of IDF, Dr. Peter. So next we are having a lecture it's a keynote lecture from Juan Pablo, the Chief Medical Officer and Head of Diabetes, Bionia Fusion, Redwood, California. And from the title of the lecture itself, probably we have an idea about the answers. And this is on treatment of obesity in people with diabetes. Will bariatric surgery become unnecessary? So possibly you are going to discuss about the bariatric surgery going to be obsolete. So we are all keen to listen to you. And over to one of the elegant speakers, Dr. Juan Pablo.
All right, well, thank you very much for the introduction, and thank you to the organization for this invitation. So I've been very fortunate over the past 30 years or so to be involved in diabetes and metabolism-related research. And over the past 20 years, I've been very involved in GLP-1 receptor agonist based therapies. And we know this was since the days of exenatide twice daily. And over the past 5 or 10 years, there really has been an explosion in these therapies, not only for diabetes, but also for weight management, for metabolic liver disease, which I'll be speaking about tomorrow, which then begs the question, will bariatric surgery become obsolete or unnecessary? And that was what I was asked to address. So here are my disclosures, primarily the research we do at the center in Los Angeles. And I'll start with the problem, which I think we all know is a global issue. In the United States, in the next 5 years, in 2030, it's anticipated that half of the population will be obese, and we define it as a BMI over 30 kilograms per meter squared, and about 25 or a quarter of the population will have severe obesity, or a BMI over 35. These are data I found from India. Many of you may be involved in this study, a very large cross-sectional study across all of India. And here, with the definition of obesity being greater than 25 kilograms per meter squared, the estimate is that about almost 30% of the population is obese. And using waist circumference, which for this population may be more important than the BMI of over 80 or 90 centimeters for women and men, also about 40% of the population. I think it's interesting to note, if you look on the far right, this study looked at both urban and rural populations. You see all red there. That indicates a prevalence of obesity greater than 25%. So certainly in the urban populations in these areas, a higher prevalence of obesity. And we know that obesity is associated with many complications and comorbidities. And the good news, I guess, would be that we know that weight loss actually has a very important impact on our patient outcomes. And it doesn't even take that much weight loss. If you look on your left, 0 to 5%, you can get improvements in hypertension and hyperglycemia. So when I'm seeing my patients, I don't tell them I'd like you to lose 30% of your body weight. We say even 5%, or as Dr. Herman in the DPP has shown, 7% reducing the risk of progression from normal glycemia to type 2 diabetes. But certainly as we get to these higher percentages of weight loss, we get improvement not only in cardiovascular disease, obstructive sleep apnea, but also diabetes remission and improvement in cardiovascular mortality as well. So we get improvements in not only the physical, but the biomechanical as well as psychological issues that are associated with obesity. And this was a very nice review written by Ildi Lingve and published in The Lancet. And it really makes a point that as we're treating particularly diabetes, but any other obesity-related side effect, we need to start early. So we should take a more weight-centric rather than a glucose-centric approach, particularly in the more obese patients with type 2 diabetes, which is many of them clearly, and address the key driver, which is obesity. This shows medications over the year for the management of overweight and obesity. I've seen this presented many times. It's sort of referred to as the graveyard of medications, because in the light gray are all the medications that have been on the market and taken off, and generally because of safety issues. So really not a very good previously benefit to risk profile. In the U.S., there are 6 medications now that are approved for long-term use in overweight and obesity. And I'm going to focus on the GLP-1 receptor agonist-based therapies, primarily semaglutide, 2.4 milligrams once weekly, and then more recently for weight management, tirzepatide, 5, 10, and 15 milligrams. And you can see that these so-called second-generation agents get significantly greater weight reduction. And this has shown studies here in people without diabetes. I'll be showing in people with type 2 diabetes. But you could see with semaglutide across the STEP program, which was a clinical development program, for semaglutide, you're getting 15, 16, 17% weight reduction at 68 weeks on average. And then with tirzepatide, which is the dual GIP and GLP-1 receptor agonist, up to 25% mean reduction in body weight. So clearly very important. So now turning to bariatric surgery, and metabolic surgery, how does this compare? So this is a study that's referenced or spoken about quite often. It's a very large study. It's retrospective, about 120,000 people with BMIs over 35 treated at Kaiser Permanente in California and having either bariatric procedures, a Roux-en-Y, a sleeve gastrectomy or no surgery. And these people actually, when we say no surgery, they also didn't really receive any medical management. And you can see at 1 year with the Roux-en-Y, about a 28% mean reduction in body weight. Sleeve gastrectomy, a little bit less, 23%. You also see the numbers at 5 years there. And at 1 year, greater than 30% weight loss with these procedures in over half of patients with the Roux-en-Y, and about 1/5 or 22% of the patients with sleeve gastrectomy. And importantly, in the bottom bullet, you see weight regain, and I'll come back to this after. So there is weight regain, a little bit less here. It was about 4% with the Roux-en-Y, patients getting back to within 5% of their original weight, but other studies have quoted as much as 25%, and that's generally what we see in a lot of our patients in Los Angeles, and generally less weight loss in people with diabetes. But there are multiple benefits to metabolic and bariatric surgery. Improvement in glycemia, improvement in cardiovascular risk, reduction in microvascular disease in people with type 2 diabetes, improved quality of life, reduction in cancer risk, and even all-cause mortality, improvements in all-cause mortality. So clearly an important intervention that's become much more safe these days than many years past. Certainly you should have the surgery in a center that does a lot of these. Now, based on these results, what does the ADA say? And I won't go through all of this, but says that in people with diabetes, metabolic surgery should be considered in people with a BMI of greater than 30, and importantly, in Asian Americans, and this includes Indian Americans, greater than 27.5. Other recommendations there you can see, but they also say that some patients have insufficient weight loss or weight recurrence, and in these patients, we should consider obesity pharmacotherapy. And again, I'll come back to that. The American Society for Metabolic and Bariatric Surgery, very similar recommendations. So BMI over 35, irrespective of any cardiovascular risk factors, greater than 30 if type 2 diabetes. They speak about making sure that you're taking the patient's ethnicity into consideration. Again, with Asian individuals, greater than 25 being the BMI, and also that we should follow these patients very carefully because there is a tendency for weight regain, and these patients may need revisions of their surgery or may need pharmacotherapy added. And I looked actually at the Indian, the OSSI it is, the Indian Society for Bariatric Surgery and Obesity, very similar recommendations here in India as well. So going back to pharmacotherapy, these are the guidelines from the ADA and EASD for the management of type 2 diabetes. Clearly, and I'm not focusing here on lifestyle, but irrespective of using pharmacotherapy, bariatric surgery, lifestyle, so good and proper nutrition, exercise, critically important. But if we look at glycemia and weight management, really the GLP-1 receptor agonists rise to the top as the most potent agent. So semaglutide, either in high dose, or tirzepatide, being the most potent agents with respect to glucose lowering as well as weight reduction. And if we talk about the GLP-1, or I should say incretin or glucagon agents sort of harnessing this physiology for pharmacotherapy, if we look at GLP-1, reduction in appetite, so these agents act centrally to reduce appetite and reduce energy intake, and at the level of the islet then, the incretin effect, so enhancement of nutrient-stimulated insulin secretion, a reduction in glucagon secretion from the alpha cell, and the so-called selective GLP-1 receptor agonists would be examples here, semaglutide and dulaglutide. Now we've moved on to the unimolecular multi-agonists, so these are single molecules that have activity at two different receptors. In the case of tirzepatide, this is GLP-1 receptor agonism, and the second incretin hormone, GIP, or glucose-dependent insulinotropic polypeptide. And the difference here is that the GIP not only acts centrally to reduce appetite, at the level of the beta cell to enhance insulin secretion, but GIP receptors are highly expressed on adipose tissues, and GLP-1 are not. So it improves the health of the adipocyte, the uptake of triglycerides postprandially, the more normal release of free fatty acids in the post-absorptive state, and is thought to reduce ectopic fat accumulation. So not only in the liver, but now today we talk about fatty everything, fatty heart, fatty kidney, fatty islet. So it reduces ectopic fat, and that's one of the methodologies or one of the ways in which we think that we get better efficacy with the dual agonism. Glucagon, very important. There are no GIP or GLP-1 receptors on hepatocytes, but highly expressed glucagon receptors in the liver. Now, not only do you get reduced appetite, but potentially also increased energy expenditure. So you're sort of acting of both sides of the equation, reducing energy intake and increasing expenditure, and again, highly expressed in the liver, where one of the important actions is to increase fatty acid oxidation. And I'll talk more about these agents tomorrow, because they're very important for metabolic liver disease, because they really do end up defatting the liver. There are several GLP-1 and glucagon receptor agonists, co-agonists in clinical development. Survodutide, probably the most advanced at this point. And very importantly, retatrutide, which is the triagonist of GLP-1, GIP, and the glucagon receptor. And I'll show some of those data. So very quickly, let's talk about selective GLP-1 receptor agonists. I'm going to focus on semaglutide. 94% structural homology to native human GLP-1. It has an 18-carbon fatty diacid moiety, which binds to albumin. This gives it a half-life of 7 days, allowing for once-weekly dosing. The STEP trials were the obesity or weight management trials that supported the registration of semaglutide 2.4 milligrams for the treatment of overweight and obesity. And you can see here about 17 or so mean percent reduction in body weight in people without diabetes. In all of these studies, people with diabetes lose less body weight for a number of reasons, some of which are not totally understood, but this is true of metabolic surgery and also of these weight loss agents. And compared directly to liraglutide 3 milligrams, which is a once-daily GLP-1 receptor agonist, which was the first one that was approved for the management of overweight and obesity, significantly greater weight reduction with semaglutide 2.4 milligrams. Now, there was one study in the STEP program, STEP 2, which studied patients with type 2 diabetes. This was published by Melanie Davies. And you can see about a 10% mean reduction in body weight at week 68, with about 70% of patients achieving greater than or equal to 5% weight loss at that period, and about a quarter of the patients having greater than 15% weight reduction. This was as good as it got when this first came out, so very potent compared to previous weight loss agents. I think this is an important point. This was a study, an interesting study, in that everyone started with semaglutide. So we randomized these patients. Everyone was on semaglutide for the first 20 weeks of the study. You see the weight reduction. And then they were randomized to either switch to placebo or continue semaglutide. And this was done in a blinded fashion. And you can see that when you stop the drug, the weight starts going up. And we see this clinically as well. There are studies now that are ongoing looking at potential maintenance regimens. Can you lower the dose? Can you maybe give it less frequently, for example? But the bottom line is that in general, these patients need to stay on medication for the weight to stay down. And we've all seen, I think every time you pick up the New England Journal, there seems to be a new article on semaglutide, but we've seen a non-alcoholic steatohepatitis in adolescents, in heart failure as well, in improvement in cardiovascular outcomes in the SELECT study in people with obesity and without type 2 diabetes, and people with chronic kidney disease with type 2 diabetes, and then weight maintenance over the long term in the SELECT study as well. So a lot of evidence on semaglutide beyond just the weight loss, but also on weight-related complications. And this is the most recent analysis of the SELECT trial, which actually looked at, these were all patients without diabetes over a 3-year period, the reduction in the risk of developing type 2 diabetes, and there was a 73% relative risk reduction, about a 9% weight loss in these patients, and the number needed to treat was around 18 to 19. I'm going to show a couple of other, while I'm on the selective GLP-1 receptor agonist. This is very impressive compound. So we published this in the Lancet last year, and this is looking at semaglutide in combination with cagrilintide. And cagrilintide is an amylin analog. So amylin is another hormone secreted by the beta cell along with insulin, which also has some very important appetite suppression effects through central binding. And in this phase 2 study, which was, I have to take my glasses off to see, 32 weeks, so not a very long study. And it's interesting, this was not a weight loss study. When we study these drugs for diabetes, weight is generally a secondary endpoint. When we study, and we don't have a lot of dietary counseling or calorie restriction, when you study these drugs for weight management, they see the dietitian all the time. They're on a 500 calorie deficit diet. So really the focus is weight reduction. What did we see with this combination? A 16% weight reduction, and it looked like it was still going down at week 32, compared to 2.4 milligrams of semaglutide, which was 5%. So almost triple the weight reduction with this combination of cagrilintide and semaglutide called CagriSema. And this is in phase 3 of clinical development, both for type 2 diabetes and for overweight and obesity. So this will be sort of the next generation of semaglutide for the management of overweight and obesity and type 2 diabetes. Now, I know in India you don't have injectable semaglutide. I found that out yesterday as I was speaking to the reps there, but you do have oral semaglutide, or Rybelsus. This is a study in people without diabetes. I wanted to show this, looking at very high dose oral semaglutide. So this is once daily, dose up to 50 milligrams daily. Now, the highest approved dose right now in the US, and I think probably in India, is 14 milligrams once daily, but you could see very substantial weight reduction, 17% on average at the end of 68 weeks, with 90% of patients having greater than 5%, and almost 40% greater than or equal to 20% weight reduction. And what Lilly has, though, is an oral small molecule. So semaglutide is a peptide. It has an enhancer. It's a little difficult to take because you have to take it on a fasting. You can't eat for some time after it's administered. These small molecules can be taken with or without food. And this is called orforglipron. And this was a study in type 2 diabetes we published in the Lancet last year. You see from an A1C of about 8%, a 2% mean reduction in A1C over 26 weeks, and you see the weight reduction. These patients were quite obese. They had a body weight of 100 kilograms on average. They lost 10 kilograms at week 26. It looked like it had not yet plateaued, but about a 10% reduction in body weight. So this molecule, there was a companion paper in the New England Journal looking at people with overweight and obesity without diabetes, significantly greater weight reduction. And orforglipron is now in phase 3, both for type 2 diabetes and for overweight and obesity. So let's move on now to tirzepatide, which is the dual GIP and GLP-1 receptor agonist. So again, this is what's referred to as a unimolecular multi-agonist. It's based on the peptide sequence of GIP, and it's been modified then to be able to bind and activate both GLP-1 and GIP receptors. It has a 20 carbon fatty diacid moiety which gives it a half-life of 5 days. So this is a single molecule possessing activity at 2 pharmacologic targets, which is the GLP-1 and the GIP receptor. This is a paper we published a couple of years ago in the New England Journal, the SURPASS-2 paper. This was in people with type 2 diabetes and directly compared tirzepatide to semaglutide. And what we saw was significantly greater A1C reduction with tirzepatide. You can see from a mean A1C of 8.3%, a 2.5% reduction in A1C. So we were able to get to an average A1C of 5.8%, and almost 50% across all of these SURPASS trials, about 50% of patients reach normoglycemia. So significantly greater than semaglutide 1 milligram. And if we look at body weight reduction, about a 12 to 13% body weight reduction at week 40, looked like it was continuing, and again, significantly greater than the 6.2% reduction that you see there with semaglutide. Very nice categorical variables as well, about 86% of patients greater than 5% weight reduction, and about 40% greater than or equal to 15%. So a very potent agent. Was studied in obesity, was approved for obesity about a year ago. Last November, it was approved in the U.S. for the management of overweight and obesity, a suite of studies called the SURMOUNT trials, and also studies looking at obesity-related complications, whether it's metabolic liver disease, HFpEF as well, kidney disease, and obstructive sleep apnea. The one study, all these SURMOUNT 1, 2, 3, and 4 have been completed, they've been published. The one we're really waiting on, which is a great study, is a direct comparison of tirzepatide, 10 or 15 milligrams, which are the highest doses, with semaglutide 2.4 milligrams. And I can tell you, having been part of this study, these studies fill in like one day when you have a clinic near Beverly Hills in Los Angeles. And very simple, because you just say you're going to get either tirzepatide or semaglutide, and you've got to turn people away. So very nice. And this is what was seen in these SURMOUNT studies, about 25% average weight reduction in people without diabetes, and always a bit less in people with diabetes, about 15% or so. This is a study, SURMOUNT-2, which looked at patients with type 2 diabetes treated with tirzepatide. Again, about a 15% weight reduction at week 72, and about 50% of patients having greater than or equal to 15% weight loss. As with semaglutide, you have to stay on the medication. This was a SURMOUNT-4 study. Again, everyone started on tirzepatide, and then at week 36 in this case, you either randomized to placebo or to continue tirzepatide. And what happens when you get placebo? The weight starts going up. I'm only going to mention SURMOUNT-1. I know the talk is about type 2 diabetes, but this was the first of the SURMOUNT studies that was published, and it had very impressive weight reduction, which I can't even see here, 21% at week 72, with about 40% or 35% of patients having greater than 25% weight loss. And the reason I mention this is just last week, Lilly came out with a press release, because this study was a 72-week study in the majority of patients, but you could see in the small print there, 40% of the patients had prediabetes. And in those patients, there was a 3-year follow-up to look specifically about looking at prevention of type 2 diabetes. And what was reported, and we don't have all the data yet, but in this study, there was a 94% relative risk reduction in the progression from prediabetes to type 2 diabetes at 3 years. At 3 years, the mean weight loss was 23%. And generally in these studies, when you start looking at the factors that predict the progression, it's generally weight reduction is the main, is sort of the main factor. And again, these patients need to stay on the medications. I haven't talked too much about side effects, and I should mention it. With all of these drugs, gastrointestinal side effects are the most common. We really have to escalate and dose titrate very slowly oftentimes to avoid it, but many patients do just fine and do not have any issues. One word about GLP-1 and glucagon receptor dual agonists. I'll speak more about these when I talk about metabolic liver disease tomorrow. Survodutide is Boehringer Ingelheim's medication. This is in clinical development now for metabolic liver disease and overweight and obesity. This was published in Lancet Diabetes and Endocrinology this year. and showed with survodutide, which is a once-weekly injection also, close to a 20% reduction in body weight. So very effective with respect to weight management. Not as good with diabetes, just because with glucagon receptor agonism, you get an increase in glucose and hepatic glucose output. So, so generally, with respect to glucose, they're quite neutral. So they're being looked at more for metabolic liver disease or for overweight and obesity. And I'll end with retatrutide. It took me quite a while to learn how to say that, but that is the triagonist, GIP, GLP-1, and glucagon. Kind of same story, linear peptide, 39 amino acids based on the peptide sequence of GIP, and it's been modified to a once-weekly injectable agent. Single molecule activity at 3 pharmacologic targets, GIP, GLP-1, glucagon receptor. This is a paper that we published with our good friend Pablo Julio Rosenstock last year. And this looked at retatrutide. This is phase 2 in people with diabetes. This was not a weight loss study. There was a companion paper I'll talk about tomorrow specifically for overweight and obesity, which had just tremendous weight reduction. But we did very well here as well. So this was 36 weeks, about an 18% mean reduction, and about 40% of patients having greater than 20% weight reduction. In the people who were overweight and obese, it was about 70% of the patients had greater than 20%. And this actually I saw published yesterday, which shows in the US how popular these medications have become. About 1 in 5 adults with diabetes are using GLP-1 receptor agonist-based therapies. One of the big issues, though, is the cost, $34 billion. So this is becoming an issue, not only cost, but also supply in the United States. It's very difficult. I get calls all the time, you know, can you find a pharmacy that's got the 7.5 milligram dose of tirzepatide, and we're chasing this thing around all over the place. But it's become an issue, and in fact, Lilly just launched little single-dose vials in the U.S. when they were using pens, single-injector pens before. So very important. The last slide I have before I come to my conclusion is various studies just showing patients who've had metabolic or bariatric surgery who either do not have the weight loss they need or have weight regain that are then treated with GLP-1 receptor-based, agonist-based therapies. Very effective, as you can see here, with respect to the weight loss and the categorical variables that are achieved. So the combination can be good. So back to the question, final slide here. Will bariatric surgery become obsolete or unnecessary? I say no. And the reason, even Donald Trump says no. Our patients need options. We say no to him too, but our patients need options. Some may not respond to or may not tolerate GLP-1 receptor agonist-based therapies. Some may not be surgical candidates or may not have significant weight loss or may have significant weight regain. And in some patients, we need both medical and surgical therapy. So I think they're both here to stay and can complement each other very nicely for the right patient. So this is the beautiful Disney Concert Hall in downtown Los Angeles. I live right behind it there in LA anyway when I'm there. And with that, I want to thank you very much for your attention.
Thank you very much for this very cool talk about what is the better approach for our patient. And I just hear that William Herman is not here, so we have plenty of time to discuss this topic.
Oh, he's not here.
Isn't
You should have told me that. I could have gone slower. Or not taken out 20 of my slides.
I just got the information a minute ago, so
Yeah,
otherwise
no,
I would
that's
have
okay.
told you we have half an hour more.
Yeah.
Pablo, you have a question. I apologize that the better lining up for the questions.
So I probably have a simple one. Excellent talk, Dr.
Oh, thank you.
Diaz, and really honored to have you here, or have all of you here. As compared to semaglutide, although the profile of the adverse events is similar, orforglipron seems to fare better. Why is that so?
You know, I don't know if fares better or not. I think we need to see a head-to-head. So you're talking about semaglutide, oral semaglutide versus orforglipron?
That's right.
Yeah, I think it's very difficult to compare those two studies, whether it's Pioneer Plus, which is type 2 diabetes, or the study I showed, the OASIS study I showed, versus, but they're different stages. The other ones are phase 3 studies, are a bit longer, versus a study in type 2 diabetes that wasn't an obesity study. It's hard to tell, but orforglipron is very potent. I think we'll need to see in phase 3. I mean, this is early phases, was not as well tolerated, but you know, if you think about it, when we published the first tirzepatide paper, phase 2, at that point we reached the 15 milligram dose in 6 weeks. About 25% of the highest dose patients dropped out due to GI side effects. We did a subsequent study that looked at different dose escalation regimens.
Right.
And then when we went to phase 3, it takes 20 weeks, 5 months to get to the 15 milligram dose. So I think we learn in phase 2, you may see a lot of weight loss, but a lot more in the way of side effects. But phase 3, it's really a much more refined process. So the short answer is, I think we need to wait and see head-to-head, which may or may not come, but
So where I'm coming from,
Yeah.
I've been a co-investigator for trials on oral semaglutide as well as orforglipron.
Right.
And then we have clinical clinical experience also with oral semaglutide
Right.
because it got approved last year in India. So we have almost more than 15 months experience with that.
right.
But definitely, I mean, this is what I just see, and there is no head-to-head comparison, as you said. But
You see
yes,
better efficacy with orforglipron?
or at least better tolerability with that. I'm not
Yeah.
commenting
It-
on
it-
the
it- it could
efficacy,
be-
but
It's a biased agonist, which
Yeah.
means that it works
It's
more
not-
with respect to cyclic AMP
as
as
compared
opposed
to
to beta arrestin, and
That's
that
right.
then increases sort of the time on the receptor. So it probably is more, it may be more potent.
And
but
I spent a
again,
good number of years in drug development, so definitely these small molecules excite me more than anything else.
Yeah.
But yeah, maybe the answer lies in that biased agonism. I think that would be
I
interesting
think,
to see.
yeah, possibly. And I agree with the small molecules, just from a supply chain and refrigeration chain and being able to get it out to multitudes of patients.
Absolutely.
You know,
It's
and
not
very
a
easy
huge
to take with or without food as well. But you always have to be careful with small molecules with just off-target effects as well as a drug developer, as you know well. But it seems to be quite safe, and we'll see how it does in phase 3.
Great.
Thank you.
Thank you for a wonderful update. I have a question about side effects. I've heard that one of the side effects is loss of muscle mass. You don't just lose fat, you lose muscle mass, and on a long-term risk of sarcopenia. Could you say something about that?
No, absolutely. And that's one of the slides I took out. So that is very important. And in fact, you want quality weight loss, and patients will definitely lose muscle, whether it's bariatric surgery, any kind of weight loss, you're going to lose some lean mass. So all of our patients see the dietitian. We encourage resistance training. We encourage adequate intake of protein as well, as long as there's not significant kidney disease. And we're very careful with the weight reduction. I mean, some of these patients come in almost looking emaciated. So it can be too much of a good thing. And, we're literally, you don't even recognize them anymore. And a lot of times there is some muscle loss, which is significant, particularly in elderly patients. And in fact, if you look at the semaglutide label with the 2.4 milligram dose in the SELECT study, there was actually an increase in osteoporotic fracture. So it's actually in the label in the older individuals. Now, that could have something to do with sarcopenia, loss of some of the cushion, if you will, if they fall. Maybe it's bone as well, but also patients can become less stable. So we're very careful with our older patients. And in fact, the companies now are looking, Lilly recently last year or so bought a biotech company that has an agent to build muscle mass. So now we have weight loss drugs and drugs that will increase muscle mass. And I don't know, at the end of the day, I think, resistance training and probably at the end of the day, it's just preventing obesity in the first place, you don't even need these medications, but they are very important, obviously.
Well, thank you very much. It was really a very nice talk. Actually, you were talking about the Ozempic phase, right?
Yeah, exactly. Yes, I didn't want to say it, but you said it. There you go.
I was wondering, first of all, in clinical trials, diet has to be kind of, like you said, 500 calories below what you usually take. But some people take a huge amount of calories. But in real world, usually you hopefully try to induce a very, not a very low, but a low calorie diet as well. So some patients might, thanks to that, maintain their weight loss longer in real life.
Yeah.
So I was wondering if you really managed to get them to a low calorie diet and change their diet for as long as possible, you could maybe give, like, after you finish, let's say 6 months, you start giving them, every time they regain, let's say up to 2 kilos, then you begin again for another 3 or 6 months, then stop. Has that been tried? Is there a trial where they are looking at that?
There are trials. I don't know about that exact regimen, but there are absolutely trials looking at sort of once they reach their nadir, then given either different doses or different dosing regimens. I think this is very anecdotal, but the real world is that we've sometimes run out of the medication or have a very short supply. So in practice, we've been doing it with some patients. Either switching them or just really having to ration the medication. And some of them do very well. I mean, some of them even, in trials, and most of my patients, as you may know, are indigent patients that don't have insurance. So oftentimes they come into these studies, they'll lose all their weight, do great, and then they have no resources to get this medication, which is very expensive. And some of them are able to maintain their weight loss because they've gotten so well trained with their diet and their activity, but the vast majority do not. But I do think we're going to need to have some regimens, like you mentioned, and really study that well.
Okay.
That's a great point.
I would like to jump in with a question before we come to the next question. And I want to be provocative. I'm fascinated by the more than 90% diabetes prevention from the publication from last week. But it was a study more than 170 weeks. So I want to be provocative and say, does it make sense to give an expensive drug lifelong for the prevention of diabetes if we have the just discussed risk that the people lose muscle mass, develop sarcopenia, and may gain weight if we stop the drug again? And the second part of the question, if we want to avoid this, what would be the best approach if the people stop GLP-1 dual or triple agonists not to gain weight again?
Yeah, so the first is a tough question. Certainly if you look at the cost-benefit analyses that have been done in general, particularly in the patients who are very obese, it ends up being sort of a net positive, if you will. Certainly not all patients develop sarcopenia. You have to be careful with elderly patients, but anyone who loses weight is going to lose some of their muscle mass. I think it's a difficult question because they're extremely expensive drugs. In the US, this will cost $1,000 or $1,200 a month. The insurance companies pay for it, but ultimately the taxpayer pays for this as well. But I think, given all of the benefits you end up getting, probably cost effective, but we'll need to see over time. These drugs haven't been around. Zepbound, which is tirzepatide at the high dose for weight management, it's been less than a year. It was November of last year when it launched. But more than likely, or the vast majority of patients will need the drugs for the long term. So, that's just what I was, discussing with Pablo here, is that I think we're going to need to come up with some regimens that can maintain this weight loss, not at such a high dose. Maybe it's less frequent, maybe it's more dietary instruction, but I think it's a problem that we'll need to continue to study over time.
Hi, Nita Faroohi from Cambridge. My question pretty much was asked by both of them, but I have an extension to the dialogue just had. In the studies, typically, are you collecting, or is it on the horizon that people's dietary intakes will be collected and monitored and feedback given as well? Because this links back to the point Pablo was raising about, there's supposed to be a calorie deficit, but is there actually? Now, theoretically, there should be, because it's working through appetite suppression.
Right.
But I just wondered whether there is data and any publications to follow. Because I think that's really crucial.
No, I agree. It is very important. It is not, and certainly in the studies that I've participated in, whether it's a STEP program or SURMOUNT or some of the other obesity, they do have to see a dietitian. There are set materials and sort of a curriculum that they follow, but into the database, there's not that, they're just such large studies, it would be impossible, well, everything's possible, very difficult to capture that level of detail about their diet. But in general, you would say, they calculate what their energy expenditure is, what they sort of need, and then they're given a diet that's generally a 500 calorie deficit diet that we see if they can follow or not, but not details on the exact diet. Now, there are smaller studies that have clearly looked at this, but not in these large-scale phase 3 trials. And generally the patients, as you say, I mean, these are anorexic agents. They tend to, and this again is very anecdotal, but people who crave certain sweets no longer crave them. As you know, I mean, this is being looked at even for smoking cessation, for alcoholism, just for gambling addiction. So there's something going on there where they definitely alter their diet in general. But I'm not aware of these phase 3 trials collecting, certainly at our center, and I would have known. So
Sure. No,
I agree, it's
I understand
important.
the challenge.
Yeah.
The other side of the challenge, as you've already highlighted, is they're extremely expensive, and they're certainly critical for a subgroup of the population.
Right.
But at a population level, in the context of prevention that we've been discussing, in a country like India alone, how does one factor, the expense and the dependence on these types of therapies to maintain that weight loss? And I just wonder, starting with research, I think, challenging though it is, I would like to advocate for collecting some of that dietary information, because I think it could be really helpful in informing other strategies for people who are given a helping hand with this. But then, for example, I live in the UK, the NHS gives it for 2 years and then that's it.
Yeah.
Right? So what is the dietary pattern? And to understand that would be incredibly helpful.
Yeah, no, I
Thank
agree.
you.
Yep, you're welcome.
Go for a second round here.
Yeah, we have time
We have
apparently.
time.
So, yeah.
Unfortunately, Bill Herman didn't make it, so. As you mentioned, any obesity treatment runs into the problem of the body has made a new set point, or whatever you want to call it, and defends its previous weight, which apparently doesn't happen if you just gain a couple kilos and then take it off again, which I have done, you've probably done, many of us have done, and we managed to stay more or less at the same weight. So a question looking forward is, are there any trials or plans for trials to use the drug to help somebody who recently gained 3 or 4 kilos get back to where he was, where presumably the body set point won't be so important, or postpartum women who put on this weight, but hopefully they can get it off and get back to normal without the body defending itself. Any thoughts about that?
I think it would be important to look at. I don't know, and certainly no studies that I've seen that are sponsored by the pharmaceutical companies, whether these will be investigator-initiated studies. I think interesting. Anecdotally, it's done a lot. I mean, again, someone wants to lose some weight for a wedding or whatever, they go on their Ozempic. I don't know if it's, from my perspective, probably not proper use. I mean, I know it's not what you're talking about, but and that's probably why we've run into supply issues with the drug. I think the issue, though, with the set point and all is actually when these patients end up losing a lot of weight and come off the drug, they've lost a lot of muscle mass as well. I mean, they've lost much more fat than muscle. The ratio is still very positive, but as they gain their weight, they gain a ton of fat and they don't gain muscle. So they have this rebound in their obesity, and that could be, I think, problematic. I've also had, again, very anecdotal patients who've come off these drugs and truly have like a physiologic withdrawal, and very difficult to manage. They get hyperphagia. I mean, they say, doctor, I mean, I've never been so hungry in my life. I mean, they were very hungry before, but they come off. It's almost like these receptors need to, and I've treated some of these patients with very low doses, because I've had samples in the clinic, for example, and it sort of calms them down a bit. So I think it's when you stop them, you need to be careful. Perhaps, I've thought there needs to, potentially be, if you're going to stop, just more of a de-escalation, if you will, rather than cold turkey stopping, because they tend to gain more weight. But again, lots of things probably to look at with this.
My co-chair, Jyotitev, has a question.
So, Puru, you have to? Yeah. So
Just
anyway,
one
let
question.
me
Any data in the
thank you once again. So we need to thank you for giving us an opportunity to chair this session, because it's too good a session.
I agree with you. It's,
Yeah.
it's a different high
Yeah,
being
yeah,
in
yeah,
this room. Do we have any particular data on the perimenopausal or menopausal women, using these and the weight loss benefits in them?
Nothing in particular. I can't tell you, though, that there are, and this has been seen with semaglutide and tirzepatide, and it's talked about quite a bit in the, or not quite a bit, but some in the SURMOUNT-1 study paper that came out in the New England Journal. Definitely some gender differences, some sex differences with respect to the weight loss. And women tend to lose more weight than men in general in these studies. But I haven't seen, pre and postmenopausal women. I've just seen sort of data on women in general. It's probably out there if you looked at it, and I would think that it would be more difficult for a postmenopausal woman to lose weight. I mean, we know a lot of the metabolic diseases. If you look at metabolic liver disease, certainly during postmenopause, I mean, women, suddenly their incidence of metabolic liver disease goes up. It is definitely more difficult to lose weight, and there probably is a sex, or within the sex, a difference pre and postmenopausal. But definitely, and in fact, it's one of the things, the SURMOUNT-1 study enrolled a lot of men, which are difficult to get into these weight loss studies. So it allowed to look at these sex differences, and the women definitely do better than the men with respect to
They
their
probably
response.
also lose more muscle mass.
Possibly,
Possibly.
yeah. That's a very good point.
The other point is that I agree with Dr. Neeta's comment that dietary pattern is extremely important, but it's not just the dietary, the caloric intake, but also the composition, because I think over time, as they eat lesser and lesser, it's a challenge to push in the right composition in them, because they're eating so little that most of the Indian patients, at least, they were already on a high carbohydrate diet. They only tend to consume carbohydrate, leaving the protein aside. So that's a big challenge for Indian physicians.
Yeah, and it's a big challenge in the U.S. as well. Most of my population is Mexican American or Mexican, and very high carbohydrate diet as well. So it is a challenge. I need to see the dietitian. It's got to be culturally sensitive, but as high as possible in protein, I think.
And the last thing that I think before the advent of these wonder drugs, we forget that the drugs are actually just to help you sort of adhere to a lifestyle modification plan. And I think everybody tends to forget that or lose that focus. And that's where we are struggling with 2 years or, considering lifelong, because in India it's a self-pay thing, and they do feel patient. It's just been approved for more than a year and a half, but they do feel like, doctor, I'll have to take this forever. I don't think I can get off this because I do tend to eat a lot more when I'm not on the drug.
Yeah, no doubt. I mean, when you really start talking to your patients about this, I mean, some of these patients are hungry all the time. I mean, they never stop thinking about food, and they're very relieved that they can actually sort of be normal with respect to their appetite, but very difficult when you pull them off the drugs as well. So I think a lot still to look at, but very important medications clearly for the right patient.
So the final question now to Judith.
Actually, Peter, I have more than 1 dozen questions, but I will ask you only 1 or 2 questions. She has given you an idea, and the idea is worth billions. She has given you an idea, and the idea is worth billions. The question is, Dr. Fries is in this space for more than, I think, 20-25 years, and these are some predictions I would like to have from you. In the select clinical trial that you have discussed, there is a 20% reduction in the major adverse cardiovascular events with injectable once weekly semaglutide when it is compared against placebo. And this, in my knowledge, is only CVOT in the absence of diabetes with established cardiovascular disease and overweight and obesity. So this probably semaglutide might be used in future only for CVD prevention.
Right, that's
maybe.
the select
So,
study,
yeah,
right.
select study. So my question is, do we have any prediction on the minimal dose? Because I know that this could be related to weight reduction, but apart from weight reduction, in the subgroup analysis also it was independent of different BMI groups, it was independent of different A1C groups. So independent of all these factors, do you think that there is a minimum dose which is required for semaglutide for cardiovascular disease prevention?
Yeah, well, in diabetes, the study looked at the 1 milligram semaglutide dose. In the U.S. anyway, for diabetes, the 2 milligram dose is now approved. You're right, in SELECT it was 2.4 milligrams. But I think the effect on cardiovascular disease, like you say, I mean, is somewhat tied to weight loss, but there are also factors that are independent of body weight. I mean, you get very nice improvements that are in lipids, for example. You get improvements in markers of inflammation. Now, some of those are also related to the weight loss, but the thought is that there is an independent effect for the cardiovascular disease reduction as there is for the reduction in liver fat and possibly fibrosis as well. But I couldn't tell you, I can't predict. I would think that, at least 1 milligram, but don't know. I mean, 1 milligram seemed to work just fine for reducing cardiovascular
Why I
risk.
have asked this question is because of the GI side effects. There are patients who are tolerating smaller doses but not larger doses.
Yeah.
So do you have any new knowledge on how to minimize the GI side effects? This is a very basic question, very practical question.
Yeah.
We have been trying all the possible efforts. We are also doing the clinical trials with retatrutide. So many patients are developing tiredness. So those who are not having diarrhea, vomiting, no GI side effects, but only tiredness.
Yeah.
So how to overcome this?
Well, I mean, some people just aren't going to tolerate. I mean, I have a lot of patients who can't tolerate metformin either, as I'm sure you do as well. So definitely very slow titration. I think in patients who are having GI side effects, not getting too full, not eating too much of a fatty meal, which will slow gastric emptying. Sometimes we have to give them medication for symptoms. Generally, these side effects will go away, and most of them are mild, but there are some patients who just absolutely will not tolerate, this no matter what. But some of those patients I've switched either from dulaglutide to semaglutide or semaglutide to tirzepatide or tirzepatide to dulaglutide, and they tend to do better with one than the other. So I don't think we really know. As for tiredness, who knows? It's a very small percent of patients that have it. It could be, less based on nutrition as well. But again, it could be central effects also. But some of these side effects are sort of one-offs, if you will. But clearly the most important one are GI side effects, would be diarrhea, constipation, nausea, vomiting, dyspepsia. And without a doubt, by slowly escalating the dose, or reducing the dose, or not escalating as quickly, you can get away from most of these side effects. But
Thank you.
Thank you very much. So now we actually exceeded 2 more minutes from the additional time. So We apologize to have more than 30 minutes question and answer, but I think it was a very, very good additional lecture from your side. Update.
No, I appreciate it. Thank you. I love to talk, so, thanks.
Thank you very much. And let's come to the stage for the facilitation. Or, yes, for the photo.